Ultra beats on the track. 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 Ultra beats on the track.
मुझे नहीं पता, वो देख रहा है, यहीं आ रहा हूँ।
और ये क्या बोल रहा है जब खत्म हो गया, बोला कि अंजन से बात नहीं रही 5 बजे उस हॉल में सबको बुलाया, 5 बजे बोला सबको पूछ रहे हैं हॉल में 5 बजे बोला कि यो कुछ में सेटअप करवाना है 5 बजे बोले को मना करके गया था उसने मेरे को बोला था 5 बजे कहता है 5 बजे जाएगा आप इसमें पब्लिक बोलते हैं 5 बजे कोई नहीं पहुंचेगा सब से हां इसमें 5 बजे कोई नहीं पहुंचेगा पूरा मैं पहुंच जाऊंगा आप पहुंचते हैं कोई नहीं पहुंचेगा 6:30 प्रधान मार मैं 7:30 पौने 8 8 बजे तक 8
जी में क्या है सीबी
देख रहा हूँ
सीएचपीडी यार लिखा तो है सामने तो लिखा है वो बैठ सीएचपीडी उधर भाई अब ये ले हार्ड डिस्क ले मेरे हार्ड डिस्क डाल दे
हाँ उसमें लाइन से कॉपी करने में तो बहुत टाइम लग जाएगा भाई
मेरे हार्ड डिस्क डाल हां अब तो आ जा पूरे में
कनेक्ट
सीटा भी दे, रिमोट वाला भी दे, ला रहा हूँ।
क्लाइंट है सर, दूसरा क्लाइंट तो 12 जो है अगर आप छूट जाओ वहाँ के सीधे खाना खाएंगे नहीं, हालांकि नहीं कंट्रोल करिए नहीं कि समथिंग खाना खाएंगे।
मैंने कल बोला था
Beats on the track. Beats on the track. Ultra beats on the track.
A very good morning. A warm welcome to our guests for the third day of the event. Can I please begin with the first session? And for the same, can I please invite Dr. Mayank Gupta, Dr. Sanjay Sharma, Dr. Rajesh Upadhyay, Dr. Deepak Gunjan to please moderate this session. I would also like to request Dr. Vibhu V. Mittal, Dr. Pallavi Garg, Dr. Vaishali Bhardwaj, Dr. Roop Jyoti Datta to please chair this session.
So good morning. We are starting this morning with a lecture on qualities needed for being a good endoscopist. And who else can be a better speaker than Dr. Rajesh Puri, who is the Director of Endoscopy and Gastroenterology in Medanta Hospital. So I invite Dr. Rajesh Puri to deliver his talk.
Good morning, everyone. So I'm going to talk about the qualities needed of a good endoscopist. As my colleague has said that I'm going to deliver a good lecture, but frankly speaking, it was a very tough task. I don't think I have reached up to a status where I can talk because I feel I'm still a trainee. I'm learning day by day. The new technology is coming. So I don't think I'm the right person, but I will try to give some tips how you can become a good endoscopist or what are the qualities of a good endoscopist. So we are what we repeatedly do. That's most important. Excellence, therefore, is not an act. It is not a one-time act. It is an habit which you do in day-to-day practice. If I talk about my journey, I didn't do the DM, joined DNB at Ganga Ram in 2001. There was an apprehension of passing the DNB exam. Always be a thought that, will I be a good clinician? I still remember there was a differentiation between a DM and the DNB in 2001, even in my unit. So that always give a stigma in the mind that we will be able to perform in our life or not. Once completed, all speculations put to the rest, and that was true because only 1 out of 15, I was the only one person who cleared my DNB exam, rest 14 was failed. And I still remember 2 of them were from the government institution, those who are doing the DM exam, and I scored the gold medal. My journey in the Ganga Ram Hospital, important is more on the patient care in comparison to the academics. Ganga Ram was famous for the endoscopic procedure, high volume of ERCP, lot of conferences, very busy life, less time for myself and for studies. So started from Jodhpur to Ganga Ram and finally at Medanta Medicity. One common virtue, practice and practice, less academics. So there's a very good quote saying, practice make the man perfect. I think that holds for every profession. Either you are a surgeon or you are an endoscopist or you are any field where you are doing a technical job. So this is an example when the Brad Hogg took the wicket of Sachin Tendulkar in 2006. And when he went to Sachin Tendulkar, he was very much excited and he wants an autograph on his cricket ball. And Sachin Tendulkar wrote this movement will never happen in your life in the future. And after that, he was never able to bolt Sachin Tendulkar. So what you require is a commitment. Similarly, if you look at the Picasso, he made a painting and the buyer asked, what is the cost of this? And he says 10,000 euros. And the buyer says, you prepared this in 30 seconds. Why so much of cost? Then he said, it took 40 years to reach 30 seconds. So it is not the one day, it is the years of the regular habit which make. Similarly, if you give an example of Major Dhyan Chand, when he was playing in the Olympics and he was not able to goal at the goal post, and he realizes that the goal post is smaller in size, and he said the goal post is small, please measure it, and the people laugh on it. The delusion of grandeur, that he is not able to goal it and he is saying the goal post is small in size, but when actually it was measured, it was 2 feet small. So the message is practice make the man perfect, and we should keep on doing. So first dictum, it takes time to get a skill and the practice. And if you look at this curve, there is an unconscious incompetence. You don't know and you are not able to do it. But there's a conscious incompetence. You know that you cannot do it. I think that's very important. And there's a conscious competence, meaning that you know you are able to do it and you are able to break the procedure into the steps. And I think that is the best mentor who knows the conscious competence. And last is unconscious competence. You don't know, everything comes from the spinal level. But if you keep on stop doing the practice, then you again come back to the unconscious incompetence. So the message is you have to practice, practice, and practice. What is a good endoscopy? First of all, we should know a correct indications is required, appropriate environment and the team, appropriate use of the medications. You should minimize the procedure risk, correct selection of the equipment and the correct selection of patients, comfortable intubation, completeness of the procedure, appropriate tissue sampling, avoid, identify, and treat the adverse event, and it should be done in the reasonable duration, complete documentation of procedure, and complete follow-up. So when you talk about what is good endoscopy, you should have all these features to say yes. And what it takes to be a good endoscopist, I think it is an amalgam of passion, vision, and the skill. If these three things combined in an endoscopist, I will say he will become the successful endoscopist. So before that, you should be a good GI doctor. I always feel endoscopy is not the technical work. You should be a good endoscopist. You should be able to interpret it. You should be able to know what are the indications. Then your skill of endoscopy that make you a better endoscopist, rather than, because even a technician can do the good endoscopy. There are places where the technician guides the doctor how to do it, but they don't know when to do it, how to do it, and how to manage the adverse event. So who can be a good endoscopist? A video game player, because always people, I talk about the hands-eye coordinations. A tennis player or someone who can type with both the hands, I think, and good endoscopist should have a good knowledge of the gastroenterology, special interest in the GI disease. Excellent hand-eye coordination is required, but is not always mandatory. What is required is ability to be persistent in applying this skill, what is important. So if you look at this article, Principle of Training in GI Endoscopy, a hands-on experimental training under the mentorship of expert endoscopist trainer that occur over a prolonged period of the time. So what you require, a good training, good mentor, and for a prolonged period of the time. And how to achieve that skill? You have a cognitive skill and the technical skill. So I always feel you should require a passion towards endoscopy. That decide your aptitude. You require perseverance, you require persistence, that decide about your attitude. You require temperament and the flexibility that decide about your altitude. And your attitude, not your aptitude, will determine about your altitude in your life. So a self-actualization create a good endoscopist. And how to develop the skill, that is important. Because earlier you always keep on watching, but now in 2022, there is a lot of scope for a beginners. You can read, there are various books, where various videos are available. You can watch on the YouTube is full of endoscopic procedure. You can watch and you will get the various technique which the different people are using, and you can perform. So for read, I think various books by Peter Cotton, gastrointestinal endoscopy, or the practical GI endoscopy, Atlas for interventional US, and number of the books are available. You can get it from the Amazon. Watch how your mentor is doing in your unit, attend workshop and conference, attend live workshop, watch use of the social media on the YouTube and the Twitter also. Perform hands-on training on the animal model or on the simulator. It has very clearly shown that if you perform on the simulator, your endoscopic skill goes up. Various simulators are available. So I think practice on the simulator going to help you in the various procedures. I always feel once you have become a GI doctor, decide your subspecialty. It does endoscopy is a very broad field. I think you know that there is a pancreatology, there is a third space, there is an ERCP and endoscopic ultrasound. So an expert can't be a jack of all, but the master of one. You need to take a stand in ever evolving world of technology. Always set a goal. And what is a goal? A dream written down with the dates become a goal. A goal broken down into the step become a plan. And the plan backed by the action make your dream comes true. So this is very important while you talk. Focus your area of interest, and you just see an example. Dronacharya asked, do you see the bird Arjuna? And he says, no. What then is visible in your eyes? I can only see the eyeball. So ignore the distraction around and pursue one great decisive aim with full force and determination that will make you the best endoscopist. So be stubborn about your goal and flexible about your methods. I think 1 minute more. So for that, you can attend the conferences once a year, and you do the international conferences also. I think this is very important about choosing your mentor. And mentor, I always feel the best mentor is conscious competence, meaning that your mentor can break the steps of a procedures which you are able to learn it, is better than the unconscious incompetence. Be a good mentor in your field. Once you feel that you are a good endoscopist, I always feel you should be a good mentor. It is a strong partnership between the both. People learn equally. Even when your junior is learning from you, you learn so many things from him. Nothing help and gain knowledge as effectively as sharing it. And once you gain, then maintain it by doing the repeated procedure. Stay up to date on the trends, never stop learning. I think that is a mantra of a good endoscopist. So how to make a mark in your field? Choose the right field, narrow down your priorities, get knowledge, choose mentor, practice, make a man perfect, sharpen your social skills, demonstrate your skill, and mentor someone. So in the last, ladies and gentlemen, the most difficult thing is the decision to act. The rest is merely a tenacity. Career path, passion, mentor, goal, risk, aptitude, social skill, and attitude. This is a path to the success. Thank you for the patience hearing.
Any comments or questions? Welcome. Thank you, Dr. Puri, for an excellent talk. Shall I go to the second talk? So the next talk is role of EUS guided drainage of radiological inaccessible liver abscess. And for this innovative procedure, I am inviting Dr. Sharat Chandra, my friend, he's from Jhansi, to deliver a talk.
Well, I'd like to thank the organizing committee, especially Dr. Anil Arora, for giving me this opportunity. I'll be talking on endoscopic ultrasound guided drainage of radiologically inaccessible left lobe liver abscess. In background, radiologically guided percutaneous drainage is a standard of care for liver abscess requiring drainage. Radiologically inaccessible abscess are managed with laparoscopic or open surgeries, which carries high rate of morbidity and mortality. EUS allows easy access to radiologically inaccessible left lobe liver abscess and can be a minimally invasive alternative approach in such patients. With EUS, one can access segment 1, which is the caudate lobe, transgastric, transesophageal, and at times even transduodenal. Segment 2 and 3, that is the left lateral segment, can be approached transgastric. Segment 4A, we can approach through the stomach, and segment 4B from the duodenum. If we review the literature on EUS-guided liver abscess drainage, most of the literature is in the form of case reports or short case series. In majority, they have drained the left lobe abscess through the transgastric route. However, recently, authors have drained even the right lobe liver abscess transduodenally using metal stents like fully covered SEMs or lamps. What is important is that in all these studies, the technique of drainage which has been used is the same. That is what we use for pseudocyst drainage. But what is striking is that there is no uniformity in the type of endoprosthesis which have been used for transmural drainage. Authors have used 5 French to 7 French nasocystic drain. They've used 7 French to 10 French double pigtail stents, single or multiple. They've used combination of NCD with stents. And in recent studies, authors have used fully covered SEMs and lamps for transmural drainage. We do encounter such patients in our clinical practice, as there are no guidelines available on EUS-guided liver abscess drainage, especially the type of endoprosthesis which is used for drainage. I thought I'll share my experience with EUS-guided drainage, which I recently presented at the World Congress recently concluded in Japan. We had 14 patients over a period of 4 years where we did the EUS-guided drainage. The abscess were labeled as radiologically inaccessible if they were deep-seated with intervening vessels coming in the path of access to the abscess cavity. These patients underwent either EUS-guided aspiration or transmural drainage. Consent for transmural drainage was taken in all patients. Aspiration was done with a 19G needle when the contents were liquefied. When the contents were thick, we did a transmural drainage. What were the steps of drainage? The first step is the puncture of the abscess cavity, avoiding intervening vessels, preferably wherever there is a rim of intervening liver parenchyma of at least 1 centimeter. A guide wire is then coiled in the abscess cavity. Then we dilate the tract first with a cystotome, followed by a 7 French and then a 10 French Roentgen dilator. We use a modified technique for drainage. What we use, we actively aspirate the content of the abscess cavity with a 10 French Roentgen dilator, with flushing requirement standby if the catheter gets blocked. We also try to maneuver the catheter into different areas in the abscess cavity where the contents are liquefied. By this, we reduce the pressure within the abscess cavity, which minimizes the chance of peritoneal spillage during the procedure and thereafter. A 10 French nasocystic drain is then placed transmurally within the abscess cavity under fluoroscopic and EUS guidance. Initially, we used a combination of 8 French double pigtail stent and NCD. Thereafter, we shifted to 10 French nasocystic drain. NCD is put on intermittent suction until there is a spontaneous drainage aided by gravity. Once the drain output dries up, we internalize the NCD. And in all patients, we remove the NCD at 4 to 6 weeks. This is done to allow the tract to mature. This is a video which is showing a large caudate lobe abscess extending to segment 4, with contents were thick and the abscess had ruptured. So this was an indication for transmural drainage, and we can see the steps of drainage. First, the needle puncture, followed by guide wire coiling. Then we are dilating the tract with a cystotome, then a 7 French Roentgen dilator, thereafter with a 10 French Roentgen dilator. After that, we actively aspirate the content of the abscess cavity, which we can see is getting aspirated. We try to debulk the abscess. We remove all the liquefied content within the abscess cavity. Following which, what we do, we see that the abscess starts collapsing and the cavity gets smaller. Thereafter, we deploy the endoprosthesis, that is a 10 French nasocystic drain within the abscess cavity. We can see the 10 French nasocystic drain is being deployed. This is what we follow. This is another patient in which the abscess looked just like a pseudocyst. And we think that as the contents were liquefied, we thought we will do an aspiration. However, on attempted aspiration, nothing much drained out of it, and we could not debug the abscess sufficiently. So we had to shift to transmural drainage. Thus, in every patient, we have to be ready to do a transmural drainage whenever we contemplate such procedures. Coming to our results, we did 14 patients, 8 patient aspiration and 6 patient transmural drainage. And the approach to caudate lobe was through the stomach. In majority, in one each, we did it from the esophagus, one from the duodenum. Segment 4, we accessed transduodenally and transgastric, equal number of patients. Segment 2 and 3 from the stomach, and segment 2 was accessed through the esophagus. US guided aspiration was done when the contents were liquefied and the indication of drainage was non-response to medical therapy or a subcapsular abscess. Whereas a transmural drainage was done when it was a ruptured abscess or when the contents were predominantly non-liquefied. 12 patients out of 14 were amoebic abscess and 2 patients had pyogenic abscess. Coming to the endoprosthesis, in our first patient, we used an 8 French stent, double pictate stent. After initial improvement, the patient worsened, and then we had to go and place another 8 French nasocystic drain alongside of the previously placed stent. And this patient did well. Thereafter, we placed 10 French nasocystic drain in all our patients. In one of our patients where the contents were very thick, we had to use 2 10 French nasocystic drain for drainage. The only complication which we found was a self-resolving biliary communication following transmural drainage in 4 out of 6 patients. As we always prefer the transgastric route for drainage, but in one of our patients, we did it transesophageally and the outcome was good. Coming to the factors which guide drainage, there are 2 important factors. One is the morphology of the abscess. Second is the indication of drainage. If the morphology of the abscess shows liquefied contents and the indication of drainage is a subcapsular abscess or non-response to medical therapy, even EUS guided aspiration would suffice. Whereas if the contents are thick and there's a large abscess with suspected biliary communication as suggested by the liver function test, or it's a ruptured abscess, we have to do a transmural drainage. Thus, EUS guided liver abscess drainage is not synonymous with transmural drainage. In a significant number of patients, you can get away with aspiration. The time taken for each of the procedure is the same. You have to be very patient when you do aspiration. The time of aspiration and transmural drainage duration is the same, whether aspiration or transmural drainage. Now, 10 French nasocystic drain works well as endoprosthesis for transmural drainage. It's just like the percutaneous drain, which the radiologist place, and which is the procedure of choice for draining these abscesses. The advantage of nasocystic drain over plastic stents are it makes drainage more predictable by allowing active aspiration and or flushing if it gets blocked. It can also diagnose biliary communication. Stents, I would discourage to be used. What happened is, like in our patients, stents work only if the content of the abscess cavity are liquefied and is it under pressure. Once the pressure goes down and if the contents are thick, these stents get blocked. It's highly unpredictable. And as in majority of the cases where we do these procedures, they are sick. We are not sure about there's unpredictability in drainage. These patients might worsen if we use stents. Therefore, stents alone should be discouraged. Yes, we can use a combination of stent with NCD as we did in our first patient, but if we can do everything with the 10 French NCD alone. Why to make the procedure more traumatic using both NCD and stents? If the contents are thick, we can deploy multiple NCDs. As radiologists upgrade the size of their percutaneous drain, we can place multiple NCDs. That is a good option if suppose the content of the abscess cavity are thick. In recent studies, authors have used fully covered SEMs or LAMs for drainage, as it allows initial rapid decompression followed by sustained drainage. They also allow us access into the abscess cavity where we can perform a necrosectomy sort of thing, what we use in WOPN. But these are expensive. They need technical expertise to place them. And there is definite risk of migration, bleeding, perforation. Therefore, if we can do the same with NCD, I would prefer NCD over these expensive modalities. It's also a safer option if there's a peripheral rim of preserved liver parenchyma is thinned out. It's also easy to place in the esophagus transesophagally. What is important is that one has to ensure that all the side holes of the NCD are within the abscess cavity. That is important. In conclusion, EUS guided drainage is a safe, effective, and minimally invasive approach for draining radiologically inaccessible liver abscesses. The drainage technique is simple and can be performed by anyone doing interventional EUS. And 10 French nasocystic drain works well as endoprosthesis, even in difficult situations. Thank you.
Thank you, Dr. Chandra, for your lucid talk and your experiences. One question is allowed, if anybody.
Yes, excellent talk, and I think you showed that you can access anything through the areas. I think you had 2 cases of amoebic liver abscess, and they usually don't need any kind of drainage unless they have ruptured or there's a secondary infection. That's one issue. What was the indication for drainage? The second thing is that if you look, this pus in this pyogenic abscess is very thick, palaceous, and tenacious. Putting a 3 mm nasocystic drain, I don't know what you are going to drain. If you look at surgeons, suppose they operate, they put a McKelt's catheter, which is usually 8 to 13 mm. Although you have been very lucky that everything is okay, but I would like to have your reaction on that.
So actually we had 12 patients of amoebic abscess, and the indication of drainage in them was we had large abscesses and they were thinned out periphery. That was subcapsular abscess in around 8 of them, and 6 had ruptured abscess. So in all ruptured abscesses, we placed due to transluminal drainage. For amoebic abscesses, like we did aspiration, because once you debulk the abscess cavity, it will not rupture. And we use medical therapy, they respond. That is why I say there's a role of EUS guided aspiration. So just like if you cannot aspirate, like radiologists don't, they have a problem in aspirating because of the intervening vessels, we can use a EUS guided approach to aspirate them. But only if it's ruptured, then only we do a transluminal drainage. There were 2 patients with pyogenic abscess. I agree, both of them, there was a problem in drainage. Usually amoebic abscess, in 2 to 3 days, everything is improved. But for those abscesses which were pyogenic, we had to deploy 2 nasocystic drain, and it required constant flushing and lavage of the abscess cavity. So I agree, for pyogenic abscesses, at times it is difficult to drain them, especially if it's an organized abscess. Then even surgeons at times feel difficulty in draining them. But in our, whatever we did, like we found that using a nasocystic drain, using multiple drains works well in our patients.
But if an abscess in the liver ruptures into the biliary tree, whether it's a pyogenic or amoebic, simple procedure would be an endoscopic sphincterotomy. You eliminate the gradient between the duodenum and the biliary tree, and if you feel that is draining some pus, you can put a catheter there and do an irrigation, rather than sort of putting all these things.
So this was, it was not intrabiliary rupture. This was rupture of the abscess into the perihepatic area, or it was a contained rupture of the abscess. It was not a biliary rupture. The biliary communication which we found, that was following transmural drainage, because we actively aspirate. So that was the reason. Once the abscess collapsed, there was some degree of bile which came out for a day or 2.
If abscess ruptures into peritoneal cavity anywhere, any space, I think surgical dictum is, principle is that you have to do the toilet of the peritoneal cavity. This is very important, because if any abscess, wherever it is, maybe in the peritoneal cavity, which may be small, I think is an indication for surgery.
So contained abscess will not cause.
You are saying the ruptured abscess. Then
ruptured abscess which was contained. So actually the abscess, if the peripheral, most of the time abscess, either it can go and cause generalized peritonitis. That is not an indication of doing. Then you should go for surgery. These are abscess which are contained, because if abscess get localized in by a peritoneum in a localized part in the upper, just around the liver, then you can go ahead and do these procedures. If it's a perforation peritonitis, like generalized peritonitis, then you have to go for different surgical option and do surgical clotting.
Thank you, Dr. Chandra.
Thank you.
So now next talk, I would like to invite Dr. Monica Zain. She is consultant at Exxon Balaji, Delhi, and she is also running a DNB program. So she will talk on management of post-EPT bleed that we see in day-to-day life. Dr. Monica, please.
Thank you, Dr. Gunjan. Thank you, Dr. Anil and his team for giving me this opportunity. The topic for me is management of post-EPT bleed. This is as we all know, that therapeutic ERCP is the standard of care for many pancreatico-biliary diseases. And ERCP is an invasive procedure with lot of known complications, and some of them may be very, very serious. Post-EPT bleeding is one of the most fearful complications of this procedure. The prevalence of post-EPT bleed is variable. This variability is because of different criteria which have been used to define the extent of bleed. The overall prevalence has been reported as 10 to 30%, very high. The significant bleed is 1 to 2%. The major bleed is less than 1%. And the fatality with the present modes of management, either it is endoscopic or IR mediated, it's less than 0.1%. It is not a single disease. Basically, this has a spectrum. This can be immediate bleeding, intra-procedural, which can be during sphincterotomy, stone extraction, stenting, or even after at the time of stent removal in the form of oozing or spotting. This can be delayed bleeding, which can be from hours to days. Patient can come after 10 days or 15 days of post-procedure. This can be a insignificant bleed to massive bleed, self-limiting bleed to refractory bleed. What is significant bleed? The bleed which obscures the visual field, making it impossible to proceed with the intended procedure, or any degree of bleeding which continues after therapeutic procedure is complete and the endoscope would otherwise be withdrawn. Grossly, any bleed which obscures the vision and persists at the end of procedure is significant bleed. We must follow certain ERCP safety rule. We should have a meticulous pre-procedure planning, precise execution, and dedicated post-procedure monitoring. There are certain risk factors which have been associated with post-EPT bleed. Definitely, we have more bleeds in patients with coagulopathy, patients who are continuing on anticoagulation within 3 days of sphincterotomy, cholangitis before procedure, bleeding during initial sphincterotomy, lower ERCP cases volume may be associated with cirrhosis, dilated CBD, periampullary diverticulum, pre-cut sphincterotomy, CBD stones. May not be associated with aspirin use, NSAID use, ampullary tumor, longer length of sphincterotomy, or we have extension of prior endoscopic sphincterotomy. Prevention is always better than cure. This applies definitely in cases of post-sphincterotomy bleed. We must use a blended current as opposed to pure cutting current. Fortunately, the cauteries which we are having alternate cut and coag mode. So this problem is taken care by new cauteries. And the papilla should be incised in 10 to 11 o'clock position because this contains only less than 10% of all the papillary arteries. So incidence of post-EPT bleed decreases if we take care of the direction in which the papilla is cut. The patient's factors which are important is the most important factor which has been seen is a platelet count. The odds ratio for bleed, post-EPT bleed was highest with platelet count less than 50%. And the INR should be more than 1.5 times before the procedure is taken up for EPT. What are the modalities available for post-EPT bleed? We have the standard procedures which are there in management of GI bleed, standard methods of hemostasis they apply in post-EPT bleed. Initially, patient can go for mechanical compression, injection therapy, thermal coagulation, and endoclip application. And in refractory cases, fully covered self-expendable metallic stent is coming up as a big rescue before patient is sent up for angiographic embolization or surgery. Most episodes of immediate bleeding, they cease spontaneously, and endotherapy is required only in few of them with significant bleed. The basic principle which comes when we are starting our EPT, then complete the cut. Why? Because when we complete the cut, the automatic contraction of the two cut ends of arteries occur. So many a time bleeding stops. Then comes the role of balloon tamponade. This is a very simple method. We need to pass a retrieval balloon overinflated in the bile duct, and then it's pulled up forcefully and compress the bleeding side between balloon and the endoscope for few minutes. These few minutes may be 3 to 5 minutes. We have to keep patience because this much time may be required to stop the bleeding from the bleeding side. Success of this procedure is almost more than 90%, especially when this is combined with injection sclerotherapy. The site of next modality is the injection therapy. This is a very simple thing. We need a just sclerotherapy needle and diluted epinephrine, which is available in every endoscopy unit. The site of injection should be the apex because most of the bleed occur at the apex and around the cut. The volume is 0.5 to 30 ml, it is written, but I think any volume can be injected because we need to control the bleed. The success rate is almost 96 to 100%. A word about epinephrine. Most of the cases, what we are doing during ERCP, we are putting diluted epinephrine in the washing tray so that we spray the sphincterotomy site with epinephrine, diluted epinephrine, and many of the small capillary ooze, they stop with just spraying the epinephrine. There is a issue that few people, they say, once you have a bleed, you take care of bleed first. And there are people who are saying that you put a stent first. If there is a massive bleed, you put a stent first, then inject. What is the advantage of putting a plastic stent before injection? That you secure your axis of biliary axis. Secondly, the injection therapy sometimes becomes much easier. You have a place which can oppose your needle and the bleeding side. So there are no definite studies which can code this, but definitely placing a stent, if you are in panic, put a stent and then inject. The single agent versus double agent. There are studies in which people have used 50% dextrose with epinephrine. They say probably the longer duration of tamponade may be there, but clinically there was no difference seen in the bleed control. There is no comparative trial which I could find. Then comes the thermal method. We have monopolar modalities and bipolar modalities. Monopolar, what are the accessories which we can use? We can use a tip of polypectomy snare. We can use sphincterotomy wire. We can use needle knife, hot biopsy forceps, or coag grasper. The practical tips for monopolar coagulation, we try to remove the adherent clot because the energy delivery to the bleeding point should be precise, and try to give the energy at the apex because generally that is the site, or if you can see the vessel, then cauterize that. Advantage is this is technically easy, cost effective. The disadvantage is sometimes the delayed hemorrhages are seen with this modality. Deeper injuries can be there, which can lead to perforation, and rarely a sticking of this probe can occur to the tissue. Once you remove the probe, a major bleed can occur. The main important thing in delivering this monopolar coagulation is we must avoid pancreatic orifice. So try to inject on the right side of papillotomy site, unless we have direct bleeder on the left side. And if possible, in doubt, place a pancreatic stent if that is possible. Then comes the bipolar probe. That is either heater probe or gold probe. This is basically coaptive thermocoagulation in which we put pressure as well as heat. Large channel of ERCP scopes allow the passage of this modality in use of post-EPT bleed. We should avoid pancreatic orifice again. The deeper injury is much more in bipolar probe as compared to monopolar probes. Then there are case reports of using argon plasma coagulation for post-EPT bleed. But again, because the energy which is delivered is not pinpoint, try to avoid pancreatic orifice, and if possible, put a pancreatic stent before using this modality. Then comes the endoclip application. This is a technically very difficult to place through ERCP scope. There are two important things which we can take care to overcome this. One is we can use a cap-fitted forward viewing scope that gives a distance between our papilla and the scope, and application may be slightly easier. Secondly, what we can do, we can go at the junction of D2, D3. Open your clip in D2, deep in D2, come back and then apply with the elevator. It becomes slightly easier. Hemostasis rate is almost 90 to 100%, and new clips designs are coming up. We don't have at the moment, which their delivery system is not dependent on elevator of duodenoscope. Mechanical method, one of the most rescue mechanical method is fully covered self-expandable stent placement. This is now, I was talking to Dr. Sanjay, he was saying that this is a very good modality he has also experienced. The success rate of bleed control is almost 100%, but cost is an issue. The optimum size of stent which should be placed and when to remove it, it is still, we don't have much data. Generally, it is removed at 4 to 8 weeks of placement. The problem with this stent is sometimes the stent migrates because this is fully covered. Secondly, the problem of, if we take a longer stent, the problem of cholecystitis can be there by covering the cystic duct. The use of multiple plastic stents have been definitely used in patients with, we have case reports in which it was found to be cost effective, easier to place, easier to remove than fully covered metallic stent. We don't have any comparative trial comparing multiple plastic stents with a fully covered metallic stent for GI bleed control. Rarely we need to go, just 1 minute more. We sometimes need to innovate also. In one of our patients who came with rebleed after sphincterotomy, one of the lip of sphincterotomy side was bleeding massively. Other modalities did not work. What we did, we took a forward wing scope with a band set and we banded the one lip of our sphincterotomy side. So these things can be tried if possible. Then if patient is not still responding, arterial embolization is, we can take a help of IR people. If still not controlled, then surgery is the treatment of choice. We can use combo method. We can combine two methods, injection or CLAP, injection or other hemostatic methods. Hemostatic powder and fibrin glue are other possible rescue therapy with limited experience. Post successful bleed control, the rebleed rates are 5 to 20%. And what are the predictors of bleed? Initial severe bleeding and serum bilirubin more than 10. The treatment of a rebleed is again the same way, the same protocol we can follow. The second important thing in this is when to re-endoscope the patient. Once the patient has a bleeding control, do we re-scope the patient? Every patient, there are no recommendation at the moment. And so this is the management algorithm. Extend the cut, spray epinephrine solution, balloon tamponade, not controlled, endoscopic therapy. If that does not work, then we go for injection therapy, hemoclips and thermocoagulation, depending on the experience and availability. Fully covered metallic stent is the rescue, which is coming up in a big way. Angio and surgery is the final answer. With all these modalities, the rate of mortality is almost to the tune of less than 0.1%. So we can control GI bleed secondary to post-EPT. Thank you.
Thank you, ma'am, for your simplified way of telling us how to control the bleed. We will not allow any questions because of delay in the sessions. You can ask questions to ma'am.
You think you not talked about the medical treatment of it? I mean, say drugs, why you can achieve the hemostasis. We have very good experience using injection of Transtat, what is called tranexamic acid, and it really helps many patients.
So the role of
and second thing, I think majority of the bleed they stop of their own, even if they initially are the brisk. And what you showed that you should cut further. And if we just wait for, I don't know, 3-5 minutes,
that remains the part
may not
only.
need to anything. And third point is also the protection of the pancreatic orifice. That is very, very important. You may stop the bleeding, but you may lose the patient with the pancreatitis.
Definitely, sir. The only way where drugs have been shown to be useful was basically post, you can say, stent placement in patients with portal hypertension or EHO with portal biliopathy. Once the biliopathy part is bleeding, even then we need a compression along with the other hemostatic drugs which have been used in those cases.
I think there are controlled randomized trials in the upper GI bleeding. where they have shown this hemostatic agent, tranexamic acid, is very effective.
There are no trials in post EPT bleed, probably. Thank you.
Sir, we are already late. You can ask Dr. Monica. Sir, we are already late, sir. So next talk is by Dr. Rohit Gupta, Management of Hepatic Hydrothorax. Dr. Rohit Gupta, Professor and Head at M.I.C.E, and he's also running successfully DM programs. Dr. Rohit Gupta, please.
Change कैसे होगा? Slide कैसे change होगा? Good morning to all of you. At the outset, I'd like to thank Professor Arora, Dr. Ashish, and Dr. Praveen for this kind invitation. So in the next 10 minutes, I'll be talking briefly about how to manage a patient of hepatic hydrothorax. Now, we know that hepatic hydrothorax is a condition which happens in patients with chronic liver disease, where there is presence of significant pleural effusion, usually more than 500 ml, in the absence of significant cardiopulmonary disease. So around 5 to 10% of patients of cirrhosis will end up with hepatic hydrothorax. Now, if we have 100 patients of pleural effusion, around 2 to 3 patients will have underlying hepatic hydrothorax. Around 15 to 20% of patients may not have underlying ascites, and their only presentation of cirrhosis will be with isolated pleural effusion. Now, in terms of their prognosis, recent studies, 2018, which showed 1 month, 3 months, 1 year, and 9-year data. 1 month mortality was 20% in these cases, and 3 years mortality was in the tune of 75%. So what causes this accumulation of fluid? So patients with ascites have increased intra-abdominal pressure, and there is a negative intrathoracic pressure. So there is fluid which gets sucked into the pleural cavity through the defects in the diaphragm. And these defects have been demonstrated beautifully in this elegant study, which was published in Annals of Thoracic Surgery in 2016, where the authors described 4 types of defects. So basically, type 1 defects are where there's no obvious defect. Type 2 defects are in the form of these blebs. Type 3 are most common. These are sieve-like defects of fenestrations. And type 4 are gaps. You can see in this image, the fluid is actually exuding from the diaphragmatic surface. So these can occur singly or in combination. Now, we all know that majority of hepatic hydrothoraces are in the right side. The reasons which have been postulated is that the left dome of diaphragm is muscular, it's thicker. So around 80% of effusions will be on the right side, and minority of effusions will be on the left side, or there will be bilateral effusions. So the presentation, majority of these patients will have features of chronic liver disease. In terms of their respiratory symptoms, the most common presentation will be on dyspnea at rest, then cough, nausea, and pleuritic chest pain. Rarely you will find patients presenting as tension, acute tension, hydrothorax, which a cirrhotic patient presenting with severe dyspnea on chest X-ray will find that the whole one hemithorax is completely wiped out. So it's a diagnosis of exclusion. So you need to rule out underlying cardiac and pulmonary disease. So the person may undergo echo for cardiac disease, a CT chest to rule out thoracic or mediastinal disease, and ultrasound abdomen to look for hepatic masses, HVOTO, or presence of ascites. So once you have a patient who is dyspneic, you show on chest X-ray there is a pleural effusion. The patient undergoes either diagnostic or therapeutic thoracocentesis. So we all know that the pleural effusions are diagnosed as transudates or exudates on the basis of light criteria. And that comprises of protein estimation, pleural fluid to serum protein ratio, pleural fluid to serum LDH ratio. And then you can, like calculation of SAG, you can calculate SPAG in these patients, and it will be more than 1.5, more than 1.1, making it a transudative effusion. Like patients of ascites have a spontaneous bacterial peritonitis. There's an entity which is described in pleural effusion, which is called as spontaneous bacterial pleuritis. The diagnostic criteria are if there is a positive blood culture with neutrophils more than 250, or if culture is negative, the neutrophils are to be more than 500 with no evidence of underlying pneumonia or contiguous infection, and the SPAC should be more than 1.1. These patients are managed as a case, managed as a case of SBP with IV antibiotics and albumin. Now, if the etiology is uncertain, you have isolated left-sided effusion, then you can undergo other tests like PCR for Mycobacterium tuberculosis, fluid amylase to rule out pancreatic effusion, malignant cells, and triglycerides to rule out chylothorax. There has been some role of scintigraphy, especially in patients who have atypical presentation or at the presentation the ascites is absent. So in these diagnostic dilemmas, the person can undergo a scintigraphy. What happens is the interperitoneal injection of radiolabeled sulfur colloid or human albumin. It's injected transperitoneally, and then repeated images are taken at frequent intervals, and you can see the movement of tracer from peritoneal cavity into the thoracic cavity. Excuse me. So once you have a patient with hepatic hydrothorax, what are the different treatment options? So the first is reduction of ascitic fluid production. Second, you can prevent fluid migration from peritoneal cavity to pleural cavity. Third, removal of fluid from pleural space. Fourth, obliteration of pleural space. And finally, the ultimate therapy in these patients is to take for liver transplant. So as a case of ascites, the first advice the patient is to be given is to have sodium restriction. So salt restriction should be less than 5 grams per day, or sodium intake of less than 2 grams per day. Then these patients are started on diuretics, and then they gradually titrated. And like we have diuretic resistant ascites, diuretic intractable ascites, same terms have also been described in patients with hepatic hydrothorax. And around 20 to 30% are diuretic resistant. There is limited experience of use of vasoconstrictors. So octreotide and terlipressin has been used, and we know that they have natriuresis and they decrease activation of renin-angiotensin-aldosterone system. So a study which has been done by SGPGI, where they used furosemide infusion with albumin and terlipressin infusion in managing patients with hepatic hydrothorax. So when do you call a patient is having refractory hepatic hydrothorax? If on salt restriction and diuretics, the patient continues to be symptomatic, continues to have effusion, and is requiring thoracocentesis every 2 to 3 weeks, then it's considered as refractory hepatic hydrothorax. Up to 25% of patients become refractory to treatment, and this happens only 10% in cirrhotic patients, cirrhotic ascites. So in this group of patients, the first preferable treatment, if the patient is a candidate, is TRIPS. Now, this was a meta-analysis published by Dr. Patrick Kamath's group in 2015 in World Journal of Hepatology, which was analysis of 6 studies, 198 patients. The response was seen in 73% patients. Complete relief was seen in 56% of patients, and partial relief happened only in 17% patients. Now, majority of these studies were done with bare metal stents. We do not have currently data on covered stents, but probably the results will be better. And the poor predictors following tips were older age, advanced liver disease, and renal failure. So second is, how do you can prevent fluid transfer from peritoneal space to pleural space? Limited data on this. Some people have used continuous positive airway pressure, but the problem is for how long these patients could be put on these positive airway pressures. So they increases the intrathoracic pressure and it decreases the fluid migration. It has been used especially in patients who have undergone pleurodesis, So once the pleural injection has been done with a sclerosant, then by doing a positive airway pressure, you can decrease the fluid movement from a sciatic cavity into the pleural cavity and maybe give time for pleurodesis to work. Another is a surgical intervention with video-assisted thoracoscopic surgery. But the problem is that these patients are really sick. They are child B or C cirrhotics, they have poor liver function, and this becomes a major surgery. So the only indication is that if the MELD score is low and patient is having contraindications for TIPS, then possibly these patients can be taken up for VETs. But post-procedure morbidity and mortality is extremely high in this group of patients. Now, third is removal. I'll just take a couple of minutes. Removal of fluid from pleural space, then repeated thoracocentesis. So suppose you have a patient who is a transplant candidate, he can undergo transplant in the next 3 months. Then this becomes one of the indications you can do patient for repeated thoracocentesis, or if the patient is post-TIPS failure. However, the problem is repeated thoracocentesis leads to a lot of complications in the form of infections and all. Chest tube placement, there is no doubt. We all have seen in our clinical practice patient getting chest tube placed. We are unable to remove. There is a lot of infection, a lot of fluid loss, a lot of immunoglobulin loss and all. Then recently, some role of indwelling pleural catheter placement, mainly used for malignant pleural effusions, but some research is now coming up where people are having experience with placement of these catheters. There is limited role of pleurovenal shunt. Then you can do surgical pleurodesis. The only problem is that it is associated with very high complication rate, and there is mainly case series and case reports. Briefly about liver transplant, it's a definitive therapy. Another important point, these patients are not given any MELD exception points, and the transplant outcomes are similar to patients with or without hepatic hydrothorax. Some results of liver transplant in refractory hydrothorax, mainly by Zoll, Sursti, and the results show that the outcomes are similar to patients without hepatic hydrothorax. So a simplified management algorithm will be a patient with symptomatic hydrothorax. All these patients are put on salt restriction and diuretics. They can undergo therapeutic thoracocentesis. If required frequent, then you label it as refractory. Then your treatment options are either TIPS. If it's not a candidate, then indwelling pleural catheter, or the ultimate treatment will be surgical management in terms of liver transplant. Thank you all for your patient hearing.
Thank you, Dr. Rohit. This is very difficult condition to treat, and Dr. Rohit has given us a very simplified overview how to treat these patients. Any comments from chairpersons?
Hepatic hydrothorax is very difficult to treat, but I think managing it like ascites and TIPS are the answer, and it's very lucidly explained by Dr. Rohit. Thank you.
Thank you.
Thank you. Thank you, Dr. Rohit.
Thank you. Thank you.
We can now move to second session.
So we'll request you for a picture. Can I also request the speakers who in this session to please come? Dr. Rajesh Puri, Dr. Sharad, Dr. Monica, Dr. Rohit, please be a part of the picture. Thank you. For the next session, may I please invite Dr. Arvind Khurana and Dr. Shrikant Mukevar to please moderate this session. I would also like to request Dr. Tarun Kumar, Dr. Ashish Kumar Jha, Dr. Vishal Gar, Dr. Pranil Rai, and Dr. Tanka Prasad to please be the chairpersons for this session.
Good morning, everyone. we're going to have a next topic on endoscopic techniques of weight management. As you all know, obesity, diabetes, and hypertension has become epidemic. 30% of the Indian population is obese, 20% hypertensive, and about 8 to 10% diabetic. And surgery is only done in 1% of the eligible patients. So endoscopic techniques of weight management have been done excellently with a follow-up of 4 to 5 years and having a good result. To talk on this subject, may I invite Dr. Saransh Jain to please come here and deliver his talk. Dr. Saransh Jain has done his DM in gastroenterology from the prestigious AIMS, and he's practicing at Bhopal. Over to you, Saransh.
Thank you, sir, for the kind introduction. And at the outset, I would like to thank Dr. Anil Arora and the organizing team for giving me this opportunity. And after a healthy Punjabi breakfast, let us talk about endoscopic therapies for weight management. So obesity is growing, and it is growing in India. The definition of obesity in India is a BMI more than 28, not more than 30 as in West. Why do we get fat? Because body weight is a composition of energy intake and energy output. And the balance, when tilts in favor of energy intake, leads to obesity. So shouldn't diet and exercise work for all? Do they actually work? This was a good study in New England Journal of Medicine that looked at what happens when you do a diet and exercise program to the hormonal pattern on your body. What actually happens is when you do a reduced calorie diet for a weight loss and you do some weight loss, body's physiology sees it as a deviation from the metabolic set point. It thinks that you're too thin. So it starts obesogenic hormone expression, which increases your appetite. Ultimately, you regain the weight that you have lost. So what works? Bariatric surgery works. It has successful long-term maintenance of weight loss, reduction in comorbidities, and improvement in quality of life. Why it works? Because it resets this metabolic set point. Since it works so well, why do we need anything else? Because of the eligible patients for bariatric surgery, as my chairman rightly pointed out, nobody actually undergoes it. Especially in class 1 and class 2 obese, they don't even think they're fat. So this is because it is an elective procedure. It's not an emergency. It has some complications and reoperation rate. And even rare, those serious adverse events are discouraging and probably responsible for less patients undergoing bariatric surgery. So what is our role as an endoscopic bariatric therapist? We can have a large unmet need that can be addressed to these therapies, especially in class 1 and class 2 obesity. So what are the types of non-surgical bariatric therapies? We have drugs, phentermine, topiramate, lorcaserin, orlistat, liraglutide, naltrexone, and bupropion. We have intragastric balloons, Orbera, Sparts, recently Aileron balloon is there. And then we have stomach restrictive procedures like endoscopic sleeve gastroplasty, pose, and endomina. When we talk about intragastric balloons, they are either fluid filled or air filled. They are space occupying and they delay the gastric emptying. The major limitation is they have to be removed after 6 months to 1 year. They have some side effects, including nausea, vomiting in the early phase. Partial deflation can lead to obstruction. They cannot be given in previous GI surgery or large hiatus hernia. Coming back to the previous slides, we see that the drugs are there, but their efficacy is low. The total body weight loss is 5 to 7%. There is short-term use and there are some side effects with higher doses. Balloons have moderate efficacy, but the problem is you have to remove them after a period of time. That's where the newer modalities come in. And I will be focusing on endoscopic sleeve gastroplasty as this is the modality available in our country. So this is a procedure known as accordion procedure where we reduce the greater curvature of the stomach using U-shaped sutures. Using a special device which has a suturing tip mounted on the device. As opposed to laparoscopic sleeve gastrectomy, where we remove a part of the stomach, here the stomach is sutured to reduce the volume. The difference between laparoscopic sleeve and endoscopic sleeve is a little different because endoscopic sleeve delays the gastric emptying, whereas laparoscopic sleeve works on the principle of faster gastric emptying. The de novo GRD rate in endoscopic sleeve is almost nil, whereas there is de novo GRD risk in laparoscopic sleeve gastrectomy. There are some complications, less than 5%, and the duration of stay in endoscopic sleeve is almost daycare procedure. This is a typical endoscopic sleeve gastroplasty first image that I'm telling you. We start with the incisura. We use a helix to pull the tissue to our side, and this tissue is then sutured with the help of a suturing device. We go to the greater curvature, reaching up to the posterior wall, create a base over the posterior wall, again in the greater curvature, and reach back to the point where we have started to create a U-shaped suture. Then we tighten the sutures over a cinch, which is like an appendix cinch, and create the restriction. So this is the barium swallow before the procedure, and this is the barium swallow after the procedure. This is the endoscopic image before the procedure, and this is the endoscopic image after the procedure, showing reduction in the volume of the stomach. This is a 3D rendition image of CT showing reduction in the body of the stomach with sparing of the fundus. So why it works? Human appetite has two components to it. One is satiation, how much you eat at one point of time. Second is satiety, how much you will eat after you have had a full meal. Once you have it in the morning breakfast, when you will feel hungry for lunch. Satiation is dependent on the volume of the stomach, and satiety is dependent on the time it takes for the stomach to empty the food that it has taken at one point of time. So it reduces both the volume to create early satiation, and the food stays in the stomach. This is a SPECT image showing 6 hours after the food intake, the food stays in the stomach, leading to more satiety. That is why you are able to lose weight with endoscopic sleeve. When we look at evidence ladder for these type of new devices, new procedures, there are case control studies, there are cohort studies, there is a randomized control trial, and there is a systemic review and meta-analysis. I will go through some of the important studies for this study, for this device. And we start with the cohort studies. This was our study from India. We took 53 patients, did primary endoscopic sleeve gastroplasty. There was 18% total body weight loss at 1 year. This center has come out with a 4-year data showing that the weight loss persists over 4 years. This is a study from Saudi Arabia showing 1,000 patients, showing 64% of excess body weight loss, which is around 15 to 20% of the total body weight loss. It not only reduces the weight, it also reduces the metabolic complication of obese patient. As my chairman pointed out before this talk, that we also have a very high proportion of diabetic and hypertensive and obese along with dyslipidemic patients. And this study found out that it reduces HbA1c, reduces systolic blood pressure, reduces waist circumferences, even ALT. NAFLD is a very common disease in our country, and very few drugs are able to reduce ALT in these such patients. And this was confirmed with a study from India, from AIG group, which showed that endoscopic sleeve gastroplasty for non-alcoholic fatty liver disease reduces the ALT levels over 1 year. Coming on to the randomized control trial, this is an important trial which was recently published in Lancet in 2022. This is known as the MERIT study. It was done for class 1 and class 2 obese patients. It was an open label trial. It was a randomized trial, and it was a crossover trial. There were 8 US centers. They took 2 groups. One was given endoscopic sleeve gastroplasty. One was given lifestyle modification. At the end of 1 year, the lifestyle modification patients were allowed to shift over to the endoscopic sleeve groups if they were doing lifestyle modification as and when the protocol required. So 85 patients had ESG and 124 had lifestyle modification. When you look at this trial results, you see that endoscopic sleeve patient, had a good, had a good weight loss, around 15% of the total body weight loss. And when lifestyle modification patient crossed over to the endoscopic sleeve arm, they also had a very good weight loss. So endoscopic sleeve has much better weight loss than lifestyle modification alone. And also it also showed improvement in almost all the comorbidities that they were looking on: diabetes, hyperlipidemia, hypertension, metabolic syndrome, and multiple comorbidities. All improved with endoscopic sleeve and did not improve or even worsen with primary conservative treatment. This was a meta-analysis that was done for all the studies that have been done on endoscopic sleeve gastroplasty in 2019. And this also showed that there is 16 to 17% total body weight loss at 2 years, with only 2% severe adverse effects. Now, beyond endoscopic sleeve gastroplasty, this technique has been there for around now 7-8 years. So now there are techniques to improve its durability or efficacy. So how can we increase the durability? Either we can reinforce the sutures that we are taking at the time of primary procedure, or we can do a new technique known as osculating circles gastroplasty, or we can do resuturing after a year or 2 years to suture the dilated stomach. Or we can delay the gastric emptying. How can we delay it? We can do a new procedure known as gastroplasty with endoscopic myotomy, or we can add a simple drug known as GLP-1 analog, which will also help in delaying the gastric emptying and improving the efficacy of the procedure. This is a technique known as osculating circles gastroplasty. This is a simple technique, modification of basically endoscopic sleeve. We do a submucosal injection on the greater curvature, do a band EMR of the mucosal lift, EMR is done through a normal snare, polypectomy snare. Once the mucosal defects are created, we do a perilesional APC of this mucosal defect. What we are trying to do is basically we are trying to create more injury so that when healing occurs, there is more fibrosis. This fibrosis will lead to a more sturdier structure, which will lead to a longer results. So now we will take U-shaped sutures like this over these defects so that we are able to close the defects. We will start with the incisura. We'll go to the greater curvature. We'll go back to the posterior wall. We'll go back in the greater curvature and back to the incisura. This is after I've taken the first layer, the distal layer. And then we will take the more proximal layers. And this is the post of final endoscopy where all the mucosal defects are opposed to each other and the lumen is significantly reduced. So this is another technique. Here, the concept is rather than reinforcing the sutures, we can delay the gastric emptying. For that, what they're trying to do is they're trying to cut the muscle in the antrum of the stomach. So they do a modified G-poem with a horizontal incision, some mucosal tunneling, and they stop short of pylorus because they don't want to cut the pylorus. They want to just cut the muscle of the antrum so that it does not push the foot forward. They do a full thickness myotomy of the muscle, close the defect, and do an endoscopic sleeve in the proximal body as described previously. We can also do suturing for revision of bariatric procedures. We see patients with sleeve, Roux-en-Y bypass, and mini gastric bypass gaining weight after some period of time. They are hesitant to undergo revisional surgeries. Revisional surgery are also more complex and difficult to undertake due to the fibrosis of the previous surgery. We can do a sleeve pouch reduction with suturing, outlet reduction with APC, and suturing in bypass. To conclude, endoscopic management of obesity has a role in management of obesity as a primary modality also, as well as an adjunct to surgery. Endoscopic sleeve gastroplasty is a safe and a well-tolerated endoscopic option for weight reduction. Nowadays, with good efficacy for weight loss as well as comorbidity resolution. It addresses a large lacuna in management of obesity, especially in class 1 and class 2 obesity, and a welcome armamentarium in a fight against obesity. Thank you.
Thank you, Saransh. It was a wonderful, precise presentation. Now the topic is open for discussion. May I ask you a few questions?
Yes, sir, please.
How do you compare endoscopic sleeve gastroplasty versus Pose.
Pose, yeah.
That's question number one. Secondly, what are the limitations of endoscopic sleeve gastroplasty? Because I think the cost is the major limitation.
Yeah.
And where it cannot be done.
So I will break the question into the three parts. First question is comparing two restrictive procedures. One is an endoscopic sleeve gastroplasty. Another is POSE, primary obesity surgery endoluminal. So POSE is a procedure in which the device is a little different, but the structure they make eventually is same. So initially what they did in POSE 1 was they tried to restrict the gastric fundus, but did not work well. So now what they are doing in POSE 2 is they are trying to restrict the body itself and make a similar structure to endoscopic sleeve. Only thing is the device is different, and the POSE is like a single suture device. So once you put in a suture, the suture is complete, you move into the next suture. So they are interrupted sutures, whereas endoscopic sleeve is a serial suture device. First thing you go into the incision, you take one bite, then second bite, then third bite, then fourth bite, then fifth bite, then you stop the suture and cinch it. Here it is like one suture, done. Second suture, done. Third suture, done. POSE requires a different set of basically accessories, but the work that they are doing is almost similar. So I would say they are both restrictive procedure. There's also a third procedure which is not yet available, Endomina, which is also doing the same stuff, restricting the body of the stomach. That is the main key in all three of these procedures, and this will be their results will almost be similar in all of them. Only thing is the device cost, the surgeon training cost, and the acceptability among the gastroenterologists. As endolima does not require any special endoscopes, your upper GI scope is good enough for it. Apollo will require either a Fusionon or an Olympus double lumen scope. POSE also does not require any special scope. So it also depends on the clinical structure where we are practicing. Second is limitation of endoscopic sleeve. So limitation of endoscopic sleeve is it is good for class 1 and class 2 obese. It's not good for a 200 kg person. So if you want, if it is a super obese, if it is a super obese, he will lose maximum weight of around 20, 30, 40 kg, 50 kgs. That will not bring him back to the normal. But it is a good bridging procedure. You start with it, and if the person has now 150, it is a very less surgical risk. He can undergo further procedures for weight reduction if needed. The cost of the procedure is high, and that I was discussing is actually very high as compared to the surgical running cost. But now with merit study, it is FDA approved in states. So that would bring up the numbers in the states and probably will reduce the costing of the device.
Thank you, Saransh. Excellent presentation. The basic aim of any endoscopic surgery is twofold. You either delay the emptying of the stomach so that your satiety increases and or satiation is improves, or else you restrict the stomach. Ultimately, everything boils down to hypothalamus. There are two areas, one which increases the appetite, second which increases satiety. It has to be all tweaked through hormones. So there is a new combination of drug recently released by Eli Lilly, which has a combination of GLP-1 and GIP agonist, which gives you 24% weight loss.
Sir,
so how would you compare that? Ultimately, everything is even bariatric surgery is tweaking through hormones. Then why do the surgery?
Sir, the hormones have a lot of redundancy. Once you block one pathway, the other pathway takes over, because these three things are basic instinct. First is to eat, second is to sleep, and third is to reproduce. This is the basic instinct of a survival for any animal, any human. So there are too many redundant pathways to survive. So anybody who has not eaten will have another pathway which will take over from the first pathway. That is why a lot of drugs came in, a lot of drugs came out, but they were never able to really give a long-term weight loss because of the redundancy in the pathways involved with analog mechanism. However, they're a very good adjunct to endoscopic procedure. There is a trial going on in India also and in West also, GLP-1 along with ESG. So that will give a very, very good results as compared to alone any of the drug. Plus the drugs have a side effect profile also, especially when given in higher doses which are required for the weight loss profile. So that also has to be taken into the account, the side effect profile of the drug as well as the side effect profile of the procedure that is being done.
And second issue is most of the patients who come to us, they don't think class 1 obesity is a problem.
Yes.
They have come to you for NFLE.
Yes.
And when you talk of to them about obesity and surgery, they say, you said nonsense, we have come to you for NFLD. So they don't accept upfront surgery from gastroenterologist point of view.
They won't accept
Those who have to
surgery
get
from-
it operated, they go directly to the surgeon.
They
That is
won't
the reason.
accept surgery from anyone. You have to tell them it's a daycare endoscopic procedure, then only they will accept.
Yeah, please.
Saransh.
Go ahead.
So there are two questions. One is, what is the role of nutritionist?
Yes. So
When there is a post ESG, the weight gain is a
Yes.
major problem.
Yes, yes.
And
So-
the second question is that we have a different body composition as compared to Caucasian population.
yes.
So if you will see the merit studies, does it apply to our population?
So very good question. Actually, multidisciplinary approach is the key in post-op management of such patients, and not only operative, procedure management, I would say, because multidisciplinary approach helps in maintaining their exercise and diet protocol. There was a very good study from Spain that said that what is the difference between balloon, pose, and ESG in long term, and they found out the patients who had a good multidisciplinary approach had the most weight loss regardless of the primary procedure they underwent. It was regardless of the primary procedure. Primary procedure did not even come out in the multiple regression analysis. What came out was how many visits they had with the nutritionist post operatively and how sincere were they in managing that diet. So our patient who actually wants to lose weight is the only patient that should undergo such type of procedures. The thing should come from the patient, not from the doctor itself, because ultimately he has to follow that diet and lifestyle protocol. Even in the merit trial, they included only those patients who are willing to undergo diet and lifestyle modification for life. They're written in the protocol. Diet and lifestyle modification who are willing to undergo for the entire life should be included in, because in states you see it's a culture of binge eating. Their size is, if you order a Coke, it's like this big. So that's very important.
So would you advocate in class 1 and class 2 obesity ESG in our population?
Yes, we have our data. We have data, 3 studies. One I did with in Indore. Second is a follow-up of that study. Third, 4 studies actually. 2 studies are from AIG, which show that there is total body weight loss with endoscopic restrictive procedures, endoscopic sleeve gastroplasty in our population. So we have our own data that it is working. It's just that the post-procedure follow-up has to be more strict than others.
Thank you.
In fact, in continuation with the question, Saransh, usually our people, they want to reduce weight initially, but they are not interested in cutting down on their diet. So the whole problem here comes is that after ESG or post whatsoever, they again go back to eating, normally most of them. So in such a case, don't you think that the procedure at times for the sutures they get, lose something in that manner, and the whole restrictive procedure which you have done, in fact, goes in vain sometimes?
Yeah. So when the person actually, there are 2 components to it. One is a psychological thinking that I want to eat, and second is the hunger itself. So when you look at only diet and exercise, when you go to a gym, it is the hunger also that troubles you. You feel like I am hungry and I am not able to satisfy myself. And second is the psychological component also. कि भाई मैंने आज गुलाब जामुन नहीं खाया, 20 दिन हो गए मेरे को खाए हुए. That is also one component to it, but most component comes from that hunger, that I am not satisfied, I have not eaten enough. That component is very well taken care of by endoscopic sleeve.
Yeah, one question from my side. India, we have more of a truncal obesity.
Yes.
So will it affect that also? Because some may come only, they have a big belly, their body is not that
Yes.
obese.
So I was not able to emphasize that, but the waist circumference in the third trial, which I showed, which showed metabolic improvement, also the waist circumference reduced. So yes, it improves.
Thank you.
Matthew.
Question
from the chairperson also.
I think nutrition is very important role, and I have seen patients who underwent sleeve gastroplasty for surgery. They actually come back with weight gain. Another thing is that suppose a patient overweight, not obese, she or he has diabetes type 2, and he approaches you for a bariatric surgery or bariatric sleeve gastroplasty. What will be your approach?
So if the predominant problem is diabetes, we have duodenal therapies available. So they should also be considered. They are not commercially available in our country, but they will soon be. So it's a growing field. So duodenal sleeve and duodenal ablation are the 2 things that are more beneficial in diabetes rather than weight gain. So duodenum is the center for diabetes or metabolic center. Yeah, so they are not available. They will be after some time, but still, if they want right now and they're not willing for a major procedure, balloons have also shown to improve the diabetes and weight loss. So that is also what thing I can offer them.
People.
Yeah, Saransh, enjoyed your talk. While laparoscopy, endoscopy, everything is failing, if you ask me honestly, we are operating a normal stomach, a normal organ we are touching.
Okay.
So we need to find something. Are you in exposure of anything which is going to be a fundamental paradigm shift in this area? Because we are tackling diseases. When you tackle a disease, it gives you results. When you operate a normal organ, this is the issue.
So, so the disease here is the hypothalamus. So if you talk about disease, the disease here is the hypothalamus. The hypothalamus thinks that 120 kg is good for that person. However, that might be an overweight for that person. So how do we talk to this hypothalamus? We cannot remove this. It's a major organ doing a lot of other stuff. We cannot bypass it. The drugs which have come to bypass it get bypassed by the other mechanism themselves. So we have to trick it. So how do we trick it? It listens to stomach. If you go to a party, you have had a full meal and your friend comes in and says, "Ye gulab jamun aur ho jaye," so okay. But if he says 10 gulab jamun aur ho jaye, you will say, "I know I love gulab jamun. Thodi der ruk ja bhaiya, 1 ghante baad sare kha lunga tere saath." So this is what is satiety. This is what the stomach tells the hypothalamus. Okay, I don't want more. So we are trying to trick the hypothalamus into thinking, yes, you have had enough. Please stop, so that we can lose weight. And this is the trick that has been going on with the bariatric surgery as well as with the endoscopic restrictive procedures. I'm not talking about the malabsorptive procedures that they are adding on to this restrictive for severely obese patient. So yes, we are incomplete, but we are progressing.
But do we have anything in that line for malabsorptive procedure?
Malabsorptive, yes, we have.
Yeah.
So we can join these two procedures. We can do a duodenal sleeve and we can do an endoscopic sleeve also. So duodenal sleeve will bypass the food tolerance, food joining the duodenal mucosa. So it will improve the diabetic component of it, and the endoscopic sleeve will improve the weight component of the person.
Thank you.
Thank you.
Last.
One question.
Yeah, Dr. Sanj, one
Yes,
question only.
yes,
What
please.
is more important as a parameter for you, excess body weight loss or total body weight loss?
So
because
I like
excess body weight loss
I like total
gives
body
you a
weight.
more rosier picture.
No. I
compared
like
to
total body weight loss.
Total-
This is what we have to explain to the patient.
Yeah.
You are 100, you will be 80.
With
That
the
is
lean
the thing
NASH
that
and
works.
other things.
It's
total
not
body weight
65.
loss would be a more.
We have total body weight loss of 18 to 20% at 2 years. This
Just
is the
that these
final
recent
say.
papers are talking about excess body weight loss of 50 to 60%. It's a more rosier picture.
That should not be taken into account. It's a total body weight loss. Also, sir, we also have a pill that can coat the duodenum so that your diabetics improves. Thank you.
Saransh, last question.
Sir.
How do you compare duodenal mucosal resurfacing versus all these procedures, DMR?
So duodenal mucosal resurfacing is a duodenal procedure. When we talk about duodenal procedure, we are talking about metabolic implications. It's a very good thing to reduce diabetes. It will reduce diabetes, but it will not cause any weight loss. Duodenum is not a center for weight control. It is a center for metabolic control. So diabetes improvement, DMR is a very good technique. However, after 1 year, the mucosa reappears. You might have to redo it.
Okay. Thank you. Thank you. I think it was wonderful discussion. PK, I'll let to stop. Please. Thank you. Thank you all the chairpersons. Please join for the picture.
Thank you so much for the session. Can I please invite Dr. Arvind Khurana and Dr. D.K. Bhargav to please moderate the session? Can I also request Dr. Mayank Agarwal, Dr. Jeevan Thapa, Dr. Gaurav Bachav, and Dr. Himanshu Pandey to please chair this session?
Sir, you start.
Well, we start with the next session. An interesting part is that small bowel being evaluated long last, because I remembered for the first time, we started seeing the jejunum only through colonoscope right in 1978 and 1979 at AIMS. So we were doing small bowel endoscopy through colonoscope, and which is still existing because more thin colonoscopes are coming. So we were usually able to see the jejunum, but now various types of endoscopes are there recently, and I request Dr. Philip to tell more about those.
Thank you, sir, and other chairpersons and moderator for a kind introduction. And I would like to thank the organizers, Dr. Anil Arora and his team for inviting me. As we know that the journey of endoscopy through the small bowel has been considered to be the black box. And it was a difficult area to be evaluated, mainly because of the length of the small intestine, as well as the anatomical changes or the pattern of the small bowel. When we say that, when we talk about endoscopy, it actually refers to an endoscopic examination of small intestine. We know that when we do a upper GI endoscopy or colonoscopy, we do a limited evaluation of the small bowel. From the colonoscopy, you can go up to nearly 25 to 30 centimeter. And if you are lucky enough, you can go beyond even. And upper GI endoscopy, we study the duodenum full, or you can even go beyond ligament or teats as well. But when we say about endoscopy, it actually refers to the extensive or deeper study of the jejunum and or ileum. This could be studied either through the antegrade route or the retrograde route. But we know that most of the time, we actually evaluate the small bowel by a non-invasive imaging like cross-sectional imaging like CT angiography or MR angiography. So coming to endoscopy, we know that we have the operative endoscopy, and people of my age group had witnessed operative endoscopy. We used to go to the theater to do an operative endoscopy. We also had the fortune of doing a lot of laparoscopy assisted pan endoscopy. In fact, we presented a paper in SGI some time back, way back in long time back. Then we had the push endoscopy, I'll come to it later, and then the capsule endoscopy and device assisted endoscopy. Intraoperative endoscopy is a cumbersome procedure. You need to move the endoscope to a theater, and there actually you can do a total endoscopy if you want. And it can be either passed through the mouth or through the anus, or you make enterotomy and do that. Similarly, you do it in laparoscopy assisted pan endoscopy also. You make enterotomy and do a complete evaluation. It also helps to find out transillumination and find out lesions sometimes. Push endoscopy was the preferred modality for many years, almost 30 years. And then it's actually a long endoscope and with a standard diameter, and you can study up to the proximal jejunum only. And for bleeding, small bowel bleeding, suspected bleeding, quick examination of the proximal small bowel can be done with this one. And the advantage is that it's a shorter duration of procedure, as well as sedation is also, only sedation is required. But deeper study is not possible. This is on patient. Recently, we did a push endoscopy on CT scan after COVID came with diarrhea, and it actually showed there is extensive mucosal ulceration in the proximal. It's a post-COVID enteritis. So when you want to study the deeper areas of small bowel, you have either use a small bowel capsule endoscopy or a device-assisted endoscopy. We know that the commonly used capsule is the pill cap. That is the SP3 model is be used, but there are different types of capsule available in different parts of the world. And capsule actually has revolutionized the evaluation of endoscopy in the small bowel. And it has been actually brought out for evaluation of GI bleeding and later in the IBD. But we know that there are enough and more reasons to indicate a capsule endoscopy. And in fact, in many centers, it is a routine practice to do a capsule endoscopy. The visualization of the mucosa is good. The quality of image is quite good. And we can actually find out lesions. This actually kit of Crohn's disease, and it was in fact endoscopy and in fact upper GI colonoscopy where normal CT angiography was also essentially normal, but the patient had significant symptoms and we found tiny ulcers in the small bowel. This is another case where actually a GI bleed and we found a neoplasm in the distal small bowel. This is actually a bleed. This is another case. We can see a neuroendocrine tumor in the ileum. Sorry. So coming to deep study of or a deep intubation of small bowel. This can be assisted either by a balloon assisted endoscopy. Sorry. And this can be either a double balloon, which has been introduced earlier, there was single balloon endoscopy. And in 2014, another modality was also introduced, but it did not pick up much. That is a balloon catheter guided endoscopy, which I'll come to later. And in everything, the biggest problem was the time and become a cumbersome procedure. Hence, a new introduction of rapidity was achieved by using a spiral technique, and the spiral endoscopy came in. But it was a manual procedure initially, but now it is a motorized one, which actually made a lot of difference. So when you look at the historical device-assisted endoscopy, in fact, in 1970 itself, people started making the sonde type endoscopy, which is a device-assisted. It actually a balloon is attached at the tip, and then a rope type of endoscopy. You ask the patient to swallow through a device, a thread which comes out of the rectum, and then you pass the scope. But these are all cumbersome. This is actually a picture of sonde endoscopy. When you look at the current device-assisted endoscopy, sorry. The most commonly evaluated is or widely used is actually double balloon endoscopy, where actually two balloons are there. One is at the tip of the scope, at the distal end of the scope, and another is the over tube. And say over tube procedure, and with the effect of two balloons, you use a push and pull technique, and you pleat the intestine over the over tube and then steady that. So this was found to be quite good, and the depth of intubation was adequate. And you can do antegrade and retrograde. Antegrade, you can go up to good distance, even up to 360. And retrograde is also good passage through the ileocecal valve is possible. And it is found that you can do a total endoscopy is nearly in 44% of patients if you combine antegrade and retrograde. And we know that how to do that. And once you reach a position antegrade, you inject or tattoo there, and then you can pass through the retrograde route, and it can be done on the same day or a different day. And overall diagnostic yield is also quite good. Then came the single balloon endoscopy, basically because of competition between industry, or it is found that this could be actually a time, procedure time can be reduced with this one. This also, the complete endoscopy is not good when compared to the double balloon endoscopy, but the depth of intubation is actually quite good, and you can also do both retrograde and antegrade. Here actually, instead of, there is no distal balloon at the tip of the scope or the distal end, but there is a balloon at the over tube, and you use angulation of the scope to actually pleat the intestine over that. Then came the conventional spiral endoscopy, and this is actually where you use a tube, it's a spiral which you rotate clockwise, and this is a manual one, and this is no longer used now. The balloon guided endoscopy is actually introduced in 2014 in Israel, and this is considered on-demand endoscopy. You just do a endoscopy or you do a colonoscopy, you try to do that, the patient lesion is in the small bowel, you can immediately attach the device and then you can do that. Actually, a balloon comes through the distant and then another balloon on the tip, it is attached. It's actually a double balloon technique, but is there some difference? So when you have a small bowel disease, how do you approach that? What I do is actually get an outline by doing a cross-sectional imaging like a CT angiography or MR angiography, along with a CT angiography if there is evidence of bleeding. If I see something which I can locate, I will go for a device-assisted endoscopy. If I don't see anything, especially in a bleeding disease, then I use a small bowel capsule endoscopy. If you see something on a small bowel capsule endoscopy, you chase the lesion with a device-assisted endoscopy. So what are the developments that happens in endoscopy of recently? One is that we know that everywhere the time is quite important. when you actually do a capsule endoscopy, the biggest challenge in my department is to get the report. Because the doctor has to sit down there at least 30 minutes to nearly more than 1 hour and see all the pictures, and then actually you have to report. So this becomes a problem. In fact, in my unit, I put rotation to my younger colleagues to go and report that. And our technicians are quite good at sometimes they actually come and show us that these are areas where he is suspected. But still, it's a problem. So there is introduction of artificial intelligence as in happens in any other areas of endoscopy. And by certain deep learning process or the convolutional neural network models, the capsule endoscopy is also getting educated by artificial intelligence to reduce the human workload. And probably this could also enhance the quality and characterization of the lesions as well. Second is about the device-assisted endoscopy. Instead of, or to reduce the time, procedure time, to make it less cumbersome and improve the therapeutic procedures, the motorized power endoscopy has come in. It's actually deep endoscopy, complete endoscopy is possible, and it has got shorter procedure time. The third aspect is the most beautiful part of it. That is actually a therapeutic part of it. Now it is just like any other procedure. You can do a power spiral endoscopy, go into the small bowel, remove your polyps, or you do whatever you want there. You can actually do that dilatation of strictures, etc., etc. And also these endoscopes, device endoscopes can be used in altered anatomy for doing ERCP or other procedures. The human eye is imprecise and the human attention span has limits. It's not uncommon that a capsule study is reviewed by the same or a different reader, and a pathology changes that were missed in the first read are noted on a subsequent re-evaluation. I'm sure in your practice you have seen that. You have seen hundreds of images, you have not seen anything, but the actual lesion may be found only in 1 or 2 frames only. So that makes a big problem. That is how the advances of technology came in for small bowel capsule endoscopy. That is, one is that improve the reading experience. Second is to enhance the accuracy and diagnostic capability of capsule studies. Classic convolutional neural network model has been created and it has been evaluated and found that this is quite useful. And this is actually an accuracy of express view mode compared with the standard reading technique, and found that the accuracy is quite good, sensitivity and positive predictive value are all very good. So what's the future for small bowel capsule endoscopy? Another system we have found that we cannot control the movement of a capsule endoscopy. Can we do something on that? And we know that suppose is it possible that we can have a capsule with a pan endoscopy? Put it through the mouth, it comes through the anus, and you capture everything from esophagus, stomach, duodenum, and up to the colon. So people are trying to say whether we can enhance the life of the battery as well as you can actually control the locomotor activity of the capsule. And this can be, some studies are going on with a magnet-assisted adjustment of the capsule. You might have seen the videos on that. But it is found that you can actually reduce the time in the upper GI tract so that you can evaluate the esophagus, look for varices, Barrett's esophagus, stomach studies, etc. Sometimes we see that it gets stuck in the stomach. So whether an external magnet can change this or not. Here again, artificial intelligence has shown that the detection as well as the reading time, everything can be reduced by incorporating artificial intelligence into a video capsule endoscopy. The most important thing is that higher sensitivity of picking up, especially the bleeding, shorter reading time, and improved identification of small bowel mucosal abnormalities and bleeding. So when you look at the different types of device-assisted endoscopy, what all we try to look at? Most important thing is the depth of incision, complete endoscopy, procedure time, clinical outing, and how to educate people. All these are important. And then other modalities like safety, financial consideration, all are quite important. And it has been found that when I look at the different types of endoscopes available, and these are the different types, and we found that power spiral has got certain advantages, which I'll come to it later. And you look at this, the depth of insertion, maximal insertion is quite good, comparable or even more than double balloon. And total endoscopy rate is comparable or even slightly more than that of double balloon. Why I'm taking double balloon? Because studies have shown that double balloon is slightly superior for maximum depth of insertion, and complete endoscopy is double balloon compared to single balloon. And so in total pyral endoscopy is found to be slightly superior or equivalent to that of double balloon endoscopy. So there is, instead of a handmade movement, a motorized endoscopy was devised in 2015. That was the first human clinical study was done. It was mainly introduced to reduce the challenges of small bowel therapeutics. And it also found that it reduces the wear and tear of the endoscopist. When you know that when you do a double balloon, you have a lot of activities and you have got a lot of time to do on that. And there is actually a setup time is there to do that. Power spiral endoscope has got main three components. One is a reusable endoscope, then is a spiral over tube, then a control unit. And these are the three, and this is actually the, sorry. This is the control unit, and this is the spiral over tube, and this is the spiral motor, and this is the foot switch where you can do antegrade and retrograde movements on that. And you require a special mouth guard. It's a bigger mouth guard for that. And the technical success is almost 97%, diagnostic and therapeutic yields of 74 and 68%, and depth of insertion is to the tune of around 450 centimeter. And median insertion time is much less. You require only 25 to 30 minutes. In my unit, almost all the power spiral is finished in 30 minutes. Or rarely it goes beyond 45 minutes, unless we do a retrograde. And but I don't think that we go into the seeker most of the times, because it is not necessary, because you find out lesion, you stop it. And in case if you have studies have shown that around 10 to 15% of people you can go up to the cecum even. There are certain adverse events which I will come to it later. This is just a mechanical cartoon which I just want to show you the power spiral equipment. This is the antegrade movement. We have to do a clockwise movement on that. And on withdraw, you do an anti-clockwise movement and then remove it. This is the control panel we see, and we can see that when the pressure increases there, it actually gives alarm and it stops spontaneously. This is actually a small bowel bleed, and you do a therapeutic work with a clip and then stop it. Another one, there is actually a telangiectasia where we use an organ plasma coagulation. This one actually a fairly big polyp there. We do an endo loop and place it and come back. This is a case of Peutz-Jeghers syndrome. Another one is a polypectomy, again in another patient with Peutz-Jeghers syndrome. So when you look at the summary of, when you evaluate all the studies available on the power spiral, it is found that it is, the results are quite good. And it is found that you can do a therapeutic yield is quite good. And also the side effects or the adverse effects are minimal on that. So what are the indications you use power spiral, or actually whatever indications when you want to evaluate the small bowel, then this is a good technique. But I told you what I practice is you do a cross-sectional imaging, and if you see some abnormality where you think endoscopy is better, I go for a device and endoscopy. If not, nothing is seen, then I use capsule endoscopy. Today, you can do different types of therapy. What you do is in colonoscopy. We have even, people have even removed the capsule which have been stuck there. People do a tattoo placement for surgical endoloop placement, everything is possible. And what are the other indications of device-assisted endoscopy? You can do a device-assisted colonoscopy. Suppose a colonoscopy fail, it is difficult. You can use the same technique to do a device-assisted colonoscopy. And also in patients with altered anatomy, you cannot reach there, or the patient has got a stricture there. You want to put a metallic stent there, so all this can be used. And the other important thing is device-assisted ERCP. Device-assisted ERCP actually depends upon the anatomy of the anastomosis there. You know that the different types of anatomy of different types of surgeries are there. So you need to know what type of anatomy is there. And then you can use any type of device-assisted endoscopy, what is available with you. All are found to be successful. And we have got some experience with the power spiral on this. And this is actually not my picture. I have taken from Dr. Chalpati Rao. And this is actually a ERCP using a power spiral endoscopy. So what are future directions of endoscopy. We know that device-assisted endoscopy is an evolving and a new and improved endoscopes allowing more complex therapeutic endoscopes are available. And power spiral appears to be a promising and exciting advancement in deep endoscopy, and maybe the start of an endoscopic motorized revolution. I'm sure in the future it is possible that you get motorized endoscopes become a common thing. And even we know that now there is capsule with probable motorized actions, So it can actually go into the small colon and then it will go by itself and find out and come back. And another thing is artificial intelligence, make the doctors will be made lazy when the artificial intelligence comes in and tells us this one is available or not. And eventually, artificial intelligence translate the device endoscopy by improving its diagnostic yield and performance. So I would like to conclude by telling that the artificial intelligence in capsule endoscopy could alleviate some of the challenges faced with the present generation capsule endoscopy. I'm sure that in the future, it may be available that a patient can go to a medical store, a surgical store and buy a capsule. The patient says that my stool occult blood is positive, I have got black motion, so I can use a capsule. So capsules will be available for different types of purposes. So in the future, that may be possible. So a small bowel, once considered to be a black box for gastroenterologists, can be studied endoscopically, and that too with more ease and more possibilities. Power spiral has revolutionized the approach to small bowel pathologies, and the therapeutic potential of device-assisted endoscopy is enhanced in small bowel and also in non-small indication. Thank you so much.
Thank you, Dr. Philip. Let us ask first, any questions from the audience? Yes.
These DAEs which we use for ERCPs, do they have, are they side wing and do they have elevators or are they?
No. See, that's why I told you that, showed you the picture, did not have time to discuss on. Suppose it is a below 2. In that case, we always tell that we always use an endoscope. We use a side view endoscope and then try to see that. Because, doing an ERCP always is better with a side view scope, wherever the lesion, wherever it is there. So if there is an intact ambula, I always prefer to do a side view endoscopy. But side view endoscopy. But when it comes to Roux-en-Y loop and all, it's not possible to go with that. And it is dangerous also, you will not see it properly. So always what we do is, in the past I used to do the endoscope, or sometimes, endoscope, the biggest problem is you cannot do any work on that. So pediatric colonoscopy was used at that time. And when this came in, we actually use a forward viewing scope, classical endoscope, and now it is available, short length endoscopes are available for this purpose. In power spiral endoscopy, the length is actually good enough to actually go in, and the channel size is quite good. You have got a channel of more than 3.2, 3.8 is there. So you can actually do metallic stenting, whatever is possible is you can do, and we can even pass. And many of the accessories which we use in ERCP, can be used in the power spiral or the shorter type of endoscopes.
So how do you control the sort of hold the things? Are there any sort of maneuvers or maybe some?
It's a very good question. It is not easy, but once you see an opening there, you pass a gateway, dilate it, and then once your hands are good in putting a stent, gradually you don't require any of these things.
Practical thing, sir. Capsule is quite costly, and still it has got no therapeutic things which you can do with the capsule, sir.
It will come in the future.
No. Whereas at the same time, sir, with this endoscope, you are able to do and perform each and every procedure and try to take away the lesion immediately, for example, a bleed or whatsoever. And the cost also is a bit different. So don't you think, sir, that we should advocate more of endoscopy rather than, except for the time consuming thing? Because within capsule, only thing is that the guy swallows the capsule and then off for 8 hours. Here you have to give around 1.5 hours. So shouldn't we promote more endoscopy other than the capsule in today's days?
It's a very good question, and that's why I answered you. I showed a slide that whenever you suspect a lesion, what I follow, and I think I'm sure all of you will be following that, we do a cross-sectional imaging that will give 2 advantages. One is that you may pick up the lesion straight away. Suppose it's a tumor, you don't have to do anything. You can even give it to the surgeon straight away. And another is that you will also know whether the capsule gets stuck there or there's any stricture or not. So I always try to do that. And another thing is that if you see some lesion, then straight away endoscopy. I don't do anything. But if you don't see anything, the patient has got bleeding, then no, unless you do a capsule endoscopy, you don't know where to how to chase and go and find it out. Suppose you do a capsule endoscopy, the one which I have shown you is actually a retrograde endoscopy with bleeding. And we did a capsule, CT was normal, we did a capsule and we found that the lesion is in the ileum, proximal ileum. So we used a retrograde and so we could easily go and close it. So capsule will help in that sense.
Just to direct your question, now, so what do you suppose if you suspect a case of small bowel disease, will you directly go for enteroscopy or will you still adhere to imaging techniques like enterography through MRI or through CT scan and capsule endoscopy and then go for enteroscopy, or you will immediately go for enteroscopy, except in one case that if you feel some obstruction, then you will not put the capsule, then you will probably go to enteroscopy.
So it depends upon the clinical indication and the disease you suspect. Suppose you are suspecting that you want to know more about the small bowel, I think we should go for example, like case of IBD, and you want to know how far the small bowel is involved and what is the extent of the disease, whether this is stricture and is a critical stricture or not, whether it is an involvement of it's a long stricture. So I think an evaluation using either a CT endography or MR endography is quite useful. So I would prefer that, but it all depends upon your clinical skill as well as your clinical need and the hospital facility. Everything will decide. And the cost is also important because when you do 3 investigations, it becomes an enormous cost. But now for the patient, like bleeding coming, this patient and the neuroendocrine tumor, I tell you that patient has been, the small tumor is actually only 9 millimeter with the bleed, neuroendocrine tumor. This patient has been having recurrent bleed for so many times, and this patient has been visited so many hospitals. And even the first CT which he has taken has not shown that.
I
So
think
this is possible.
as far as capsule and double balloon is concerned, I think they are more complementary to each other.
Yes.
Many of the times the lesions detected on capsule will not be detected on double balloon and vice versa. So I think both are complementary, excluding the cost. I think they have to be used in that perspective.
Yes,
Matthew, excellent talk. In occult or obscure GI bleed from the small bowel, where do you see radiology, interventional radiology or nuclear scan? Do you still use in some patient or it's completely out?
Nuclear scan, I don't use it. I was using it in the past, but no, interventional radiology, yes. I'll tell you, one patient, patient came with lower GI bleed. We thought it may be from the colon somewhere, and we went inside and we found the colonoscopy is negative. Before that, we did a CT scan and it was nothing is seen. And we did a colonoscopy. Actually, colonoscopy there was nothing. We went into the ileum, there was nothing. And we thought the patient will be, we kept the patient in ICU. Next day, he bled again. So we did a CT scan, CT angio immediately. We found there is a bleeding. And the patient was torrentially bleeding and was hypotensive. So nothing, the interventionalist called in and he actually embolized it. It was actually a jejunal diverticular bleed. So it was a super selective angiogram was done and it was embolized. And when the hemodynamically patient is unstable, I think better involved radiolized. And another thing is, one more thing I told you, I want to tell you, I'm sorry. When you see an ectopic varix also, when you see an ectopic varix, then I'll call the interventional radiologists. They can do tips or they can do retrograde passage through the veins and then block it.
Thank you.
Any question from Chairperson?
Yes, I have a question. Is there any limitation to the size of the polyp while you're doing the therapeutic enteroscopy vis-a-vis the earlier known indications?
See, in those cases, actually, what we do is, we just do an endoloop, and if it gets into the endoloop, we actually endoloop and leave it alone. So it will actually spontaneously got automated polypectomy. And we don't have, because, you cut it and again go endoloop and again go and cut sometimes, the only issue is that you may not get a tissue diagnosis on that. And in patients with the Peutz-Jeghers syndrome and all, you are not really interested in this because you will be doing a lot of polypectomy on the small bowel on that.
And what is the extra advantage of that spiral, which is the spiral is giving you some extra advantage over the conventional one? The spiral, the addition of a spiral.
See, motor spiral is actually the one which your hand spiral is actually not very good because the depth of incision was not much. But there was a rapidity on that. Complete endoscopy study is also not very good on that. And it was a cumbersome procedure also, though it was looking very good when it's actually introduced in the market. But when it became motorized, then it actually became very good because motorized it actually moves so fast. The another thing is only the biggest, actually I did not show the contraindications, complications, because I thought I'll have it during discussion. Suppose you are stuck, you cannot withdraw it immediately. That is a big, in double balloon, you deflate the balloon and bring it out. Here actually what you have to do is you have to inflate the intestine. Actually you distend it with the carbon dioxide of air. Yes, I can take that. So I would always think that there should be another modality which should be available. And if you ask me which is the best to find, I think we have all
I think we are getting late. Sorry.
Truly speaking, we have not covered any of this except for mucosal infections. And the biggest selection is good. That is, 40% is not major reasons. The major reasons are actually esophageal tear and mucosal tear. These are the commonest which we see. And when you do a retrograde and tear, sometimes occurs just adjacent to the ileocecal region. So these are the major. Very rarely you can have complications, bleeding, and anesthesia-related problems. All this can occur. What you see in other one also. But I think if you are asked which endoscope is better, Saras, I would at present with the available data, power spiral is probably superior.
Thank you, Dr. Philip. Once more, I'm also thankful to Dr. Anil Arora for inviting me. And well, he's doing a very good job for last so many years. And today I also remember Dr. Sama, that he was the originator. But Dr. Anil Arora, once more, thank you.
I will request you for a picture in the center of the stage. Sir, please. Thank you for the session. For the next session, can I please invite Dr. Sunil Dadich and Dr. Mandir Kumar to please moderate this session. I would also like to request Dr. Surakshit, Dr. Alok Gupta, Dr. Aval Sadikot, Dr. Indra Kumar Jha to please chair this session.
Good morning. So we move on to the another endoscopy topic. Pancreas has been difficult to get visualized by the percutaneous ultrasound method, but with the advent of endoscopic ultrasound, it has been visualized very well. And to tell us about the role of the EUS in pancreatitis, we have a person other than Dr. Vipul Rathore. He is the originator and I'll say he's the pioneer, or the first person to do endoscopic ultrasound in our country. So let's listen from horse's mouth. Dr. Vipul Rathore is a well-known person. I think he needs no introduction. Dr. Vipul, please.
विपुल तो नहीं है ना
मेरा
आपका विपुल नाम
हाँ मेरा नाम Thank you, Dr. Sunil, Dr. Mandir, and our respected chairpersons and moderators. Thank you, Anil, for having me here. Okay, just a moment. Yeah. There's a point. Anil, some problem. Big problem. उस पे लगा दो आगे में आया क्या वहाँ अभी आया आया किधर हाँ या फिर इसको सेट Okay, so we have been struggling about pancreas for almost 200 years. It's a very difficult and very enigmatic organ. The disease itself poses a challenge, and it's even more difficult to treat. And this struggle is ongoing, and we tried a lot of imaging. We are getting somewhere, but I don't know how far we have gone, but we are exploring the future for pancreas. So if you ask me what is the role of endoscopic ultrasound in disease of pancreas, and then you will have all this entire list we can do. But today I'm going to restrict my talk only on 3 areas. Acute, recurrent acute pancreatitis and chronic pancreatitis. Just give you a little gist of it. There is no level 1A evidence as of now. Level 1A evidence does not exist, though I've been doing for 25 years. Because it's difficult, I guess, and it's evolving, the science. But what is my wish list? This is my wish list. I should be able to see on endoscopic ultrasound this picture. And perhaps future technologies will probably make it happen for us with color rendering and all kind of softwares. But essentially, currently what we are trying to do is, with endoscopic ultrasound, we are trying to look at the pancreatic inflammation, the ductal morphology, the parenchymal morphology, stones, strictures, tumors, fluid collections, atrophy, microcalcifications, and so many other things which you can have additional information than a conventional imaging. And therefore, I felt that let's explore EUS in this area of acute, recurrent, and chronic pancreatitis. We'll start with acute pancreatitis. We all know in clinical practice, presuming that it's a pancreatitis, the most common cause is, of course, gallstone pancreatitis, and the transabdominal ultrasound falls short of this diagnostic ability by almost 40–50%. And therefore, I feel we need a better technology which is closer to the organ and proper scanning. So EUS, I feel, has filled that lacunae. More so for small stones. So even a conventional ultrasound, they usually do to 3 to 5, maximum 7.5 megahertz. But when you go on 12 megahertz, sometimes you can pick up very, very small fine stones in the gallbladder. Now, why I'm showing you this particular video is as to why EUS is so important. If you are suspecting biliary microlithiasis, this is where you start your journey. And this is the patient, a small, young 10-year-old boy. And you can see something filling up in the lower bile duct. Can you see here? Very small grain-like thing. And this patient has a choledochal cyst. Actually, I'll run the video a little faster so that you can know. I'll just show you the choledochal cyst. And you can see a sludge layer in the bile duct. And you can see the forking of the pancreatic duct. See how beautiful forking you can see of the pancreatic duct in the head. This detailing of EUS is unfortunately still not very focally evaluated with other conventional imaging. You can actually find incomplete division, complete division in a very detailed fashion. And this is something I feel we are still missing because not many focus diagnostic EUS guys are around. Everybody wants to poke a needle. So we need diagnostic EUS, okay? I think this is something which you need to understand. And this is the bile duct. You can see a choledochal cyst. This is a portal vein. I can actually trace the entire choledochal cyst. This is extension into the right lobe. Can you see that? With a gallbladder microliths inside. So this kind of radial EUS imaging has transformed our understanding as far as pancreatico-biliary tree is concerned. So coming from there, we go and see the pancreatic body now. So entire pancreas you can map. You can see the whole pancreatic duct in real time. Can you see how beautiful you can see the parenchyma in the duct? It's better than a pancreatogram. I'm getting a beautiful pancreatic parenchyma as well as the duct morphology. It takes 5 minutes, believe me, to see the entire pancreas. Uncinate, head, neck, body, and tail with the ducts. This is how it is. And then when we intervene, it allows me to intervene properly. You can see the choledochal cyst here. Classic, do a sphincterotomy. Now I have a question for people who say microlithiasis or cholesterol crystal seen on a microscope. If that can give pancreatitis, see what comes out of this duct can definitely give rise to pancreatitis. And this is something which I felt EUS will fill the lacuna. So Pramod is a very dear friend, a great respect for him. Yesterday he spoke about beautifully on pancreatitis. My practice is pancreatitis suspected biliary. In the first 4 hours, do any EUS. Pick up the bile duct, gallbladder, whatever you need, and then treat the patient. So this is how we treat these patients. I'm going to skip some slides for the paucity of time. So EUS in biliary pancreatitis. Now we know that the bile duct stone passes out of the ampulla. But what if it does not? What if it does not? This is the problem. So this patient had a solitary gallstone in the gallbladder. 6 months ago, patient had pancreatitis. Ultrasound showed no gallstone. You see the entire length of the CBD, like a cholangiogram. So the stone went up to the ampulla, reflux back in the pancreatic duct. Now the stone is sitting in the pancreatic duct. If you do not handle this patient will have a florid necrotizing pancreatitis. And therefore, it's very important that you intervene in time. Always in my practice for last 24 years, ever since we started EUS in 98, always EUS within the first 4 hours if patient has access to us, and then do super selective intervention. So I do not cannulate the bile duct. It will be only pancreatic duct. And this is something which we don't even inject contrast because I have beautiful pancreatogram on EUS. So do a pancreatic sphincterotomy and take out the stone. So I think as the more experience grows in our community and endosonographers, I think we will come to this particular protocol of management. So you can see this classical stone. You may argue this is a chronic pancreatitis, but no, this is a classical cholesterol solitaire. This was one small stone migrated from the gallbladder, okay? So let's go further. Now we spoke about acute fluid collection yesterday. Well, I was forced to drain this 20 centimeter fluid collection in a young boy who had a severe necrotizing pancreatitis. Within 2 weeks, I had to drain it, within 2 weeks. Now we know that we have to wait for 4 to 6 weeks. But there have been cases where we were able to do this. And what we do is very super selective dilatation. We actually don't dilate much the tract and leave a nasocystic catheter and a small stent. And these patients do extremely well. So I think we are learning through our experience that we can probably intervene in some small select group of patients even earlier than 4 weeks, yeah, with EUS. Coming to pancreatic neoplasm, we all know that pancreatic neoplasms can give rise to pancreatitis. And I have this young 35-year-old young lady. She came to me, referred by a surgeon, one moderate attack of pancreatitis, imaging was not very clear. And what we actually found was an 8 millimeter, I'll show you, 8 to 9 millimeter intraductal adenocarcinoma. Here, a small tumor, a very, very small tumor. So when you are talking of anything less than a centimeter, you have to look at endosonography and a good quality endosonography because it's a very operator dependent procedure. So we did EUS FNA for this young lady of 35. She underwent a proper surgery thereafter because they insisted on tissue diagnosis. I would not put a needle in this small lesion, believe me. I was forced to put a needle in this lesion with a 25 gauge. We did a FNA of this small lesion of 8 millimeter and turned out to be adenocarcinoma. And this changed the entire management of this patient. Coming to recurrent acute pancreatitis, I don't want to bore you with the theory part of it and the definition part of it, but we all know that there are some are idiopathic, some are genuinely idiopathic, and majority, after 70%, 75, 80%, you can find the etiology. And if you look at the etiology list here, the ticked mark on red is where endosonography has a role. And I remember some cases, I'll just share with you, that this young girl had recurrent attacks of pancreatitis, and you can see the beautiful bile duct coming. Here's the gallbladder on radial endosonography. Now you must be observing, I'm doing all radial endosonography. These are all radial EUS. And it gives beautiful images. I saw a roundworm in the pancreatic duct. Can you see this stent-like structure in the pancreatic duct? This was missed on CT, MR, all imaging. So if you suspect recurrent pancreatitis, after transabdominal ultrasound, my practice is endoscopic ultrasound. No CT scan, no MRI, no MRCP. Okay? But then you need to do this EUS to pick this with that sensitivity and specificity. So we managed to go inside. You can see the roundworm now lying down in the pancreatic duct. And there's another myth. A roundworm can survive in the pancreatic juice. This is a myth which has been broken. It does not die. It was alive. So you can see we put it out. And this has particularly changed this because this is not chronic pancreatitis. This is recurrent acute pancreatitis in a 20-year-old girl. If you fiddle with the pancreas here, you'll have a massive pancreatitis. So you have to be very, very careful here. Yeah. Let's go to a choledochal cyst again. Now, whenever a child has a problem with pancreatic symptoms and pancreatitis, you have to rule out malunion. And sometimes CT, MR, MRCP may not be able to do that. And you can see a choledochal cyst here with an abnormal connection with the pancreatic duct and a small stone in the pancreatic duct. So the pediatric surgeon asked me, can you do that? Otherwise, the child will never settle down. And therefore, we had to intervene because of EUS findings. We intervened the pancreatic duct, minor papilla, and we managed to clear the stone. And that saved the child from a major complication during a pediatric choledochal cyst excision. Otherwise, it would have landed with a major pancreatic leak and all kinds of problems. Huh? So these are complex interventions for patients. And I feel EUS, if you do it in the right spirit, you will be able to, help these patients. I want to share with you small duct disease. There's a fantastic data now from coming out, very early data from Europe, Northern Europe, especially the Dutch group, where they have started surgical intervention in undilated ducts. So this is what I found in a patient, undilated PD. I found this is a CBD. This is the pancreatic duct, and you can see a small 3 millimeter stone in the minor papilla. A 3 millimeter stone in minor papilla sitting. This patient has recurrent attacks. They didn't know what to do. They said, everybody said nothing can be done. MRCP, CT, thing is negative. I said, okay, fine, we'll find out something for you. And we cannulated the pancreatic duct because it was an incomplete divisum. We always do a major and minor papilla sphincterotomy for all my patients of chronic pancreatitis. Because there is a surgical principle to it, that when you do a surgery for chronic pancreatitis, you do head coring, especially if there's a head disease, where you expose the minor as well as major papilla cannulation through the surgical procedure. Here you can see a stone coming out from the minor papilla on a pre-cut. This stone, if you miss, this patient will have florid, full-fledged chronic pancreatitis. So this is the advantage of recurrent acute pancreatitis EUS intervention. Pancreas divisum, yes, you have to chase the duct, and it is possible to chase the duct with some experience. And I feel that you can definitely rule out a divisum on EUS, that there is no divisum, but incomplete divisum can be sometimes extremely difficult. We have level 2 evidence as of now in all those areas which I discussed with you. I don't want to go into details of it, but we still are struggling with randomized controlled trial. Coming to chronic pancreatitis, we have certain criteria, like the Rosemont criteria, where if you are suspected patient from having pancreatic pain, you have parenchymal criteria for calcification, lobulation, hyperechoic foci, and so forth. Now, looking at this Rosemont criteria, we can have some idea about the parenchymal structure of the pancreas. And you can see here multiple calcific foci in the pancreas. You can see some stones in the duct. And then there are some ductal criteria, which will allow you to combine both this parenchymal and ductal criteria to come to a diagnosis whether this patient has early chronic pancreatitis. Now, this is how beautifully you can see a pancreatogram on a radial endosonography. It's like a pancreatogram without injecting contrast, and that's the beauty of it. So I don't want to go into details of it, but you have to mix match the major and minor criteria, ductal as well as the parenchymal, and then come to a diagnosis. Sometimes we can overdiagnose chronic pancreatitis, especially alcoholic patients or some patients. Even I've seen post-tubercular treatment, ATT. I've seen patients with lymph nodes, seen their pancreas is fine, and sometimes they come for follow-up and they insist that we need to see, and I see fibrosis in the gland. So we have to be careful in India for those patients. Elastography can give some idea about, but it's still work in progress. So I'm going to skip some slides here, and I'm going to share something which makes some sense as to how easy it is to pick up chronic pancreatitis on EUS de novo. And this is how we pick up pancreatic duct, stones, CBD coming down, straightforward intervention, EUS, diagnosis, therapy, and patient is going home next day. Believe me, yes, this is how it is done. So you just do that. I'm going to skip that, but I'm going to show you something which is not very commonly done in a young child. So the youngest baby I've done a radial EUS scope, adult scope, is 7-month-old child. This is 20-month-old baby failing to thrive with recurrent pancreatic symptoms. And we did endosonography. We found there was a small fluid collection impinging on the main pancreatic duct. So it's mandatory in my practice to map the pancreas before doing any pancreatic intervention on EUS. Map the gland properly, duct properly, and then intervene for the best outcomes. So I'm just going to show you. We cannulated, and you can see a fluid collection there in a small 20-month-old baby. And then we did stenting and a pre-cut sphincterotomy on that. I'm sure, how many of you have heard of or you've seen a case of Hemosuccus pancreaticus? Can you raise the hand? Okay, so these are difficult cases to diagnose, first of all. This patient had interventional radiology, no aneurysm was seen. So we did endoscopic ultrasound to find out whether there's any aneurysm. And this patient had multiple soft stones eroding the pancreatic duct. But there was no classical aneurysm on color Doppler study. So we felt that it would be comfortable for us to intervene in these patients. And you can see the papilla is spitting blood. And this was the cause of anemia, which required multiple transfusion in these patients. So my only request is that you have to have a good EUS map if you want to do a case like this. And another important message for those who are in the audience, young patients in India, we deal with soft stones and see how kind of soft stones we can take out. So it's not always that we need ESWL, unlike other data. At least I'm seeing about 70% of my patients will have a soft stones like this in chronic pancreatitis because of our population. And therefore, I feel EUS and endotherapy combined will give you a fantastic outcomes, long-term solutions. Coming to my final slide, or final video, you can see this is a case of an incomplete divisum with some calcification in the head. Now, whenever there is undilated ductal system, you have to be extremely careful. You have to be careful in the sense that you need to know and tell the patient the prognosis that this patient will probably require surgery in the future because of the calcification. And you can see there is a dilated duct, the accessory duct here, you can see here, and the main duct. So this mapping is crucial for long-term outcomes of pancreatic intervention. And you can see the whole pancreas now in detail. Whole pancreatic body up to the tail you can see. And I'm just going to show you quick one intervention, what can change the management of this patient. So we went in and you can see there is a kink here in the main pancreatic duct. Now, if you keep pushing your catheter, you'll fracture the duct. You'll fracture the pancreatic duct. So what we did, we took a small pancreatogram, we rendezvoused the wire from the major to minor, and then I climbed up straight from the minor over the guide wire with a pre-cut. Now, these interventions are important for you to learn if you want to have long-term pancreatic interventional outcomes. I've been doing for 20 years, and this has allowed us to have very, very satisfying results for pancreatic interventions. So we did a pre-cut over this wire, and then we cannulated by the side of the wire and stented the pancreatic duct. Coming to the mapping of the pancreatic parenchyma in the duct, my last video of this talk, why it is important. You can see here, this is a pancreatic parenchyma, looks okay. The duct looks okay to me, a little bit prominence of the duct. And these are all calcification in the head of the pancreas, all calcification. These are extra ductal. There is no ductal dilatation. I'm just coming to the last slide. Look and see. You can see this is the pancreatic duct, undilated duct. You can see calcification on the side of the body of the pancreas. You can trace right up to the tail of the pancreas. There is no dilatation of the duct. Now, if you try and do a procedure, an endoscopic procedure for this patient, they will not have satisfying result because these guys are suffering from segmental pancreatitis because of calcification in that area. And therefore, EUS mapping becomes crucial in chronic pancreatitis. Ladies and gentlemen, my observation that role of EUS in acute pancreatitis for sure for etiology, same for recurrent acute pancreatitis, chronic pancreatitis, it probably give you a proper plan of intervention. And I don't know whether EUS alone can be the primary modality for managing pancreatic disease. We don't have a study on that. I think I leave youngsters to take that challenge and explore that in future. Thank you very much, ladies and gentlemen.
Thank you, Dr. Vipul, for a very nice overview on the topic. One thing can I ask you?
Yeah.
After the discovery of EUS, the role has shifted from diagnostic to therapeutics.
Yeah.
So if you ask about a new endoscopist, he will never go for a radial scope. He will always go for a linear scope.
Yeah.
So what is your view on that? All of your videos are on with the radial scope.
See, all my videos are on radial. And the reason for that, when you're doing a diagnostic endosonography, the scope is doing your job of moving. You just sweep through the duodenum like one gentle movement, like a gastroscope. So we can do a diagnostic upper GI endoscopy with an ERCP scope, essentially. I can do it. I'm sure all of you can do it. But we still use a gastroscope for that. What is the reason? That you get a 360-degree view of the anatomy. And that allows you to have a very quick evaluation. Rather than moving left, right, dancing and around, you miss out some windows. So sweeping through the gut from the duodenal second part, gently through the stomach, through the esophagus, it gives you a CT scan-like imaging. And therefore, I feel those who want to be very good diagnosticians, forget about intervention, it will come follow. It is a very fancy thing. So people have gone for the glamour, but the real challenge in EUS is diagnosis. So you become a good diagnostician, then you can treat effectively. So I think radial still in my practice will have a role unless there is something magical comes. You agree? Yes.
Excellent lecture. I'm
Thank
Dr. Ashish. So you told that you would do US for all patients of acute pancreatitis within.
No, when it's suspected biliary pancreatitis.
Okay, so only when LFT is abnormal or something? Or?
No, if there are gallstones on ultrasound and there is nothing seen in the bile duct, before sending the patient to ICU or ward, we will do an EUS, make sure the bile duct is clear.
So even if LFT is normal?
Yes.
Okay.
Because I have seen bile duct full of stones with normal LFT. I'm sure all of you have seen also.
Right.
Excellent talk, Dr. Vipul, as expected. You see, the reason why people have moved on from radial to linear is, as tertiary referral centers, most of the patients are referred to as for therapeutic purposes and for diagnostic purposes, including FNAP. Since most of us are so used to doing linear EUS, that having two modalities, first a radial and then a linear EUS only adds up to the cost. But I agree, the way we look at the pancreas in toto in one frame will never be possible on linear alone. That I fully agree with you. But surprisingly, in these days, most of us are using radial only to look at the submucosal lesion. Short of that, linear is sufficient for most of us. And the reason mentioned is because you, in addition, and end up doing biopsies and FNACs. My question is that pancreas divisum is a very common problem occurring in 7 to 8% of the population. There are three modalities, ERCP, MRCP, and EUS. And still, in the absence of duct, we are not sure when to implicate pancreas divisum as a cause of recurrent pancreatitis. So what is the gold standard? And how do we say when the duct is not dilated, there is no calcification, when do you go in for minor duct papillotomy?
I think it's a very interesting question. First of all, there is a huge debate and there are two schools of thought worldwide that some say that divisum is not contributing to pancreatitis. There is a school. I feel that we still don't know those who believe that divisum can cause pancreatitis. Undilated duct, if you ask me, is no longer a limitation for us not to intervene. But it requires a tremendous amount of confidence in your handling the duct and the ampulla. I probably use maximum number of 3 French stents in the country, perhaps, because I love that stent. It's a beautiful stent. And for undilated duct, that is the stent we should use. Coming to your question, when will you do a minor papilla sphincterotomy? If patient has recurrent acute pancreatitis, EUS or MRCP has demonstrated pancreas divisum, then what leads to recurrent attacks is not presence of calcification or stone, but sometimes protein plugs which are floating in the pancreatic duct. Now, these protein plugs are so fine that on EUS you can pick up actually. And you can say that these are the protein plugs which are obstructing. What happens is when a patient has developed pancreatitis is the inflammation fibrosis sequence. And that leads to some element of narrowing at the prepapillary area of the pancreatic duct. And the dilatation and the calcification is the long drawn process thereafter. And therefore, I feel that on EUS, if you see some protein plugs floating, some abnormality which I showed you, then you can safely intervene. I always put a first, I never do a pancreatic sphincterotomy in undilated duct. First, I'll put a stent. And over the stent, I'll do a needle knife pre-cut on the stent as a standard of care. Because when you have undilated duct, you do not know how much to bore your sphincterotomy in the duct. And that can lead to damage of the gland because essentially the parenchyma is normal. So this is my response to that.
People, beautiful pictures. I just have a comment that in the last decade, the EUS has come as one of the major therapeutic modalities for draining pancreatic WOPNs, putting stents and, all that. And also the interventions done through the stomach in case of failed ERCP, then when there is, you cannot do. So these are also the important aspects as far as pancreas is concerned. Thank you.
Yeah, I fully agree that for last 20 years, at least my surgeons in Mumbai, my unit have not operated a pancreatic fluid collection, 20 years. Yes.
Sir.
Chairperson. Yes.
Sir,
please
here,
go ahead.
Chairperson.
Yeah.
Very nice lecture, sir. Dr. Rawal here from Rajkot. Actually, I wanted to know two things from you, sir. One is role of EOS in diagnosing malignancy in chronic pancreatitis, early pancreatic malignancy.
Oh.
I mean, what is the rate of picking it up? Because EOS basically is very difficult in chronic calcific pancreatitis. Lots of window is lost because of calcification. I mean, what do you do to pick up the malignancy?
I think it's a very important. I didn't share a video. I had a video on that, but because of the time constraint. Same correlate to that. I was referred a patient of pancreatic endotherapy, 28-year-old young man. Now, whenever you have a pancreatic cancer in a setting of chronic pancreatitis, my observation is that these are the head disease, and these patients come with abnormal LFT. So there are two components. One is inflammatory head mass of the pancreatic because of chronic, recurrent, acute on chronic pancreatitis. Second is there could be a neoplasm. So if you come across a patient with abnormal LFT with chronic pancreatitis, you should suspect a neoplasm. Now, fortunately, we for last 7-8 years have been doing contrast enhanced EUS. So that gives more information compared to CT or MR. But still, I think we fall short about 30-40%. It's 60-70% you can pick up, but we do not have a hard data on that. But it is still a better imaging than a conventional CT or MR. So if you suspect malignancy in a setting of chronic pancreatitis, you need to do a contrast enhanced EUS that will assist you where to target your needle.
Okay, and sir, second question is regarding EUS management of WOPN. Should we go by the percentage of solid component in a WOPN while deciding the role of EUS, or by the absolute size of the solid component? Because say 30% of a 10 centimeter size WOPN versus 30% of a 18 centimeter size WOPN. So the percentage is 30 only, but the size of solid component is, there is a major difference. So does it change the management?
Well, I have a very general, simple rule that if the fluid collection 1/3 is solid component, then you can go ahead with a clear idea and prognosis in mind that this patient may require additional intervention, percutaneous intervention, and other things, or even including surgery, rarely in a very rare case. If it is 50% solid component, I would not even touch that. So if I see a huge cavity with 1/3 solid component, I will definitely try an option of endotherapy. Yes.
Thank you.
Yeah.
See, the whole war is going on as far as diagnosing early CP is concerned, especially the Japanese group, although the world bodies don't agree. So how close EUS gets to this, and what is the future like as far as early CP is concerned?
See, I shared with you those Rosemont criteria, and today most of the centers would probably depend on those criteria. But we have, as I said, in our population, a tendency to overdiagnose chronic pancreatitis because of maybe our gene pool, our gene mutation, our diet, history of alcohol, tobacco chewing and smoking, as well as I say, TB is endemic in India. So I will actually tell some youngsters to pick up this study that post-ATT, how would you compare a pancreas compared to pre-ATT? And you will see some changes. So in India, we have a tendency to overdiagnose chronic pancreatitis. But if you have a telltale patient symptoms of pancreatic pain postprandial with some elevation of enzymes here and there, with more than 3 or 4 criteria which you see ductal, and then you can diagnose. And it is, I think, still the best modality for diagnosis.
Don't you think that most of these patients ultimately land up with chronic pancreatitis?
Yes, they do. They do. Eventually they do. And even recurrent acute pancreatitis. And I showed you a case, a 3 millimeter stone in the minor papilla. If you do not handle it, because MRCP will never pick it, CT will never pick it. So what will you do? You'll leave that patient alone, and that patient will definitely develop into full-blown chronic pancreatitis. So you need to intervene, guys, in small ducts now. And you need a very powerful EUS machine and an operator behind. Thank you.
Your question, please.
Yeah.
Next question.
VK Kapoor from Mahatma Gandhi Hospital, Jaipur.
Yes, Dr.
I am a surgeon, so I'm an odd man in this eminent gathering of gastroenterologists.
Me too.
But difference of opinion with you. 10-year-old child with choledochal treatment of choice should be surgery, not endoscopic intervention, unless it is a choledococele.
No, this patient had pancreatitis and cholangitis. That's why we had to intervene.
Yeah, so that is the temporary intervention.
Temporary, this is temporary.
The treatment of choice for the
Of course,
choledochal
surgery.
cyst will
Of
be
course,
surgery.
surgery. No, this question, we have to intervene on a 10-year-old child only for the immediate symptoms and cholangitis.
Only for cholangitis.
Yes, of course.
I think we close this session.
Excuse
Thank you,
me.
Vipul.
Sir, when will you time your EUS in a patient with acute pancreatitis and also in a patient with recurrent acute pancreatitis? When
I usually give a window of about 2 weeks from the time of amylase becoming normal levels. 2 weeks from the amylase touching the baseline. Ideally, that should be the time. But as you saw in that case of a 3mm stone in the minor papilla, this guy had continuous recurrent attacks. So there is no window for us to wait. So I intervened in an recurrent acute pancreatitis, diagnosis and intervention both. So I have intervened in the pancreas in an acute pancreatitis setting. So it is possible to do in some cases, but ideal would be 2 weeks.
The conventional teaching is 6 to 8 weeks after.
Yeah, but 2 weeks you can have, reasonably good. If you are experienced enough, you can see things. Yeah. Thank you very much. Yeah. Okay.
Thank you for the session. Can I request all of you to be in the center of the stage? For the next session, may I please invite Dr. Ajay Jain and Dr. Manoj Sahu to please moderate this session. Can I also request Dr. Shivam Khare, Dr. Priyanka Udawat, Dr. Indraneel Saha, and Dr. Mandeep Kar to please chair this session.
मनोज जी अजय भाई अभी क्या 25 साल से यही तो कर रहे हैं।
Without wasting much time, we'll move to this session on third space endoscopy. And the title of the talk is Future of Third Space Endoscopy. And we have none other than the pioneer in third space endoscopy, Dr. Amol Babai, who has done an extensive work in the field of third space endoscopy. And he will be enlightening us about the future of third space endoscopy. Over to you, Amol.
The outset, let me thank Dr. Arora and his team for this kind invitation. Wonderful to be back here and again in person after a long hiatus. And thank you, Dr. Jain and Dr. Manoj Sahu for this opportunity. So third space endoscopy. So we're going to discuss a little bit about what is new and what is past and everything. No disclosures. So I'm sure many of you all have seen this slide of mine earlier as well. But let us start with this question as to what is third space endoscopy. We all know about the first space, which is the luminal endoscopy that we've all been performing. And the second space is the intraperitoneal space, which our laparoscopic surgeons utilize, and also Notes endoscopy also utilizes that. But then there is a potential space in the submucosa of the GI tract, which is a potential space, but that can be exploited to perform various procedures. And how did all this evolve? Because it's important to understand how this evolved to see where it is going. They started with mucosal surgeries like polypectomies, EMRs, ESDs, and full thickness resections, and along with the developments in notes, which gave us an improved knowledge of the submucosal space. And this actually exploded into a variety of these procedures, all of them which are in combined called as third space endoscopy procedures or submucosal operations. POEM being the index procedure and several other offshoots that we will discuss. And all these are based on the principle of the mucosal flap valve. We know that the bowel wall comprises of the mucosa, submucosa, the muscularis propria. And what is done in these procedures is we make a mucosal incision only on the mucosa after creating a submucosal elevation. And then we dissect in the submucosal plane to create a tunnel. Then the muscularis propria is accessed distal to the point of the mucosal incision. And then once the scope is withdrawn, what happens is the mucosa falls onto the muscularis and creates a watertight sealing. So this actually gives us protection from a full thickness perforation, but at the same time gives us access to the submucosal and the muscularis propria layer. And this can be implemented to access and treat deeper layers of the gastrointestinal tract. So POEM is the index procedure. We know that POEM for achalasia cardia has become a very popular procedure for more than 10 years now. And what is done is we create a mucosal incision in the mid-esophagus, create a tunnel across, which goes across the gastroesophageal junction, and then perform either a selective circular or a full thickness myotomy, extending beyond the gastroesophageal junction again. This is how I'm going to run through all these videos because these are, I'm sure many of you all have seen these videos earlier as well. So after that, the mucosa is closed using clips, and that is how the procedure is completed. So outcomes of POEM for achalasia over the last decade and more have shown impressive results, encouraging results. Overall, more than 90% efficacy in majority of the studies all throughout. Of course, as experience grows, we also know that there are certain failures, there are adverse events, and reflux has started emerging as one of the concerns after POEM, and we will discuss that in the future, some slides. But what POEM did is actually gave us the opportunity to explore the submucosal space in much more detail. And endoscopists around the world have actually exploited this submucosal space to perform a variety of these procedures for spastic disorders. These are the spastic disorders, as well as to resect subepithelial tumors, also to treat esophageal strictures, and also to treat reflux. So all these are possible. So refractory gastroparesis is another major issue. And for this, based on the success of POEM, a few years down the line in 2013, this was the first report by the Johns Hopkins group where they performed a pyloromyotomy through the submucosal tunnel. What is done is a submucosal incision is taken in the antrum and a tunnel is created up to the pylorus. And once this is the pyloric ring, there are several similarities as well as some technical differences and as to how a G-POEM differs from a POEM. The myotomy is very short, but it is always necessarily a full thickness. It is more of pyloromyotomy rather than what is actually considered to be a full thickness, a length of a myotomy. So this is how it is performed. And then typically the mucosa is closed using clips. So what was the success of G-POEM? Well, POEM had success rates more than 90% in majority of the series, but here we can see that majority of the G-POEM results are somewhere in the range of 70 to 85%. So good results, no doubt, but probably not as good as POEM. Why is that? So this was the first international prospective study, and we're going to discuss a few. I've selected a few of the recent most studies because they actually put the perspective correctly. So here, this was a study design with 5 tertiary centers. They had 80 patients, and the follow-up was for a year, and it was a very extensive follow-up. Variety of parameters were analyzed at frequent intervals, and the results And clinical success was reported as 56% at the end of 12 months. So that is even lesser as compared to what we have seen in the previous chart. So why is that? So one of the issues was that the definition of clinical success was very stringent in this study. And these patients had a very excellent follow-up data of around 94%. And there were several independent predictors of success. So this study was not actually a failure study. There were definitely predictors of success that they were identified. Baseline gastric cardinal index score, symptom score of more than 2.6% was considered to be a favorable factor for success of GPOM. Baseline gastric retention of more than 20% at 4 hours and early response at 1 month after the GPOM were all considered to be favorable responses after the GPOM. And patients with severe symptoms were the most likely to benefit by the GPOM procedure. And the etiology was not considered as a significant predictor. This was another meta-analysis, and here we can see that GPOM definitely has a positive outcome on patients as compared to others. However, the limitation was in this study that there were few studies and all of them were single arm. There is a very recent, few months ago, this was the first sham control study which was published in Gut. And this is a very innovative study because it has compared GPOM with a sham control group. They had planned to recruit 86 patients, but after 41 patients, they had to stop the trial because of the response rates. And the treatment success, you can see 71% for GPOM as compared to only 22% after in the sham group, which obviously indicates fantastic success rates for GPOM. And what they demonstrated was that the diabetics probably had the best results. And here we can see some of the patients also had to cross over from the sham to the GPOM group. However, even this study, there were certain limitations and criticisms because several patients were post-operative patients, but there is no detail available in the paper as to which were these patients. And the study was not powered to evaluate the efficacy in the subgroups. And therefore, we still have a doubt regarding whether the subgroup analysis was really factor to prove significance. So what is the future directions when we are talking about GPOM is that GPOM, it is definitely successful in many patients, and it has been shown to increase the pyloric diameter rather than the, by the distensibility index. And what is important is probably we need to perform end of lip or anteroduodenal manometry in order to, before the GPOM. Therefore, we can select our patients better for GPOM rather than doing random GPOMs based on only gastric emptying studies. These two are the most studied procedures, but then we have several other procedures. But when we talk about the future, Abraham Lincoln said that the best way to predict the future is to create it. And some future perspectives that there have been new techniques, and the focus has been towards improving outcomes, towards improving safety, towards optimal patient selection, as we saw in the GPOM studies, minimizing adverse events and side effects, understanding the limitations of any procedure, and exploring new horizons. So coming to the new horizons of in third space, PRAME or per rectal endoscopic myotomy for Hirschsprung's was something which we described a few years ago. We know that Hirschsprung's is a congenital disorder characterized by absence of intrinsic ganglion cells and which presents with constipation and megacolon. And the commonest treatment is a pull-through surgery, which may be a single or a multi-stage procedure, but which has significant morbidity, and there are several issues regarding that. And that is the reason an endoscopic approach was described initially in an adult and then in pediatric patients. And what is important to do is we don't know the proximal extent of the ganglionic segment, aganglionic segment, and therefore mapping is very important as compared to what we do in POEM, where the G junction is a finite organ. Here we have to do a proximal mapping so that we can tailor the length of the myotomy. And we do that by performing serial EMR biopsies and staining them for ganglion cells. And once that mapping has been performed, we perform the PRAME procedure in a prone jackknife position. And bowel prep is an important issue in these patients because they're severely constipated. And we perform the procedure along the sacral hollow posteriorly, and the tunnel is created for the desired length, and then a full thickness myotomy is performed, which needs to necessarily extend up to the internal anal sphincter. Mind you, it has to extend to the internal anal sphincter, otherwise the outcomes may be significantly poorer. Once the myotomy has been completed, obviously the mucosa is closed using clips, and that is how the procedure is done. So these are the results before POEM and after POEM at 3 months. The bowel dilatation reduces and the rectum opens up. The pressures also reduce. And we reported this initial experience of 9 patients a couple of years ago, where the length of the aganglionic segment was around 6 centimeters on mean, and the mean length of myotomy was around 11 centimeters. And these were the results. Mean stool frequency as well as mean unit laxative usage before and after POEM demonstrated significant improvement, and 2/3 of our patients did not require laxative after the initial 2 to 4 weeks after the POEM procedure. That was the advantage. Coming to Zenker's diverticulum, this is another novel technique. We know that septotomy, although successful, had its own limitations regarding adverse events or recurrences, and surgery is too invasive. And therefore, a Z-POEM or a per-oral upper esophageal myotomy, which utilizes the same principles, can be performed. So this is the cricopharyngeal bar or the septum, which separates the Zenker's diverticulum from the esophagus. And what we do is we create a submucosal tunnel, dissect on both sides of the septum, and then divide the septum within the tunnel so that it gives an excellent result. Similarly, for epiphrenic diverticuli as well, they're usually associated with achalasia cardia and particularly with sigmoid achalasia. And in many of these patients, despite doing an LES myotomy, these patients may have dysphagia, and therefore it is important to divide the septum along with whenever we are doing the POEM procedure as well. And that is the reason the diverticulum POEM has been evolved, and Zenker's or D-POEM, that is how it is differentiated. And these are the results which shows significantly superior success rates that patients typically have around 85 to 90%, even 100% success rates after the Z-POEM or D-POEM. Coming to resection of subepithelial tumors, this technique is derived from POEM. The advantage is that these lesions typically arise from the muscularis propria layer. They may be leiomyomas or gastrointestinal stromal tumors. So if we divide the muscle and the mucosa at the same point, it will lead to a full thickness perforation. But by creating a tunnel, we perform a mucosal incision a few centimeters proximal to the tumor, and we approach the tumor through the tunnel. And then the tumor is dissected from the muscle layer within the tunnel. Here you can see that the mucosa is intact. And so a muscle breach over here is inconsequential. And once the tumor has been delivered, it is pulled out of the tunnel through the mucosal incision, and then the mucosa is closed using clips. Results of STIR or submucosal tunneling endoscopic resection are excellent. Again, 83 to 100% success rates. The adverse events are to a certain extent slightly higher than as compared to POEM, because it involves much more dissection in the submucosal and in the deeper planes. Most of these adverse events are gas-related adverse events, but typically they are self-limiting, and most of the times they can be resolved without any major issues. What has been described is the tumor size more than 3.5 centimeters, and multilobular tumors present a higher technical challenge for performing these procedures. The last novel procedure in third space endoscopy is the peroral endoscopic tunneling for restoration of the esophagus. So patients with complete esophageal obstruction, where even a guide wire or contrast cannot pass across, we can actually create a passage by dissecting in the submucosal plane and then cutting through the fibrotic band under the mucosal layer. And then once we have a track that has been established, we pass in a guide wire, and place a fully covered metallic stent, which stays in place for 4 to 6 weeks. And later on, once the stent is removed, patients may still require repeated dilatations for a few times, but then we have a passage which has been re-established. So there are, occasional patients like this, but we had an opportunity to, demonstrate and report this case in one patient. And it is really a gratifying procedure in those patients who require it. So that is how the lumen has been completely re-established. Coming to the other issues where the advances are taking place, we have started understanding the limitations and the problems that we have identified regarding, POEM and third space endoscopy procedures. So one of the most important areas was reflux that was being identified after POEM. And this was the editorial and this article, which in about 5 years ago, which actually brought this topic open into the open. And several studies thereafter also demonstrated that reflux after POEM is and does seem to be a concern. So there is a novel notes procedure which has now been described by Professor Inouye, where we can perform a endoscopic fundoplication after performing an anterior POEM. And this procedure actually can give a good result, as you can see later on. So after an anterior POEM, what we do is we dissect the serosal layer on the gastric, deep to the gastric myotomy, and we open the peritoneum. Here we can see the left lobe of the liver. And once we enter the peritoneal cavity, the scope is turned to the left, the fundus is grasped, and it is first a wrap is simulated, and then the fundus is, an endoloop is anchored to the fundus using several clips, and the other end of the endoloop is anchored into the tunnel. And then once the endoloop is closed, we get a good wrap. Here you can see that the endoloop is being anchored. And there we can see that the endoloop is anchored on both sides. And now we are tightening the endoloop. And here you can see that the wrap is being completed. So that is how it looks. It's a loose wrap. It's not a very tight wrap, but it does give good results regarding reflux. Subsequently, Professor Inouye also described a suturing technique, which also can be utilized. We still don't know which is better, whether endoloop and clips or suturing. Unfortunately, this needle holder is not available outside of Japan, so we cannot even experiment on that. But we reported our results on the POEM F procedure last year again in 25 patients. So the procedure was successful in 92% in 23 out of 25. And there was a learning curve that the initial 5 cases took a much longer time because we were a little bit fumbling. But the mean additional time for fundoplication was around 45 minutes. But what is important to note is that the results, that the wrap was intact at the end of 1 year follow-up in almost 83% patients. And PS studies demonstrated that reflux rates were much less, around 11%, which is comparable to any laparoscopic hilar myotomy with a fundoplication procedure. Another important innovation that Professor Zhu has described is the endoscopic tunneling extraluminal resection. So like a stir procedure, last 2 slides. Like a stir procedure, we can actually go outside the lumen and then we can resect these tumors or lymph nodes. So this also is possible. More to come on that in future times, I'm sure to say. So third space endoscopy has opened a lot of future possibilities. Most importantly, possibly, I think the notes can be reopened now. The discussion on notes can be reopened because this has provided a very safe and secure access for notes procedures. And therefore, I'm sure that we will find appendectomies and cholecystectomies being done in near future via this approach probably. Then extraluminal tumor resection is another area. And of course, there is a variety of procedures which could potentially be performed using the third space endoscopy approach. However, certain challenges exist currently for third space endoscopy to take up to the next level. Indications, many of the indications that we've seen, except for achalasia, probably most of these are for uncommon disorders, and therefore the opportunities are quite few, and therefore data is also limited. Instrumentation also is quite limited presently, and the other issues about training, who should train, how one should credential, what should be the credentialing and competence, how that can be assessed, and whether endoscopy and surgery should be at loggerheads with each other or whether they can be complementary to each other. And therefore, what do we need? We need strong data backed by research. We need multi-center studies because of the limited numbers, randomized studies and meta-analysis. We need to position third space endoscopy procedures within treatment algorithms. We need to identify the stakeholders, which are the endoscopists, the surgeons, and the industry, and put our heads together. And we need to create optimal training opportunities and have suitable credentialing in place. So therefore, to summarize, third space endoscopy presently can be considered, it is in its adolescence. POEM is well established within treatment algorithms, but challenges do exist, particularly reflux. GPOEM, we have reasonable evidence, but optimal patient selection still remains elusive. PREM, poetry, STIR, ETER, POEMF, and POEF are new kids on the block. We need to explore more about these procedures. Third space endoscopy has tremendous potential and interest, but there are challenges. New procedures and techniques are evolving, and collaboration between endoscopists and surgeons would be the key. Thank you so much. With great power comes great responsibility. We need data, because of which we can probably improve our responsible behavior in this field. Thank you so much.
Thank you, Dr. Amal. Beautiful presentation. So only one question or a comment, then we are closing the session. Any question from the chairperson, Dr. Bipul? Okay.
Amal, great presentation. We are struggling with instruments. We don't have dedicated platforms, just like EUS. Are you looking some development in that area?
Well, one area is definitely robotics, but robotics, the way we've seen it go in surgery, I think is going to take a really long time for it to come into endoscopy. Because even in surgery, it's not become mainstream yet. So I think a very long way to go before it comes to endoscopy.
Thank you.
Okay.
Excellent talk, sir. So one question, what are the failure rates of POEM and whether redo POEM is successful, and what is the comparison between the surgical approach or redo is better? And one more I wanted to add, just recently reviewed the literature. So there is a report of GPOEM in congenital hypertrophic pyloric stenosis. One case report has come in 6 months old baby, and it was successful. Post 6 hours, they were able to feed the baby. And one more on esophageal fistula repair post-step in 5-year-old male. And they used ESD technique for opening and then closing the fistula. So the question was for the redo POEM.
Right.
Thank you, sir.
Thank you. To address the first question regarding POEM failures. So I think POEM failures are like failures after any myotomy. I think it is the disease process which actually dictates whether the procedure will be successful or not, and therefore patient selection would be an important thing, particularly patients with S2 type of sigmoid achalasia. One has to be careful about devising POEM because many of them may not get dysphagia relief. We need to understand that any myotomy in achalasia is a palliative procedure. We're not going to improve the propulsive activity of the esophagus, and that is where the issues lie. We published a multi-center study along with the Hopkins group where, redo POEM after Heller's and NAVE POEM was compared. So although the efficacy is the same over a period of time, possibly because of the longer history or duration of symptoms in the redo POEM patients, the efficacy has dropped to a certain extent. In your other congenital hypertrophic pyloric stenosis is definitely a fantastic indication for GPOEM. However, our pediatric surgeons are still not very comfortable and they're not very well versed with endoscopic procedures. We are facing the same problem to recruit patients from Hirschsprungs as well. But I think we need to do a collaborative effort.
I think the last question.
I think Amal, excellent talk.
Thank you, sir.
There was one new entity which is
LIEW poem, which is presented in DDW this year, and the results are better. Results are same, but the time is short.
There's a full thickness, the open poem, you mean to say?
Actually, they, I think, instead of staging, they cut the muscle as well as the mucosa. While tunneling, the muscle is cut. What are your comments on?
Well, it can be done, I'm sure. See, there are two types of this thing, that as you are creating the tunnel, you can keep cutting the mucosa. The issue is at the LES. If the LES is very tight, if you divide the muscle too prematurely, it becomes difficult to push the scope across the LES, because then the scope tends to buckle over there. That is the only problem which I foresee. I've never done it myself. So I would rather try and complete the tunnel and then proceed with the myotomy. That's my.
I think, thank you all. This is a beautiful session. We are concluding now. We are moving to the next session. Thank you.
Thank you.
Thank you, sir. Can I request you for a picture? We have a 10-minute tea break. We'll begin with the colonic polyp session first by Dr. Mohan Ramchandani. After this, yes. So let's meet again after a 10-minute tea break.
हेलो, थोड़ी सी लाइट ऑन कर देना, लाइट ऑन कर देना. We now have the tea session. थोड़ी सी लाइट जला दो. I think I should leave. Thank you.
Hello. Due to the paucity of the time, we have to begin the session. Can I please request all of you to be seated? We are going to be beginning with the next session on colonic polyps. Can I please invite all the delegates to be seated? What time is your flight, sir? Can I please invite Dr. Mohinish Chabra and Dr. Atul Sachdev to please be moderating the session? Can I also invite Dr. Meenakshi Gidare, Dr. Dinesh Singhal, Dr. Amol A. Suryavanshi, Dr. Sayantan De Sarkar to please chair the session. I think they're out for coffee. So I think we'll wait for another few minutes. We'll be beginning with our next session. Can I please invite the chairperson, Dr. Meenakshi? If you're here in the audience, please come. Dr. Dinesh Singhal, Dr. Amol A. Suryavanshi, Dr. Sayantan De Sarkar to please chair this session. Dr. Atul Sachdev, can I request you to please moderate this session? I think the speaker is
Okay. Good afternoon, everyone. It's my proud privilege to invite the next speaker, Dr. Mohan Ramchandani. I think no, he doesn't need any introduction. One of the best therapeutic endoscopists of the country and has made his name nationally as well as internationally, and is going to speak on chronic polyps, classification, and endoscopic management. Dr. Mohan Ramchandani, please.
Thank you, Dr. Mohinish, for the kind words. And at the outset, I thank Dr. Anil Arora for giving me this opportunity. And before we go ahead with the colonic polyps, we should all know that we as a country, India, though the colonic neoplasia is much, much lesser than the West, but we are also catching up. And you can see the problem with us is that the colorectal cancer, though the rate is 4.4 per 1 lakh, majority of patient dies because we are diagnosing these disease in stage 3 and the prognosis remains poor. So we have to learn that to diagnose these disease, not when the patient has suspicious symptoms, not when they come to us with emergency of colonic obstruction, but when they are asymptomatic. And once you do in an asymptomatic patient colonoscopy, you have to diagnose these polyps. Now, my job is to tell you about how to classify these polyps, know which polyp is what polyp. And the most important armamentarium which we are having in diagnosis, especially early diagnosis, is image-enhanced endoscopy. And if the image-enhanced endoscopy is there with us, we can do wonders. But before that, we should also know how to classify these polyps once you are doing white light endoscopy. And those early polyps have been clearly defined now as type 0 polyps. Now, the type 0 polyp can either be a polypoidal polyp like these, either they can be a sessile polyp or a pedunculated polyp. while the non-polypoidal polyps are two types. Either they are depressed type. Now, one has to learn why we are talking about depressed polyp or a flat polyp. Those which are flat polyp are known as 0-2 type, while those which are depressed type are known as 0-3 type. Now, why it is important? If just by seeing a polyp, you can say whether this is a polypoidal polyp, there is a stalk, there is a sessile polyp, the invasive cancer rate is around 2 to 10%. But as you see a polyp, which is a depressed type, the cancer rate is 50 to 66%. So you will be more aggressive in treating depressed polyp rather than treating polyps which are sessile or the polypoidal type. But also one should understand now that white light endoscopy allows us to classify these polyps into LSTs, that is known as laterally spreading tumor. So the term laterally spreading tumor refers to a lateral growth of polyp, at least 1 centimeter. We know polyp either grows vertically up or down, but they spread laterally. So these terminology is now laterally spreading tumor. And by mere seeing the white light, you can say whether the polyp is granular or non-granular. If the polyp is granular, that G for good, granular polyps do not have invasive cancers. While NG, that is non-granular polyp, where there is no granules, I'll show the example, these are not good because they have invasive cancer. So whenever you see a non-granular polyp, you are more worried. Once you see a granular polyp, you are okay. So you can see here, there is a flat polyp. This is laterally spreading polyp. It's spreading laterally, but there are granules. So this is homogeneously granular, G for good. So invasive cancer is 0.5%. As there can be a mixed variety. You can have a granular polyp and on top of it, there are sessile polyps. These are the 1S variety. So then the invasive cancer becomes 10.5%. While if there is a flat polyp, non-granular polyp, there is high chances of invasive cancers. But if there is a depressed polyp, you can see depressed polyp, a non-granular depressed polyp, the cancer rate is 30%. So you have not even switched to any image-enhanced endoscopy. You have done a good white light examination and have classified what type of polyp you are dealing with. And that will decide ultimate treatment. Why? Because these granular polyp are usually non-cancerous. So you can cut it by EMR. You do multiple polypectomy. You do not require to do an en bloc resection. While here, there can be invasive cancer. And you want to subject full en bloc polyp to your pathologist for her to say that there is a negative vertical margin, negative the horizontal margin. So whenever you see a mixed variety polyp, you tend to do a ESD, which gives us a full en bloc polyp. While non-granular polyps should not be treated by EMR because they will have invasive cancers. So you have to do a full en bloc resection. So by seeing the endoscopic picture, you can decide your treatment. Then comes, you have just now seen a full polyp based on white light. And the most important thing which will happen in cancer detection is angiogenesis. Whenever there is cancer, there is neovascularization. Now you can study these small vessels by doing a narrow band imaging or in image enhanced endoscopy. There can be a different company giving image enhanced endoscopy, different name, like Fuji will come with BLI. Other companies have different names, but that becomes image enhanced endoscopy, a push button technology. You just push a button, you convert this white light into narrow bands. You can, if you see the blue light, which is a narrow, a shorter wavelength light, which will not penetrate deep. And as I said, as cancer develops, there is development of new vessels. So these new vessels can be studied because they are superficial, good by narrow band imaging. Now, why? How a colon look like? So you can see how narrow band imaging is helping us. You can see these are the normal colonic mucosa when there is a small crypt over there, and then you will have a crypt orifice. And then you can see these glands which are opening into the mucosa. What happens in normal epithelium is there is an arteriole, then there is a capillary around this crypt, and then it goes into a vein. Now we have to see these structures very carefully on narrowband imaging. And you can see this is how the vessels will look like. And this is how the crypts will look like in a polyp. Now, based on this, you can decide whether the polyp is cancerous, non-cancerous, or invasive cancer. You can have just a push button, and you can have a polyp which is hyperplastic polyp, which only needs follow-up. You can have a polyp which is adenomatous polyp, which can be treated by endoscopy. Or you can have a invasive cancer polyp, which needs surgical resection. So these three things you have to decide. Whenever you see colonoscopy, whether I can wait and watch, hyperplastic polyp, don't touch. You can have adenomatous polyp, you remove by endoscopy, or an invasive cancer sent to surgery. This is how we decide by NICE classification. This is known as NBI, International Colorectal Endoscopic Classification. Now you have to see three things: color, vessel, and surface pattern. If you see color of a polyp, see that this color, this is the color of the polyp, which is same as background. You will hardly be able to recognize whether there is a polyp. So the polyp color is same as that background or even lighter. While if you see a polyp which is darker than background, so that become adenoma. So seeing a color on NBI, dark polyp, adenoma. You see the vessels. You can see there are no vessels here, or there are small lacy vessels, small, very thread-like. They are hyperplastic polyp. But if you see thick brown vessels, these are the thick brown vessels surrounded by white structure. This becomes adenomatous polyp. And again, you see third thing, the surface pattern. That is the dark spot surrounded by white. This is a hyperplastic polyp, or tubular branched like polyp. You can see gyrus-like structures surrounded by vessels. This becomes adenoma. So this is how a NICE classification helps us. Whether it's a type 1 polyp, which is hyperplastic polyp, you do not treat, or you resect and discard. While type 2 polyp, you treat by endoscopically. But if you see an invasive cancer, you have to refer these patients for surgery. So this is the most simplest method. But there are some problems. A NICE one is very good in deciding it is hyperplastic polyp, but it does not differentiate into sessile serrated polyp, which we'll talk. Or type 3 polyp is very good in invasive cancers, but type 2 can remain either adenoma, which requires EMR, or superficial submucosal invasion, which require ESD. So NICE classification is good by and large, but those who want to really go deep into the treatment part may require something else. So the NICE can be still nicer if it can allow us to differentiate it hyperplastic, which are totally benign, from a sessile serrated adenoma. Or it can help us to know whether the cancer is in up till mucosa or it has gone into submucosa. Because if it goes too much into submucosa, there is lymph node metastasis and the curative resection may not occur. So we want NICE to be nicer. That is why we use a morphological criteria along with NICE. I'll not take much example, but I'll give a clear example. If a polyp is looking cancerous on endoscopy, but if it is pedunculated, you can still cut it completely and get rid of that. So if there is a type 3 polyp on NICE, but if it is pedunculated, the invasive cancer is much less. But if you see type 3 polyp on NICE, but it is depressed, we saw during white light endoscopy, depressed are still more cancerous. On top of it, NBI shows type 3, it becomes 93% cancer. So don't touch that polyp at all. Endoscopically, no, it goes to surgeons. So this is how you can combine the white light Paris classification, morphological look, NBI. Both combined together become still nicer. But still we are looking for some other classification. When I said NICE is not good to tell us whether it's a sessile serrated or hyperplastic, and it is not good to tell us whether it is superficial invasive or deep invasive. If we have a Genet 2 classification where there is a subtle differences, these regular vessels which looks like tubular structures if they are regular, and here you can see they are irregular. So they decide into subtle variation into type 1 and type 2B, then type 2B becomes more invasive cancer. I'll give you an example. So this is a polyp. What is that color? Same as background. So this is more of hyperplastic polyp. So this is a hyperplastic polyp. You don't touch it. You may resect or discard. There are white surface, there are white dark spot. So this is a clear-cut hyperplastic polyp. So it's not a malignant cancerous polyp. But we want to see more closely. I'll go back to the sessile serrated polyps, which are malignant polyps. Now there are some lacy pattern here. And if you use magnification endoscopy, you will find these pits. These are the pits on the polyps, which are, these are small lacy vessels. But if you do magnification endoscopy, you will see dilated crypts. So these are very classical of sessile serrated polyp. Similarly, you can have a narrowband imaging. You can see as soon as you turn narrowband, there's dark polyp. So this is a adenomatous polyp. There are branch structures, the vessels are regular. This becomes a adenomatous polyp. So you can clearly remove it by endoscopic method. And then we come to a polyp which has got combined type of appearance. On the lateral side, you can see there is a regular vessel pattern. On the middle, you can see there is something irregular vessel. The surface pattern is not good. So on the periphery, it's genotype 2A, that means adenoma, and type 2B in the middle, which may be cancerous polyp. While here, you can see there is a depressed lesion on white light, and on narrowband imaging, complete amorphous. You are not able to see any surface pattern. The vessels are totally gone. So that is cancer. So this requires surgery. No endoscopic treatment in this patient is allowed. So by mere seeing the polyps in the form of morphology, narrowband imaging, you can decide whether you are dealing with high-grade dysplasia or low-grade dysplasia, and this can help us. I'll not go into these details, but I'll come back to another polyp which we trying to miss because we have got less number of polyp, that is sessile serrated adenoma. And whenever you see a polyp which is proximal, that means right colon, they are transparent, they have a mucosal cap, they have a large pits, or they have grooves, or they have lacy surface pattern, you should not leave that as hyperplastic polyp. They look like hyperplastic, but they are cancerous polyp. So whenever you see a polyps which are looking like hyperplastic in right colon, you should be very, very suspicious and take the help of this WASP classification. When you see a hyperplastic polyp, you see the clouded surface, you see the irregular shape or the pits which I have shown, and whenever you see that, you call them sessile serrated polyp and don't leave them, you remove them. But now this requires a lot of training, but now we have gadgets available which tell us whether we are dealing with a polyp which is cancerous or not, told by artificial intelligence, which is there inside our endoscope. And this is how we do. I'll show you an example. See, this is a colonoscopy being done. A polyp is being marked. This is yellow line, which says there is a polyp. Then you go near the polyp and do endocytoscopy. See that now we are pressing a button, which is enlarging these vessels. This is known as a cancerous adenomatous polyp. The machine is telling us you can stain this polyp by methylene blue, and then you can again do endocytoscopy based on the after staining the nucleus, and then you can enlarge this to 560 times, and you can see these are the large nucleus, the pit, there is an elongated pit, and that tells us that this is an adenomatous polyp. So now you have scopes which will tell us whether we are dealing with, but these polyps are all based on the classification. These are the images, videos fed on this artificial intelligence that is able to tell us, and the sensitivity of this endobrain is much better than a good trained endoscopist. But I'm talking about India, where the training is not that great regarding these early cancers, but we are catching up with the Japan and Korean colleagues, but still far away. But we can take the help of this type of newer methods, which can allow us to diagnose then and there only whether we are dealing with a cancerous polyp. I'll quickly go into the treatment part. Once you have diagnosed that it's adenoma or it's an invasive cancer or a superficial invasive cancer, one has to see these imaging and decide whether you need to have a treatment based on endoscopy. So the majority of endoscopic treatment are either a polypectomy. Now we have cold snare polypectomy or endoscopic mucosal resection, where we use snare and cut this polyp into many pieces and remove it, or ESD, endoscopic submucosal dissection, where we completely remove the polyp and block. So this is how we have to decide. The most important thing which has come up is cold snare polypectomy. And we have dedicated snares for that. You can see these are the braided snares, thick snares, 0.4 mm. But if you want to use a cold snare polypectomy, they are shield-like snares, thin wire, single wire, 0.3 mm, and use these polyp to do a cold snare. So any polyp which is 10 millimeter or less can be easily removed by cold snare polypectomy. There is no use to use cautery here. You just snap and the polyp is gone. So whatever small bleeding is there will happen in front of you. There is no long-term complication, coagulation related injuries, and majority of these polyps which are less than 10 millimeters can be removed. But now people are using for even larger polyp, but data is still not very clear on that. So this is a polyp dictum is all polyps less than 10 millimeter should be cold snare. What is EMR? Once you do a polypectomy, when we saw laterally spreading tumors, you have to remove these polyp in multiple sessions, and I'll show you a good example. So this is a laterally spreading tumor. You can see this is a granular variety, and then this is a homogeneous granular. So good for EMR. Good for EMR because we know granular have no deep invasive cancers. So you can do this elevation by injection with glycerol or even saline, and then you can use this large snares to cut this polyp. You can see you can go from one end to other and keep on cutting. So this is known as endoscopic mucosal resection. Advantage is it is very quick. Disadvantage is that pathologists will never be able to tell us about the margin. But choose your patient. If the patient has granular polyps, you can use this technique. While these piecemeal resections are good, I'll take another 2 minutes, and then you can see the recurrence rate is very high. But since they are non-cancerous, we are not bothered. But if you're dealing with a cancerous polyp, slightly deeper invasive, you do ESD. How ESD is done? ESD is done by completely removing this polyp. You can see we are not using snare. We have to use a technique where we have to completely remove tumor away from the muscle and remove this tumor en bloc. By doing the submucosal dissection, you can see here the tumor is being dissected from the muscle layer. But idea is to get en bloc. So I have told you about what are the polyps where ESD will be preferred over EMR. Non-granular tumors, mixed variety tumors, you have to remove these tumors en bloc. And then if you subject this type of tumor to your pathologist, they are able to say whether you have done a good job or not, because you will ultimately have a full specimen available, which can be subjected for true histopathology, like a surgical specimen. So with this, I'll end my talk and say that colonic polyps are usually diagnosed in asymptomatic patients. You have to take the help of white light endoscopy to diagnose them as a Paris classification, see whether this patient will have an invasive cancer or not, switch on to the NBI or BLI, say that is an invasive cancer, send to the surgeon, if your NICE classification or Janet classification says they are superficial cancers, you can use EMR or ESD technique or even cold snare polypectomy to remove these cancers. Thank you very much for your patience.
Thank you, Mohan, for an excellent presentation, as always. I think we can have few questions from the audience, from the chairpersons.
I'm Dr. Meenakshi. I'm actually a surgeon. I have one question that when the lesion is going till the submucosa, you are doing ESD, end block resection. I wanted to know what is the data regarding the surveillance,
Yes.
the cure rate, the recurrence, and when you refer to the surgeon.
That's very good question. Actually, ESD is also a diagnostic histopathology. Once you are removing a tumor, you are subjecting that to a pathologist who will say the lateral margins and vertical margins. If vertical margins are defined, for esophagus, it is 200, for gastric, it is 500, and for colonic, it is 1000 micrometers. If the cancer goes beyond this, and there are many studies, very good done studies, which shows that if the margin of the cancer is crossed in submucosa, say for example in colon, the cancer cells are going beyond 1000 micrometer in submucosa, you are already the lymph node metastasis there. And then these patients, the guidelines say it will require additional treatment in the form of radical surgery. But if you have removed the tumor completely and your cancer cells are less than these margins, you have done a curative resection, and then they do not require any further treatment.
Actually, we have the idea, but my question is, do we have a data when we do the surveillance? Do we have a data?
Fantastic data is available. There are so many studies in the West and Japan. There is a study on early gastric cancers, early colonic cancers, which have clearly shown that if the adenomatous polyp is there, though surveillance is required, these 20%, if you do ESD, 5 years recurrence rate is 30%. If you do EMR, it is 20%, but still they are non-cancerous. So you can do second or third surveillance colonoscopy and remove the residual polyps.
Mohan, it's an excellent presentation. I have got some small tricky questions. As a surgeon and endoscopy, sometimes what we classify the polyps into two. One is extremely pedunculated, other is non-pedunculated. Now, I have a question that if you do a polypectomy of a pedunculated polyp and the polyp is lost in the colon, you are not able to retrieve for biopsy. What are the techniques or tricks so that you are able to catch it in a basket or whatever mesh and get it out for biopsy? That is one thing, because patients are always apprehensive about the biopsy part of it. Number two, that if you think that this is on your magnification endoscopy, this is a lesion which is cancerous, and of course that if you give a choice to the patient for a curative surgery, I mean, patient would go for it. So is there a role for a deeper piercing needle biopsy, the biopsy forceps with needle, because all the time you may not be able to do ESD or resection, submucosal resection of that flat lesion. So what is your say on it?
I mean, both are very good practical questions. So the first is lost polyp. I think the most important thing is preparation. If your preparation is good, you will not lose polyp. If the preparation is bad, you may lose polyp. In fact, one should wait for good preparation before you attempt to do colonoscopy, because even if there is a complication like perforation, if the preparation is good, you may still manage these patients with endoscopic. But if there is a fecal contamination, then there's a big problem. So always make sure that there is a good preparation. And also we also use these polyp trappers, which are attached to the end of the endoscope, where by suction, because the polyps which will get lost are very small polyps. So you can keep on sucking them and the polyps will get deposited in those trappers. So good preparation, use of trappers is very, very important. Regarding your questions regarding the needle being used to define the depth of invasion, I think that's not a good idea, because you will cause more upstaging of the tumors. In fact, we use endoscopic ultrasound to say whether the tumor.
No. I mean, biopsy with spike.
Biopsy with?
Biopsy forceps with spike.
Spike.
So that you can take a good deep biopsy of a suspected malignant lesion.
That we always do, but in fact, we now the good question is that if you have a very good magnification NBI endoscopy, and if you have an expertise of ESD, remove the polyp, because that's going to be an organ preserving surgery, and you are not stopping there. You are subjecting that polyp to histopathology, saying whether that polyp resection was curative or not. If curative, you just keep quiet and go for surveillance colonoscopy. It is not curative, you go for either radiation or do additional oncology treatment. So that should be the management in 2022. Do a good white light endoscopic examination, good NBI examination, remove the polyp in toto, and wait for histopathology.
Last small question, Mohan. Do you use chromoendoscopy ever during the algorithm?
Because of the lack of training, yes, and the cumbersome nature of this chromoendoscopy, we usually do not do. But yes, there is some indication once you are not very sure on NBI that it's going invasive or not. Chromoendoscopy has shown to be better than image enhanced endoscopy to define. Once there is a doubt, you use chromoendoscopy, but practicability is very less.
Thank you so much, Mohan, for an excellent presentation. I think we'll close the session. Thank you.
We request you to come in the center of the stage. We'll now begin with the next session in the endoscopy. Dr. Piyush Ranjan and Dr. Sushil Filodia, can I please request you to moderate the next session? Also, can I please invite Dr. Jimil Shah, Dr. Rinkesh Bansal, Dr. Roshan Shresht, and Dr. Rahul Pathak to please chair this session.
There is a change in program. Can I request, since this is a very important surgical session, Dr. Vinay Kapoor, sir? Is not there. So while the presentation is being set up, I welcome you all to this topic of this session on surgeon endoscopic interface, the futuristic endeavors. Speaker is Dr. G.V. Rao, who does not need any introduction. And we all look forward to hear to this talk. Dr. D.K. Singh and Dr. Vinay Kapoor, sir, if you are there. Can I request Dr. N.M. Tikku to join us on the dais?
ये तो पूरा है लाइन इस तरफ लगाना है तो connect right on this side. ठीक है same connector they have it. They're having some problem with it.
आ गया ना
Just come. You try for that. Yeah, ठीक है चालू कर दो ना ठीक है चालू Thank you so much. At the outset, let me thank Dr. Anil Arora for the honor of this podium and his entire team. The way it looks, actually, last couple of presentations gave an impression that everything can be done endoscopically. I strongly differ from this. Actually, there is a slight, if you talk about surgery as in today, I personally believe that surgery as in today is an amalgamation of endoscopy, open surgery, and laparoscopy. And we also know that the morbidity and mortality of surgery is basically because of the bleeding, the leaks that we encounter, the blood loss that happens during surgical procedures, and the extensive resections that are done during these procedures. And we've also shown, and we also have a lot of data to show that endoscopy and laparoscopy have shown to decrease the morbidity and mortality in some of these procedures. We have these two specialties which have evolved very well, both endoscopy and laparoscopy. Unfortunately, both of them have their own pros and cons. Endoscopy is flexible, maneuverable, and has got NBI and other modalities. But the difficulties are orientation, accessories are a limitation, and energy sources are a limitation on the endoscopy side. Laparoscopy on the other side is rigid dissection, resection, anastomosis, and hemostasis is possible, and we have ICG and IR laparoscopy as in today. But the difficulty seems to be organ preserving surgery that we do in these procedures. So suppose we combine endoscopy and laparoscopy together, what happens then? As Mohan and Amol have shown you, endoscopies have started moving from the lumen outside the lumen, and the surgeons have started crossing from the outside into the inside. And we have a beautiful gray zone, which is the no man's area. And as on today, it's taken over with the laparoscopy endoscopy cooperative surgery, where both the surgeons and the endoscopists come together to do these procedures. And endoscopy in surgery, it is just not that. We do both intraoperative endoscopy and laparoscopy endoscopy cooperative surgery. And we have a totally different setup for this, wherein we have two towers in this, which one tower takes up the endoscopy part, one tower takes up the laparoscopy part, with all the gadgets available, both on the endoscopy side and the laparoscopy side. This is called as an endolap OR that we have as today. Intraoperative endoscopy can be done intraoperative endoscopy, enteroscopy, colonoscopy, pancreatoscopy, or cholangioscopy. It is not just intraoperative endoscopy. I'll give you a couple of examples. Most of these procedures can be done without endoscopic assistance. But suppose you add endoscopy to these procedures, like a Heller's myotomy or a sleeve resection or any resections that you have, there is a lot of data to show that the overall morbidity in these patients is definitely less when you're using. Suppose you have facility for endoscopy in your theater, it is always better that you can use. It is not mandatory, but it is shown that it improves the overall morbidity. And if you're showing this, actually, we're doing a laparoscopic gastrectomy, and if you have an intraoperative endoscopy, it is shown that the overall complications are less as compared to when you're not doing with endoscopy. And also, if you're doing a laparoscopic fundoplication, the re-intervention rates are less. There is a number of times wherein we can always remove an extra suture that we placed to make sure that the scope passes easily after the procedure. Likewise, intraoperative endoscopy, this is one such procedure. This is the staple anastomosis we have done. On table, we found that actually we just put in a scope and you can see the spurting result from the anastomotic side. These we don't have to reopen this patient. All we have to use is a clip. And there's a small leak that we encounter on table that can always be reinforced laparoscopically. And we have this infrared laparoscopy as in today, which shows the integrity of the anastomosis, the vascularity of the anastomotic site. So endoscopy during surgery proved to be very, very beneficial. And it is also started, we have also started using this for colonoscopy. It enables accurate localization of early mucosal tumors, aids in detection of lesions proximal to the unexamined colon for obstructive left colon cancer, visual anastomosis of anastomosis, as I've showed you, proper surgical resection, concomitant lesions, immediate hemostasis, like I showed you, suture repair of leaks, and creation of protective stomas and when it is required. Intraoperative endoscopy was the gold standard. Even on today, still there is a role. It's not that we can shy away from this. It's a laborious procedure wherein the entire scope is pleated across the small ball. For the first ever time, way back in 1996, I think we showed this concept of laparoscopic assisted enteroscopy, wherein we make an enterotomy in the distal jejunum and pass the scope both proximally and distally. Though the usage of this has become less and less with the advent of other spiral enteroscopy and other techniques, but still this has a role in current day management. Both for pancreaticoscopy and cholangioscopy, for those who are not aware of it, actually there is an increasing role of pancreatoscopy in patients with IPMN. This is one such patient who had a IPMN in the head region, underwent a Whipple's resection, and subsequently when we put this scope into the distal segment of the pancreas, remnant pancreas, we noticed another lesion a centimeter away from the transected line, which was not picked up on the conventional imaging modalities. This is what we picked up. Actually, you can see this. This is what a lesion a centimeter from the resected. So we had to revise this margin. And then this is how the revised margin looks like. So you can see this intraoperative pancreaticoscopy seems to have made a big impact in the management of these patients. And now with the advent of laparoscopy, we started doing these procedures laparoscopically. Initially, we thought there is a lot of limitation to do these procedures, but with expertise, these same scopes can be maneuvered through the laparoscope as in today. And you can make sure, you can see that is the scope that is going through the entire extent of the pancreas, and we'll be able to visualize the tumor, and also the transillumination of pancreas helps us aiding in resection margins in this. Now, this can be done both antegrade and retrograde. This is one such patient who have done it. It is not necessary that we do only for IPMNs. Actually, in patients with chronic pancreatitis who are doing a distal pancreatectomy, we want to visualize the proximal duct to make sure that there are no additional strictures which are not picked up in conventional imaging modality. These modalities can be used, and you can see this. The slim slopes that are available right now can aid passage both antegrade and retrograde. So from open to laparoscopy as in today. Now, this is another patient with a colorectal cyst with an IPMN that we recently seen 2 cases of this. Actually, this basically we just tried to show. This is one of those first images to show intracholangioscopy. You can see transilluminated bile duct here. This we used it here just to make sure that the resection margins can be identified. You understand? Actually, I know that the hilum is free here, and we could go at the hilar the site of the resection. Again, ICG in laparoscopy has made a big dent into the practice. Right now, we started using IR in laparoscopy right now. This is basically we inject ICG into the lesion, and we're able to pick up these sentinel nodes that are not picked up in conventional biopsy. Now, this is a beautiful example. Actually, this huge polyp that was projecting right from the cricopharyngeal junction to the esophagus, almost about 20 centimeter polyp, actually with a very wide base, which was not possible. Actually, obviously, when Mohan has not done this endoscopically, it means it cannot be done endoscopically. If it has come to the surgical side, it means it has passed that, it has filtered that area, and it has come to us. So obviously, we have to do a pharyngotomy here. But this is just to show you that we put the scope into the pharynx and then try to see that recording of the thing to make sure that we don't have any post-operative bleeds during this play. Subepithelial tumors are being increasingly detected now, and we seem to understand their biological behavior better. And we also understand that segmental minimally invasive resections are adequate for this. The functional outcomes of these are better with faster recovery. And umpteen number of procedures are described for this. Actually, name the procedure. All these procedures are depending on the amount of endoscopic or the laparoscopic involvement in this. Various technologies are used. Now, these are used based on the amount of lesion, whether it is predominantly serosal or predominantly mucosal. Obviously, we have a gray zone. Predominantly serosal lesions go for a laparoscopic assisted endoscopic procedure. Now, this is one such example. This is a classical example where I'm sure all the surgeons will agree that actually you just have to put a sleeve, staple this, and that should be okay. But again, if you're using an intraoperative endoscopy here, this is to make sure that there's no bleeding at the staple line. This is absolutely advantageous. This thing, actually, you can see the staple being fired. And then at the end of the procedure, we can always make sure that there is no bleeding at the site. This is the advantage of using this intraoperative endoscopy during these procedures. The biggest disadvantage of using the sleeve gastrectomy for this is the margins are good in one axis, the margins are not good in another axis. It is for these reasons, laparoscopic assisted endoscopic surgery seems to be beneficial. Some of these subepithelial tumors can be resected endoscopically, but here we have one very close to the J junction. Conventionally, these would require some sort of proximal gastrectomy or a total gastrectomy. Initially, we used to do this, but endoscopists are being aggressively doing this. But here we have done a laparoscopic resection. Unfortunately, this patient had a bleed in the postoperative period, and we could use this endoscopy to clip that bleeding site, avoiding reopening of this patient. Again, some of these lesions which are big, which are not amenable for endoscopy here. Again, we are doing this using both endoscopy and laparoscopy to aid the dissection. Actually, this is basically endoscopists here are using as an aid for full thickness resection. And this basically procedures are for the surgeons to get adapted to the new environment that are going to do the thing. So whenever you're planning for these things, actually the surgeons and the endoscopists should work together, and you should give some role to the endoscopists so that they make sure that they're doing this procedure during some amount of involvement happens during this. End of the procedure, you can see this. Here, what I'm trying to do is, it's not necessary that it's very easy for the endoscopist to put this after you resect the thing. It is very easy for the laparoscopic surgeon to pick it up and put this in the endo bag. But here, it is an exercise on the endoscopist to make sure that he gets used to the endoperitoneal cavity. He's using this rat tooth forceps to hold it and put it. It looks very simple, but it's a very difficult task to orient yourself and put it into the endo bag on the laparoscopic side. So here again, a huge gist in the antral region. This looks like as if you can do a sleeve resection for this. But when we tried to do the sleeve resection, I put the endoscopy inside. I was not able to go across. Now this would have, suppose if I had done a sleeve in this patient would have come up with some sort of obstruction in the mid body. Here, again, we've taken the help of the we do something like the third space endoscopy. We talk about third space laparoscopy, inject submucosally from the endoscopic side, create that cushion and make a seromuscular incision. And you can see this is how you make a seromuscular incision. The mucosa is completely intact in this. I'm not getting into the lumen of the thing. The lumen is completely intact. We make a seromuscular incision. Like what you do in third space endoscopy, that is the blue area which identifies that you're in the right place. You're not going into the lumen of the thing. And once you're done with this, then use this staple to just staple the mucosa. So here you're preserving the entire organ and you're able to get the complete full thickness resection here. So I'll just show you that is how it is resected. And subsequently, we can close this seromuscular incision. That's the endoscopic view. And you can see the laparoscopic view. The transillumination helps us to check the integrity of the mucosa there. And you can see this. I'll just switch off the laparoscopy light right now to make sure that you see a beautiful mucosa which is intact. You can see that is the integrity of the mucosa. So this is how it helps actually once this is done, and those beautiful vessels you can see still show that the vascularity is intact. Likewise, we have these early cancers like Mohan was talking about. These can be resected endoscopically, but now we inject this submucosally, and then we make a complete seromuscular incision on the serosal side. Once this is done, the biggest fear that the surgeons have is that these cells can spill into the peritoneal cavity. injected submucosally, make a full thickness seromuscular incision all around. Now, once this is done, now what I do is actually now, once this is done, now I close this seromuscular incision, inverting this pathological lesion into the lumen. And obviously I can put some Surgicel or something to make this more prominent on the endoscopy side. Once this is done, actually the endoscopist can always take over and do the ESD procedure on the thing. The advantage is that you're not spilling any cancer cells into the peritoneal cavity. That Surgicel helps, makes the lesion more prominent. Now, we have seen some of these lesions being done endoscopically, if you talk this, but this large diverticuli like this, I don't, irrespective of whatever you do, I don't think you can do an endoscopic resection, and you cannot do any of those mucosal incisions or the muscular incisions to create. These require some sort of a diverticulectomy, and at the end of the procedure, an endoscopic assistance make sure that there is no leak in these procedures. This is a wide neck here, and obviously it requires a thoracoscopy, and the simple stapling of this is adequate. Now, large leiomyomas like this, initially, again, this is beyond the endoscopic thing. Again, we inject submucosally like what we do, endoscopists do. The biggest advantage here is actually, you can see that blue space that we identify that helps us to make sure that you're not getting or traumatizing the mucosa here. The entire lesion can be shelled out, and then we can repair the muscular, both the circular and the longitudinal muscles safely. Likewise, so most of the benign colonic polyps Mohan had showed you can be removed endoscopically. Segmental colectomy can be done, but there are some areas wherein we have some restricted use of endoscopy. Here is one such patient. Actually, this is just an example to show you how colonoscopy helps. This is a large mucocele of the appendix. Traditionally, if I had gone with a regular appendectomy, I would have maybe put in a loop there and taken it out. But here I'm using trans-elimination to make sure that the entire tumor is taken care. So here you can see this. What I'm done is actually, so I'm using trans-elimination to put the staple line, staple it actually, and then once it is stapled, I get the complete this thing, and then again I switch off the laparoscopic light. Once this is whole thing is over, then we can always switch the laparoscopic camera light to make sure that the integrity of the thing is achieved. So this is the advantage of intraoperative colonoscopy here. There's a lot of data to show that combined endoscopy and laparoscopic procedures have definite advantage. And there's a lot of data coming up from across the procedure. There are pros and cons of each of these procedures, but each have their own limitation. But as long as you can identify the indications and you know whether the endoscopist plays a predominant role or the laparoscopic surgeon predominant role, I think these are very, very clear. And they're very clear guidelines as to the role of endoscopist and the laparoscopic surgeon. Both of them have to work together. Cytoscopy is actually, this was what we showed way back actually. Cytoscopy is actually intraoperatively, we also started using intraoperative cytoscopy to make a real-time in vivo histology of malignant nodules like this. And the same thing was extended. Endobrain came to our institute. Actually, we use the same endobrain onto the laparoscopy site to target the biopsies. I'm not saying this is mandatory, but as you show, as the technology is evolving, you have to show what is coming in. This is basically to show how to target these biopsies as in today to make sure that you're picking up a malignant neoplastic lesion versus a non-neoplastic lesion. So likewise, what to do in the colonoscopy side, we put the same scope onto the nodules and the peritoneum, and it is likely that we'll be able to target this. In future, it is likely that it maybe we avoid this and then we can avoid a frozen section biopsy also in this. So if we, I'll just go back to the thing actually. If you've seen science fiction movies 2 decades back, Iron Man, Captain America, Thor, each of them had signature techniques and technology, but somehow there were a lot of limitations and the acceptance of the public was not very good, like what happened in surgery. We have endoscopy, laparoscopy, and surgery together. Surprisingly, the science fiction movies, people seem to have realized this, and then now they have come with Avengers, where they combine all the three together. The limitations of one is understood, the limitations, the pros and cons of each person seems to have understood, and now they've come up, the new series has come up with Avengers. It is no more individual people working together, but I think all three groups working together, and all the Marvel movies that come now are Avengers and not individual movies. like what happened in surgery. So I don't believe that endoscopy is going to completely rule or surgery is going to completely rule. We have a definite space for each of us, and a combined endoscopy laparoscopic procedures are very, very advantageous. Intraoperative endoscopy and laparoscopy cooperative surgery are emerging specialties. Aids lap and open surgery in improving outcomes. There's increasing role of ICG and infrared aided laparoscopic surgery. It aids physiological function preserving oncological resections. AI endobrain likely to be an important kid in future, can be safely introduced in a facility-based manner, either by surgeons or endoscopists with advanced skill. As more surgeons are being trained in GI endoscopy, the indications will surely expand. It is not that we are trying to go onto the endoscopic side. We're just doing a diagnostic endoscopy just to help these procedures. There are a lot of limitations in haptics in laparoscopy. Newer technologies have led to increased indications. And it obviously requires a very close cooperation between skilled surgeons and experienced endoscopists. We all agree with open surgery, laparoscopy, going in for a new dimension of surgery in future, but obviously it is going to be a cooperative effort between surgeons, laparoscopic surgeons and endoscopists. And please don't get away with the message that all procedures can be done endoscopically or all procedures can be done laparoscopically as surgery. Because I see whenever the presentations are going, they see the message looks like as if all the procedures can be done endoscopically. No, absolutely not. And if in my center, if I have done this, it would have gone through the filtered of Mohan Ramchandani and et al. Obviously, it had come to us. So obviously, there is still role for open surgery and laparoscopy in current day surgical practice. Thank you so much once again for your patience here.
Thank you, GV. I think future is for a combination of endoscopic as well as surgical skills. I was just wondering whether 10 years from now, we will call them surgical endoscopists or endoscopic surgeons. Since you showed some clips from Hollywood, I take my memory back to almost 60 years ago. There was a movie which I would recommend everybody should watch, Fantastic Voyage. What I remember that they miniaturized a small space capsule-like thing in which they put 2 or 3 surgeons, and then this capsule went inside one of the peripheral vessels in the brain and did something. That's what I remember. So that is what the future is. And I think these barriers that I'm a surgeon and you are an endoscopist have to disappear. The endoscopists are learning and have to learn surgical skills, and surgeons have to become more and more familiar with endoscopy. So that is what the future is.
Excellent talk, sir. And sir, Dr. Jimil here. Hello, sir.
Hi.
Excellent talk and very fantastic video, sir. I have few questions. First is regarding the submucosal injection to identify and to separate the mucosa while cutting while laparoscopically removing the subepithelial lesion. Is it your routine practice or do you do it only in select group of patients? And second thing, regarding endoscopy and surgical endoscopy and surgeons overlap, I think, as you rightly said, that more and more procedures are being done nowadays. So one of the procedures is also for GRD, where they laparoscopically reduce the hiatus hernia, and along with that, they use the teeth to reduce the chances of post-nascence bloating and gas bloat syndrome, and to create more compliant omega valve rather than nascence floppy valve. And also nowadays, more and more procedures are being done especially in Japan, where T2 lesions are being resected and endoscopically along with laparoscopic dissection of lymph node. So what is your take on that, sir?
Very good question again. I showed you my data regarding intraoperative use for fundoplication. Yes, we routinely use, in my department, yes, I routinely use it in all cases actually. In fact, actually, after we started doing, initially we thought there is hardly any role for intraoperative endoscopy, but now we see that almost 30% of our work in the theater seems to be intraoperative endoscopy, and we're very, very happy with this. At the same time, I'm not saying that it has to be the practice. Actually, it all depends on what you have. In my center, I have the luxury of having all the scopes in my theater. I can do that, but yes, definitely, if we have this facility, and I'm sure the endoscopic colleagues will be glad to come into the theater, assist you during these procedures. And not all procedures we do this submucosal injection. As I told you, typical cases which can go for sleeve resection, predominantly exopathic lesions, we don't have to do this. But again, yes, to check for any bleed at the staple line, we use this. But again, predominantly, if the lesions are, if you have to preserve the organ, yes, endoscopic submucosal injection. And now actually, I didn't have that clip actually, but I have a very beautiful video wherein we got rid of the endoscopy right now. We inject subserosally from the laparoscopic side and do the incision. So we don't have to do an endoscopic assistance also.
Thank you, sir. And one more question, sir. Like always, it has been focused that whenever you make endoscopy suite, it should be like a surgery OT theater. So surgeons can also come and do the procedure. I think it's now time that surgeons should also focus and they should also make their OT theater where endoscopists can come and do their procedures.
I strongly disagree to this statement of surgeons going into an endoscopy suite. I strongly disagree because there are a lot of issues, actually, Vinay will agree with me, there are a lot of sterility issues which are concerned. The endoscopy suite, irrespective of what, there are umpteen number of suits available, but they're not, we don't maintain that sort of quality actually. But yes, the endoscopist coming into the theater is a very good option, but I think surgeons going into an endoscopic suite and doing it as on today, we don't have no center which can boast of saying that we can safely go do these procedures without doing any causing any increased morbidity.
Since there are since there are very few surgeons in the audience, most of you are gastroenterologists and endoscopists. My plea is that please tell your surgical colleagues that if you have an intraoperative problem which is not accessible by you through laparoscope, as Dr. GV showed, a very low after a low anterior resection, if there is a problem at the anastomosis, you can handle it very well and much better than what we can do laparoscopically. So that is what I would request. You should tell your surgical colleagues that if there is an intraoperative problem, they should probably call you for help if required. Thank you.
Thank you
very
so much.
Thank you.
Thank you for this session. I'll request you to please be in the center of the stage for the picture. Apologies for the change. Dr. GV Rao has a flight to catch, so we had to reschedule the session. I'll invite Dr. Arun Badoria, and I'll request Dr. Piyush Ranjan to please stay back for the session. Dr. Sushil Filodia to please moderate this session. I'll also request Dr. Jimil Shah, Dr. Rinkesh Bansal, Dr. Roshan Shresht, Dr. Rahul Pathak, and Dr. S.K. Mishra to please chair this session.
So for the next session, we have again continuing with these futuristic topics, artificial intelligence in endoscopy. We have Dr. Saurabh Mukhewar, our young and dynamic gastroenterologist from M.I.C.E Hospital, Nagpur, and he'll tell us how artificial intelligence scores over natural stupidity in endoscopy. Dr. Saurabh.
Can I also request Dr. Praveer Rai to be a part of this moderating the session?
A very good morning, not actually afternoon to all of you. It's indeed a pleasure to be here. And as the debate between surgeons and endoscopists end, I take you to the future. So today I'm assigned the topic of artificial intelligence and endoscopy. And I actually thoroughly enjoyed preparing for this talk because it really shows you what the future is going to be like. So as humans, we've always looked for options to make our lives easier. We had abacus way back, then you had calculators, then you have computers, and now you have artificial intelligence. So what is it? It's a system's ability to interpret external data correctly, to learn from such data, and use those learnings to achieve specific goals and tasks through flexible adaptation. So if you just broadly categorize it, you have AI in a virtual form, which is what I'm going to talk about today, or in the physical form, in the form of robotics. So let's talk about endoscopy. And I think there are few things in the history of endoscopy which have been true game changers. And I'm going to show some of those. Endoscopic ultrasound, the development of EUS has been truly a game changer in the way we treat diseases. lumen-opposing metal stents. Now we have the ability to drain gallbladders, perform gastrojejunostomies, drain collections, capsule endoscopy being one, third space endoscopy, which we heard a nice lecture from Dr. Bape on. And I would argue that artificial intelligence is going to change endoscopy. Now, AI is everywhere. Your Alexa has AI. Your Apple phone with Face ID has AI. The Google Ads have AI. Self-driving cars, Teslas have AI. So let's understand the basics of artificial intelligence. All of us are doctors. We are not computer savvy programmers. So if you look at artificial intelligence, it's essentially intelligence in a computer form. So it's the ability of a computer to perform a task associated with intelligent beings, including cognitive functions that might mimic the human mind, such as the ability to learn. Machine learning is a part of artificial intelligence, which is basically the ability to learn with data. Now, you have to understand, we have lived through programming, and programming is different. You tell the computer that x plus 1 is equal to y, you'd give 5 as x, and then y is equal to 6. That's programming. But here, you show the computer things, it learns on its own, just like humans. Deep learning is an enhanced form of machine learning, which includes algorithms that use layers of nonlinear processing, again, a technical term, for feature extraction, and I'll show you what that means. And then computer vision, which sort of includes all these three, is a field of computer systems in which processing of images or videos is performed, and how computer might gain information or some form of understanding from this. So just to illustrate, on the left are pictures of my son. The computer looks at these pictures, looks at the eyes, looks at the hair, looks at the ears, looks at the nose, and it tells me that this is my son Anil. On the right, of a similar age, is my nephew. And again, looks at the eyes, the ears, the nose, and can determine, based on a few pictures, who it is. So this is my nephew. And when you label these images, as most of you have done with your iPhones, it has the ability to understand who these individuals are. And then you show 1,000 pictures, and immediately, all of you have seen this in your iPhones, if you're using them, is that it tells you who's who. So what really changed it? And I remember this paper published in Nature in 2017. I was a fellow and I came across this work, and it was truly eye-opening. And I could only imagine what the future is going to be like. So this was the first study looking at AI computer vision in skin lesions. So what they did was they used AI computer vision to classify lesions as being benign or malignant and categorize them. And what was the most impressive part of this was the findings. Now you look at this, carcinoma, melanoma, whatever, they could predict the diagnosis better than dermatologists, and not just junior dermatologists, people with a lot of experience. So this is, I think this was a landmark study, and since then, there have been several papers published in artificial intelligence. So look at this graph over the last 2-3 years. You do a PubMed search with AI and you see a lot of articles. And again, same applies to endoscopy. And I would say, if I was giving this talk 3 months ago, 10 or 15 of the articles that I'm going to quote would not be published. So this is a very dynamic field. So let's understand the basic terms. On the left is CAD-E, which is CAD diagnosis, computer-aided diagnosis. On the left, which is diagnosing polyps. On the right is CAD-X. So I apologize. On the left is computer-aided detection, and on the right is computer-aided diagnosis. And this on the right is able to differentiate between different types of polyps that Dr. Mohan Ramchandani showed you. So now you have the ability, your scopes have the ability to tell you what polyps, not only detect them, but also tell you what polyps they are. And there are lots of tools in the market, the Medtronic, Olympus, Fuji, Pentax, they're either in development or already out there. And let's see the data. Now, the tools in the market are for colon polyps, and there are randomized controlled trials understanding the impact of using artificial intelligence in screening colonoscopies. Now, this is I would say some would argue this is less relevant for the Indian context, but I would argue that it is quite relevant because we are not used to screening colonoscopies. And if AI is there, we'll probably pick up polyps early and prevent cancers. So this is a randomized controlled trial. The first one published by Rapici et al. In Gastroenterology in 2020, where they randomized patients to AI-assisted colonoscopy versus a standard colonoscopy for detection of polyps. And what they essentially found was AI outperformed a standard colonoscopy. Now, if you look at the histology, all adenomas and colorectal cancers, the AI detection was 54% versus standard colonoscopy at 40%, as you see on the graph on the left. And this was very applicable for polyps less than 10 mm in size, which are easily missed by standard colonoscopy. And regardless of the polyp morphology or the polyp location, AI performed better. More recently, another huge randomized controlled trial, they used the new technology with iterative scopes. And here they used this in 5 US academic centers, 22 experienced endoscopists. Overall, an increase in 27% in adenomas per colonoscopy. And again, did not specifically for lows less than 10 mm in size. So putting it all together, randomized controlled, multiple randomized controlled trials, almost 4,300 patients. And what you could see is AI outperformed humans. And this, again, regardless of the polyp size, in fact, in this study, as well as the polyp location. Now, what happens when you apply the AI to the real world? This is a study just published 1 week ago from Israel, where they evaluated pre-AI time versus post-AI. So they had 2,100 procedures performed before AI and almost 2,000 procedures performed after introducing AI. Now, paradoxically, the polyp detection rate unfortunately went down. The adenoma detection rate went down. The advanced adenoma detection rate also went down, but no difference in colon cancer rates. Now, here's the problem, because these patients getting colonoscopies, their withdrawal time was shorter. This led to a false sense of belief that AI is going to solve your problems because you think you can do a poor quality of examination and AI will pick it up. So it's very important that you need to use this technology in the right way. Now, there's a solution for that too. Now, here's AI to tell you what is the quality of exam you're performing. It's telling you that when this colonoscopy is being performed, there are a lot of views of the wall. So the quality is actually not great. You're not getting good views of the wall and of the entire spectrum of the colon. And now you'll see in a few seconds. Now, this is a high quality exam. Now you're distending the colon, you're getting great views, and this will increase your chances of picking up polyps. Now, when they compared this AI and the fold examination, it correlated very well when experts performed the colonoscopy, as well as the historical ADRs. And when this was introduced for colonoscopy, what they could find was the quality of examination went up when you used artificial intelligence. So not only can you detect polyps now, but your quality of examination of colonoscopy has gone up. So this is going to be very applicable in the Indian context. And you're doing the colonoscopy, whether you're getting good quality exam, and you'll also be assisting in diagnosing the polyps. Now, as I showed you the CAD-X, which is the diagnosis with the help of AI, this is the initial data published in Gastroenterology, comparing the performance of polyp characterization with AI. They had excellent area under the curve with the training and validation sets. And what they found was when they compared this with humans, so on the top line is the AI, which is 96% sensitive, and compared to the experts, which is equal and better than novices. And the accuracy overall was similar to experts and better than some novice endoscopists, and the diagnostic time was lower. So overall, the polyp characterization is also superior with AI. Now let's look at other applications. We have Barrett's esophagus. Now this is a large study published 2 years ago. They had a data set of almost 5 lakh images, and they developed the computer-aided detection system and then compared that with endoscopists. And what they tried to find was, can you find neoplastic changes in the Barrett's esophagus? And also the secondary outcome was, can you delineate the polyp well? Now, busy slide, bottom line, accuracy with AI was touching almost 90%. But then when you compare this with senior or junior endoscopists, it was definitely superior. And the segmentation performance in terms of delineating the dysplastic changes was almost equal, actually superior with AI. And if you look at this graph, it just tells you how AI performed, and the fluorescent marker is AI, high sensitivity and high specificity. And compare with all the doctors, this was better. So clearly this outperformed. And again, this is taking it further in Barrett's esophagus, where they looked at a training with a small number of images. It's 129 and validated with 36 images for early esophageal adenocarcinoma in Barrett's. Now, this is interesting. Now you see they're looking at with artificial intelligence, looking at the Barrett's, and you'll soon see now a lot of physicians who are not trained to identify this. Now it is mapping the area and telling you this is cancer with a 95% probability. Now that's very applicable for centers and situations where the training can be inadequate. And for India, where the Barrett's esophagus prevalence is lower, not all the endoscopists are trained to identify such changes. And then again, moving forward, it's looking at another area in Barrett's, now telling you that it's not dysplastic. So this is exciting. So now moving forward, esophageal cancer. Now, another study, this is a lot of Asian studies are doing this work, and this was published in GIE. AI for esophageal squamous cell cancer. They used various data sets of cancer and benign conditions. And you see all these images, which are beautiful images now you can get with high quality imaging with endoscopy today. Sensitivity was pretty good, higher than 95%. Specificity in benign lesions was also very good. The problem in this particular series was they used images for training. So when they used and applied this on videos, the sensitivity went down for standard endoscopy. But then when they use high definition endoscopy, the sensitivity was pretty good. So still in development, but there's a lot of excitement on this front. Now, the most relevant part when you're looking at an early esophageal cancer, especially as endoscopists, is the ability to perform endoscopic resection of these lesions. And that tends to be a problem, and defining whether a lesion is resectable with endoscopy can be a challenge. And again, the studies showing similar rates between AI versus regular endoscopists. How about gastric conditions? Not only that, you have H. pylori diagnosis with artificial intelligence. Now, this is a study looking at the white light imaging, bright light BLI this is a Fuji Scopes imaging and LCI. And what they could find was on white light imaging, they were not very good with AI, but then when they used high definition imaging with BLI and LCI, the accuracy went up to 95% or above. So maybe we won't even have to take biopsies in future. How about early gastric cancer? Just as I showed you for early esophageal cancer, similar data, high sensitivity levels with AI when you're looking at early gastric cancers. And this is exciting because this is a large study published in China where they looked at almost 10 lakh images on endoscopy from 85,000 individuals, 6 centers. They did a high quality study, internal, retrospective, prospective validation, as well as external validation in other centers in the country. And overall, just like I showed you earlier, high level of accuracy of 95%, and then in the and if you can see the sensitivity of 95% almost, including the same center and outside. Now, this is how it looks, the relevance of this. On the left of the screen are expert endoscopists looking and diagnosing cancer. And this is what the expert endoscopists missed. And the ones in green are the ones which, if they used AI, would have been picked up. So this is for expert endoscopists. 61 cancers missed, AI would have picked up 43 of them. Now, not always are there expert endoscopists out there for early cancer detection. When you have a competent endoscopist, 157 cases missed, AI would have picked up 133 of them. And you have a trainee endoscopist, 306 cases missed, AI would have picked 266 of them. So it really has a great potential, especially in our context where individuals and doctors are not very well trained to perform early cancer detection. How about small bowel applications and capsule endoscopy, which is can be a tedious process to look and diagnose conditions. This one, again, AI-based study, and They looked at various parameters, red spot, inflammation, blood content, vascular lesions, protruding lesions, etc. And they had excellent ROC curves, and I'm going to move forward and I'll just show you how that impacts the evaluation. So when you looked at junior doctors performing this, and overall sensitivity was 66%, and that went up to 99% with the use of AI. And red spots increased sensitivity from 35 to 98%. Inflammation, 62% to 99%. Blood content, vascular lesions did not make an impact, but for protruding lesions, from 73% sensitivity to 100%. No difference with parasites or diverticulum, and then some increased diagnosis of normal variants. So not only that, let's talk about IBD, AI for ulcerative colitis to predict endoscopic or histological remission. And when you look at this data, it's pretty good in terms of the sensitivity, again, 90% above. And there was good correlation of AI with the endoscopist scoring the inflammatory activity. Moving on, cholangioscopy, which becomes a bit of a challenge when you're trying to diagnose a malignant versus a benign stricture. And now there's evidence to support this, again, published last week in GIE. Overall, if you look at the AI-based diagnosis, the sensitivity is 93% versus standard methods of 30 and 40%. So certainly something to look forward to. Another study looking at similar data, benign versus malignant with cholangioscopy, very high accuracy rates. I'm just going to move forward in the interest of time. EUS, yes, AI also there for EUS, and I'm sure this will be available in the market in the near future. For pancreatic masses, they had a 96% accuracy or sensitivity rather with the help of AI. And something which is very exciting to improve your efficiency, this is endoscopic automatic image reporting system. Now, look at this. The scope has been entered, and now it's reached the cecum. Where you look at the appendiceal orifice, AI detected that the scope is in the cecum. And then there's a polyp that is being removed. So AI is able to detect that you found a polyp, the size of the polyp, and what is being done. And so they're using a cold snare to remove a polyp. And the best part is, you don't need a secretary now, because AI picked it all up. It told you what happened when you went in, what did you do, and the whole report is now generated automatically, and you don't have to do anything. So what about using AI in terms of the reporting system, the quality of the examination? So now this is the reporting system with AI versus endoscopist, high quality EGD performed, and overall anatomical landmarks were much better with AI, and then detected lesions were better with AI. And then quality of reports, if you see, was better with AI on the left, which is almost 60% with grade A quality versus 20% with endoscopists. And I'll just move to the last part of my talk, if you can give me a minute or two. So this is real-time monitoring of blind spots with the help of artificial intelligence. So as the scope is being advanced into the esophagus, it can pick up whether you're getting the right views of the esophagus as lighting up on the left, and then the scope is being advanced into the gastric body, and then they can see what sort of views are being obtained and whether you're getting good views of the entire stomach. And as the scope is advanced into the duodenum, it detects that the scope's picking up. Now the fundus has not been examined, and the AI is telling you that the fundus has not been examined. So the quality of exam is being monitored. And as you get good views, the entire stomach is now lighting up, telling you that you have performed a high quality examination. So very relevant, especially if you're picking up early cancers in today's context. And randomized controlled trial looking at use of AI versus not using AI. Overall blind spot rate was much lower. Inspection time slightly increased because you're doing with real-time feedback, and the photo documentation completeness was better. So bottom line, AI, I think I would argue, is a game changer, especially in India, where we are not trained to pick up early cancers and colon polyps. So this is also not only going to pick them up, but tell you if you have done a good quality examination. There are excellent results of AI with all applications, as I showed you, from colon polyps to IBD to EUS. Most studies are retrospective, so now there is more data required to apply them to real-time videos, and the potential to actually enhance the quality of examination with real-time feedback. So there's a Japan endoscopy database project going on. The Japanese have taken a lead where they have been collecting data from all the centers to certainly help the artificial intelligence in future. So thank you so much. Happy to take any questions. Yeah.
Thank you, Dr. Saurabh, for an excellent review of the literature. So I think, as you have shown, AI definitely holds a very promising in all areas of GI. But I hardly saw any studies from India. Possibly there are none. So what do you think in India are the important areas where AI will really be helpful?
So I think it really comes down to having the data. So if our centers have archives of all the data and we connect with the computer scientists, we should be able to perform our own AI neural networks, number one. And number two is, I see that once we have the application of AI in determining the quality of exams, for all the trainees out there, your bosses can now check if you have done a good quality exam. So certainly that, number one, as we have high quality scopes coming through the pipeline, we will be able to pick up early cancers. And we have learned that there are so many now ESDs being performed because now we can pick up cancers early in India. And certainly because now this is actually potential to reduce mortality. Now, how many times are there things and developments which can actually reduce mortality? So if you have AI telling you the quality of exam is good, and AI telling you that the early cancer is picked up when you're doing high definition endoscopy, then I think you will be able to find more patients with early cancers and ultimately remove them to have a mortality benefit in the long run.
Yeah.
Excellent lecture. I have a provocative question. So it is said that as our smartphones become more and more smart, the person using them becomes more and more dumb. So do you think with increasing use of AI, the clinical skills of the doctor, that would go down and eventually will reach a stage where the nurse will be performing the endoscopy, will get the report all typed from by the AI, and there'll be hardly any requirement of the endoscopist doctors?
Well, that's an interesting point. No, true. And I think it's only going to be for the betterment of humanity, whatever is being done. And we could be down to being pure, we have to be technicians in terms of doing the quality of exam. But there'll be a component of cognitive interpretation where AI is not really replacing, but rather assisting you. So now you see there are AI models for radiology. Now there are AI models to detect nodules, detect bleeding, detect pneumothorax. So that unless a person with the cognitive skill set validates it, because it's not 100%, it's 95%. So those 5% cases, you still need brains. Thank you.
So to answer Ashish's question, probably AI cannot supplement the role of a good preparation, good examination.
Yes,
you
true.
have to have, Saurabh showed that data, that you need to have that adequate withdrawal time and all those things. If you don't have that, I mean, AI is not going to pick up extra. So probably, although the data shows that for smaller polyps or bigger polyps, the miss rate is equal, but intuitively one would think that it would be picking more smaller size polyps rather than the bigger size polyp. Probably polyps more than 10 millimeter, it is difficult to miss if you do a good thorough examination.
Oh, true. I think we are not replacing the skill of doctors to perform a good examination. AI is not going to replace your ability to remove yet. So that's still intact, but certainly it's going to assist. It's going to be a great tool to make the quality better, especially in academic and bigger centers where you have trainees performing. So, the quality of exam being performed is going to go up, right? Because now AI is going to pick up things. But ultimately, I think in the grand scheme of things, it's going to reduce the cancers and mortality from that. So I think in that context, I'm really looking forward to this being in the real world. Yeah.
Yeah. So I think the reason for missing early cancers is usually in Indian scenarios is not doing a proper examination, not giving sufficient time.
Yeah.
So I think, what's your take? Doing more meticulous examination the way Japanese do for picking up early cancers, or just roping in AI at the same time. So you think?
Yeah, I think as of now, we don't have robust screening program and the ability to understand which patients have a higher risk of early or cancers versus not. So I think that's the key, is to be able to define these people with the right amount of data. That say you have a 60-plus-year-old with a history of smoking, or versus a 20-year-old with no risk factors, which has a lower risk of cancer. So now I think once we define that, then we will be able to determine that these patients are the ones who require a higher quality examination, and then therefore have the yield will go up. But I think that starts with defining the right individuals, which I'm sure a lot of us will be now excited to do it once we have all these tools available. Yeah. Thank you.
One more question. Is there any role of AI in therapeutic endoscopy? We have discussed only for diagnostic endoscopy. So what's the future of AI in therapeutic endoscopy?
So I think in terms of therapeutic endoscopy, say you have AI probably may assist you in determining, say, a bleeding source. So now if you're doing an ESD and there's a vessel and you can't see, then the AI may be able to assist you in identifying and determining which is the vessel which is bleeding when your field gets obscured. So I would see this as a potential application. Certainly in terms of determining, as I showed you, a submucosal invasive cancer versus not, and being able to determine whether a interventional endoscopic procedure needs to be performed or not. So that certainly is another application. Yeah.
Thank you, Dr. Saurabh, for your excellent and
Thank you.
comprehensive talk. With this, we close this session. Thank you.
Oh, yeah.
Thank you. While they're taking a picture, can I request all the participants to please check out from their rooms, as the hotel is pressurizing us. I would also like to continue with the next session. Dr. Vinay Dheer will be on Zoom. For the next session, can I please invite Dr. Sanjay Satpathy, Dr. S.K. Mishra, Dr. Prashant Solanki to please moderate this session. Can I also invite Dr. Nishant Nagpal, Dr. Kapil Jamwal, Dr. Hitendra Garg, and Dr. Srihari A. Anikhandi to please chair this session.
So we're going to start our next session. May I invite Dr. Vinay Dheer to talk about advances in therapeutic endoscopic ultrasound.
Thank you very much. Am I audible? Can you hear me well?
Yes, you are audible.
Thank you. Thank you. At the outset, I would like to thank Professor Anil Arora for giving me this opportunity to talk about interventional EUS. I know it is late. You all guys must be hungry. Lunch is being served. So let us quickly go through what has evolved in interventional EUS recently. So the story is about 2 decades old, and it is very attractive because here we are mixing endoscopy, ultrasound, and interventional radiology, concepts of all these 3 very, very nice technologies. What has happened in the last decade is good studies have appeared, and so we know which techniques are holding on, which techniques are not holding on. And interventional EUS has caused a paradigm shift in management of many disorders. So this is a review I wrote about 8 years back. The indications remain more or less the same: ductal drainage, bile duct, pancreatic duct, fluid collections, pseudocysts, wands, perirectal collections, liver abscesses, cancer-directed therapy, various techniques, alcohol ablation, chemotherapies, radiofrequency ablations, and then, of course, celiac plexus neurolysis and vascular therapy in the form of coil injection for gastric varices. So most of these indications, we have got good studies now. So let us see what is happening in the last few years or so. So good collection of scientific evidence has happened. Technology innovations have come about, and utilization in community practice also has increased. So things are positive as far as interventional EUS is concerned. So now today we have level 1 evidence for pancreatic fluid collection drainage, bile duct drainage, celiac plexus neurolysis. And also, I am aware that EUS guided gastroenterostomy, there is a randomized trial just submitted, not yet accepted. So that probably will be a level 1 evidence, while we have a level 2 evidence for pancreatic duct drainage. We need better evidence for RFA, coil and glue, and other indications. There have been innovations in technology. A variety of EUS specific devices have now become available, starting with the Axios stent in 2012, the Nagi in 2012. Now more and more, there are stents and other devices which are being made specific for therapeutic EUS, and we'll discuss that. In community, as I know in India, PFC drainage is very commonly performed. Biliary drainage, I know at least 40 or 50 of my colleagues who are performing this. Celiac neurolysis is fairly commonly performed. However, if you go below that, pancreatic duct drainage, EUS, JJ, RFA, coil and glue, perirectal abscess drainage, you have certain centers which are doing these advanced techniques. It has not yet percolated to community level. So we need well-trained endoscopists and cost effectiveness of these procedures before it gets accepted in a community. So let's look at these issues. We know that EUS guided approach is best for pancreatic fluid collection drainage. Plastic stents are okay for pseudocysts. LAMS or biflange metal stents allow necrosectomy. That has been a good development. We know that early removal of metal stents are needed. Otherwise, there may be problems like bleeding. And permanent indwelling stents is a controversial issue, but it has been my contention, and now it has been proved. I will show you the study that it may not be needed in all patients. So, but we do not know, do we need LAMS in all cases, all one cases? We need better necrosectomy devices, and they are coming, and we need cost effectiveness studies. So this is a comparison published 3 years back between laparoscopy and pancreatic and endoscopy or EUS. And you see the complication rates were significantly high in the laparoscopy group, and length of ICU stay and other things tended to be significantly better in the endoscopy group. So based on this study, it was suggested that EUS is superior to laparoscopy. However, the last word has not been said on this. You see this study from All India Institute, Pramod Garg et al., which showed that more or less the outcomes are similar in the two groups. Actually, infections are higher in the endoscopy group compared to the laparoscopy group. So we need more studies comparing these two techniques, larger studies. You all are aware of the standard technique. It's a very fast technique when you're using a hot stent. Hardly takes about 30 seconds. So you assess the cyst. I'll go fast, see for any vessels in between. And if you are using a hot Axios, you just use a cautery to go in and quickly deploy the stent. Practically, it takes about 30-40 seconds in experienced hands, and you see the results are immediately. You can see the debris and other things coming out. So very, very attractive concept. And then, of course, if the patient has large necrotic debris, you can go with your gastroscope and clear the debris. This is a very important concept. We published it in 2018. And based on this classification of disconnected pancreatic ducts, we proposed that probably a permanent indwelling plastic stent after removal of metal stent may not be necessary in vast number of cases. So this is a very big study from AIG, and this is our own study, where you see the recurrence rates were not very high despite not placing stents, 13% and 9%. So the recommendation that you should leave a permanent indwelling stent in all patients probably was not correct. And this wonderful study from AIG has just been published last week, and it confirms that if you place a indwelling plastic stent or if you don't place an indwelling plastic stent, the recurrence rates are the same. So probably this confirms that permanent indwelling stents after removal of metal stents may not be needed. What about biliary drainage? It's an acceptable alternative in patients where ERCP fails or is not possible. You have a high success rate, modest complication rate, and we have a level 1 evidence, as I will show you. Problems are we are still searching for appropriate stents and accessories. We need larger comparative studies, and I'm aware of several good studies which are coming, comparison of lamps, using lamps for bile duct versus endoscopy. And I think the results, I know, but they'll come soon. What is the efficacy in Hyler blocks and the cost efficacy, of course. So we were the first to compare an EUS and ERCP for distal malignant blocks, and we showed that there is no difference between the two procedures. After that, there have been, I think, 4 randomized controlled trials, and all of them have shown that EUS and ERCP are equivalent for distal malignant blocks. Actually, the Korean study suggests that EUS is better than ERCP because of reduced pancreatitis rates. The study, which is multicenter study of Anthony Teo, is not yet published, but it shows that the success rates are lower for ERCP. Complication rates are more or less the same for both the techniques, but the time taken for the procedure is significantly less with EUS-BD compared to ERCP. So these are ongoing comparisons, and if you see, this is a rendezvous technique, a favored technique which we follow. You look at this hugely dilated bile duct. You puncture with a 19 gauge needle, inject contrast, pass a wire down across the obstruction into the papilla. I'll fast forward it. Once the wire is passed, you remove the echo endoscope, leaving the wire in place, and then use your ERCP scope to cannulate by the side of this papilla, by the side of the wire. Once you got the cannulation, you can easily place a plastic or a metal stent. In India, cost is an issue. Many patients can't afford metal stents. So rendezvous is useful because it allows you to place a plastic stent also. So our preference is rendezvous and antegrade procedures. We use CDS and HGS, hepaticogastrostomy, in probably less than 10% of our cases. EUS-GJ, I have already told you, evidence has come comparing enteral stents versus EUS-GJ, and EUS-GJ has scored much, much better. It will be published soon. Pancreatic duct drainage, we need better evidence. Similarly, RFA and glue, very, very good techniques, but we need better evidence. So this is about gastroenterostomy. Lots of small studies showing good efficacy. Comparative studies are coming soon. You can see the procedure is pretty straightforward. This is a gastric outlet obstruction. You pass a catheter beyond, pass a wire into the jejunum, then you see here, and then you pass, in this case, a E-pass tube. A E-pass tube is passed over the wire. See, this is a E-pass tube. It has 2 balloons on it. So those balloons can be filled with contrast for you to know where the balloons are. Once you are in the jejunum, you start inflating the balloons. See, this is a balloon. There's another balloon which will come here. And then you create a watertight space between the 2 balloons, which is filled with methylene blue colored solution. So this becomes your target. And then you go with an EUS scope and puncture that area. So see this is a watertight area which we have filled with methylene blue. Use a hot axios, 20 mm preferably. puncture, and you are in. You can see this blue water coming. The technique should not take more than 35 to 40 minutes, and it provides an excellent bypass in patients with gastric outlet obstruction. Patients can eat solids. Here we are dilating it with a CRE balloon, and you can see the jejunum, and you can see the EPAS tube also inside. Very, very good technique, very, very useful technique. Initial worry that maybe there will be perforations, but the complication rates are less than 10%. What about fundic varices? Lot of experience in India, in North India especially, very, very good results, but not yet published. So this is the largest study which shows that very high technical success, complete obliteration of gastric fundal varices is possible in very, very high proportion of cases. What we need is a comparative study between endoscopy and glue injection and EUS and coil and glue injection to see which is a better technique. But this is a very, very, very promising technique. Currently, we are using it in patients in whom there is failure after using endoscopic glue injection. Radio frequency ablation, Sandeep has done a lot of work on this, and again, small number of studies for management of pancreatic neuroendocrine tumors, for management of adenocarcinomas, small adenocarcinomas. Technique appears promising, but we need more evidence. It's a very, very straightforward technique, just like doing a biopsy. This is a technique which I feel will be very, very useful in our hepatology. Portal pressure measurement. All you need is a little expertise with FNA, because this needle, you have to put it in the hepatic vein and the portal vein. And then there is a device which measures the pressure, and then you measure the gradient. So you will not need to do the radiologic measurements. This can be done very, very easily. Already studies are published. And I think this portal pressure measurement is a very, very practical and effective technique to be used in our hepatology departments. These are some innovations. I think I'll quickly go through it. This is Spexis stent for HGS, or anchoring to prevent inward migration. You have this spiral coiled ends. All these slides I have taken from Professor Moon's talk. I was listening to it yesterday. So this is called as a tornado stent to prevent migration. Then you have Microtech biflange metal stent. Of course, Bona stent for gallbladder drainage is available for quite some time now. Another Hanero stent is available, or the plumber stent. So a lot of innovations in technique is now happening specific to EUS, and that is a very, very welcome development. For wire passage, sometimes in antegrade and rendezvous, wire passage is difficult. So this was published again by Sandeep, a steerable device, like how the interventional radiologists have. So you can steer the direction of the wire. So excellent new technology is becoming available. So I think I should finish here. Lot of progress has taken place. I feel very happy about last decade has been, I think, the golden decade for interventional EUS. A number of procedures have shown promise, but some indications we need more evidence. And of course, industry should continue to support us by developing new innovative EUS specific devices. Thank you.
Dr. Dev, that was an excellent talk. We're open to questions now. While I'm waiting, I would like to ask you one question, Dr. Dev, about the US guided portal pressure measurement. What are the complication rate in terms of the bleeding risk, especially these are patients with child C, child B patients? What's the risk of bleeding and what precautions you would advise?
So vast majority of these patients, there are no complication rates. Bleeding is not very significant, but of course, if a patient has coagulation abnormalities because of cirrhosis, you will need to correct that before, because what we are using is a simple 25 gauge needle. It's a very thin needle. So complications are unlikely in patients with normal coagulation parameters, very, very thin needle. And the procedure is pretty fast. It hardly takes about 15 minutes. Not yet launched in India. I think soon, this year only, we should have it in India. And I'm sure it will be very rapidly adopted by all hepatology departments.
This is Dr. Ashish here. Extending to the same question, we did try US guided portal pressure measurement in a couple of patients, but since that device is not available, we connected it to the pressure gauge device, which we use to measure HVPG. But we were skeptical because of puncturing portal vein, so this was difficult.
No, no, it is very easy. It's a 25 gauge needle. Don't worry about it. You can puncture the hepatic vein and then the portal vein. It's very easy and no complications. Don't worry.
Thank you.
Let the device come and I think you will like it.
Dr. Dheer, that was an excellent lecture. Sir, when we do US guided biliary drainage, we encounter a common problem of shearing of the guide wires very often. So is there any innovation in this regard? Are there any needles which help us reduce this occurrence, or is there any technique which should be done when to reduce this shearing?
Yeah, it's a very, very important question. Shearing is a common problem, especially when we begin learning the procedures. The issue is the needles are sharp. And there has been a needle which is available for more than a decade now, access needle, which is not sharp. It prevents shearing, but it doesn't puncture so well. So it has not become very popular. So what you need to learn is technique of passing a wire. You have to pass it very slowly. And if you feel you are going in a wrong direction, don't pull it back very suddenly. So you have to pull it back very slowly using your thumb and index finger. So rotate and pull it back. Then it comes back easily. If it is still not coming back, remove the needle from the hub of the scope and pull it back a centimeter. That straightens the angle and you can pull back the needle almost always.
Thank you, Dr. Binay. It was an excellent talk, and it was very stimulating to know that EUS has crossed so many boundaries and newer things are going to arrive. Thank you very much.
Thank you. Thank you very much. Thank you.
Thank you. Thank you, chairpersons, and thank you, moderators. I'll request you for a picture. For the next session, may I please invite Dr. Narendra Chaudhary, Dr. N.M. Tikku, and I'll request Dr. Prashant to please stay back for this session to moderate the session. Can I please request Dr. Tanka Prasad Bohara, Dr. Sanjay Kumar, and Dr. Bidhan Nidhi Podal to please chair this session. I would like to request again, if any one of you has not checked out, please do check out. Thank you.
Now, I would request Dr. Vivek Saraswat, sir, to talk about the future therapies for hepatitis B.
Thank you, chairpersons. Good afternoon, ladies and gentlemen. This is a sudden change from cutting-edge GI endoscopy back to hepatology. And at the outset, I'd like to thank Dr. Anil Arora and the CHBD team, not only for inviting me for this talk, but also accepting my request to reschedule this for today since I was not able to be present yesterday. In the next 15 to 20 minutes or so, I'd like to take you through what are the expanding horizons for the future therapy for hepatitis B virus. A brief word about the epidemiology and the disease burden. According to the WHO Global Hepatitis Report of 2017, there are roughly 257 million chronically hepatitis B infected individuals in the world, and 80 to 85% of them are concentrated in sub-Saharan Africa, Southeast Asia, including India, and Eastern Asia and the Western Pacific region, resulting in over 2 billion infected humans, of whom, as I've said, 257 million have a chronic infection, and almost 1 million people die annually from end-stage liver disease, its complications, and liver cancer. A brief word about what are the current therapeutic options that we have for the hepatitis B virus. As you know, the preferred first-line monotherapy for chronic hepatitis B in non-cirrhotics and compensated cirrhosis is the nucleoside analogs and nucleotide analogs. And in a selected subgroup, it is pegylated interferon. While for decompensated cirrhotics, we only have entecavir and TDF, not enough data yet for TAF to be recommended in guidelines. The problems with these therapies are that there are very limited treatment indications with current therapy, and chronic hepatitis E positive, chronic hepatitis E negative form the major indications where these therapies can be used, so that overall the large majority of chronic hepatitis B patients remain ineligible for the current forms of therapy that are available. Also, what do we achieve with these current therapies? Well, you're able to achieve ALT normalization, decline in often undetectable DNA levels, improve liver histology, achieve seroconversions, and as a result, decrease the incidence of cirrhosis, liver cancer, and deaths. But all this amounts to essentially hepatitis B virus containment and not cure. So what do we look for from future strategies is to achieve the goal of complete cure of the hepatitis B virus. And coming to the definitions, we have presently within our reach the concept of functional cure, which is a durable S antigen loss with undetectable DNA off treatment in with or without S seroconversion. However, cccDNA persists and there can be a reactivation in these individuals. Sterilizing cure would mean, in addition to these functional cure, also elimination of cccDNA from the hepatocyte, while a complete cure would mean not just cccDNA, but also integrated HBV DNA elimination. Now, before we move to what are the targets and what are the approaches that are being talked of for newer therapies for hepatitis B, I'd briefly take you through some steps in the hepatitis B virus life cycle, particularly the targetable steps, which begin with the entry of the virion through the NTCP receptor on the hepatocyte surface, followed by its migration through the cytoplasm and nuclear entry, where the relaxed circular DNA exposed after the uncoating of the virion gets converted to the covalently closed circular DNA, which becomes the mini chromosome. Some of the virions also undergo integration into the human genome, and the cccDNA then produces mRNA transcripts for the pre-genomic RNA as well as for the various HBV proteins, which are then translated in the cytoplasm and eventually producing pre-genomic RNA and the other forms of RNA that produce all the viral components, the polymerase gene, the core and the surface antibodies and the proteins. And the next important step is encapsulation, that is enclosing the DNA along with the polymerase chain in the nucleocapsid, wherein the positive strain is produced to give you the relaxed circular incompletely double-stranded DNA that eventually will be exported either as virions into the circulation for future infection, or a proportion will go back into the nucleus to add to the cccDNA pool. In addition, secretion of viral proteins, the surplus E antigen, the surface antigen also happens into the circulation. Now, all of these are targetable steps, and the currently available nucleotide analogs essentially act on the reverse transcription step, which is happening during the encapsulation and formation of the HBV virions, while the immune modulators like pegylated interferon act on various components of the adaptive and the innate immune response to release interferon gamma and thus achieve clearance of the hepatitis B virus. Now, what are these newer antiviral drugs? Well, these can be directly acting antivirals that act at specific steps in the HBV replication, including HBV entry inhibitors, and an important group of those that inhibit the release of HBsAg that we have talked about here, as well as nucleotide analogs that we already have in our armamentarium and newer versions of which are becoming available. The CPAMs, that is the core protein allosteric modulators, the small interfering RNAs and the antisense oligonucleotides, as well as strategies to target the cccDNA, all come under the category of directly acting antivirals. While immunomodulation, apart from the use of therapeutic vaccines, we also have immune checkpoint inhibitors that play a role in correcting T cell exhaustion, as well as TLR agonists, which will help us in modulating significantly the innate immune response, which is deficient in HBV infection in those who become chronically infected. And where do these agents act? So coming back to the life cycle, the core inhibitors like ABIH0731 will act at blocking the encapsulation step of the virion within the hepatocyte. The siRNAs will block the inhibition of these messenger RNAs so that the downstream protein formation of the hepatitis B required for HBV assembly is blocked. The cccDNA silencing techniques using the zinc finger nucleases, the TALENs, and the CRISPR-Cas9 technology will help us to clear the cccDNA from the virus. And finally, these HBV release inhibitors will block the release of surface antigen and E antigen, and these have been found to be particularly effective antigen strategies, while the entry inhibitors will block the infection of new hepatocytes. So these techniques are now available to us. And at what stage are these different molecules of, where are they in terms of development? In this slide, we have tried to summarize what is the status of these various categories of agents, the drugs, the mechanisms, the mode of delivery, and as you will see, many of them are still in phase 2. A few of them are in stage 1, including the entry inhibitors, targeting the hepatitis B X protein, inhibition or gene silencing of gene expression using antisense oligonucleotides, a GSK molecule, RNA interference with the Johnson & Johnson and Abbott and other molecules that are in the pipeline. A large number of CPAM inhibitors, the core protein allosteric modulators, are in phase 2 development. Some of them are now entering phase 3 development. The Rep 2139, 2165 nucleic acid polymers, the NAPs, are shown quite good efficacy in the phase 2 and are now entering phase 3, as well as agents targeting the innate immune response, TLR7, TLR8 agonists, as well as checkpoint inhibitors, nivolumab, that we are familiar with in the background of HCC, as well as therapeutic vaccines, particularly the INO vaccine, the J&J vaccine, as well as the TG1050. All are now, this was a slightly earlier slide, they are entering phase 2 after having gone through the proof of concept and phase 1 development. Now coming to what are the results for some of the more promising parts of these newer strategies, I'll talk to you about the HBsAg secretion inhibitors. These are the Rep 2131 is an investigational nucleic acid polymer that prevents assembly and release of the subviral particles, the E antigen and the surface antigen, which not only prevents integration and cccDNA formation, it also blocks the replenishment of circulating HBsAg, which is a major defense mechanism that the virion uses to perpetuate chronicity. In an open label randomized trial, treatment naive patients with this profile, that they were E antigen negative, high surface antigen load, high DNA load, and non-cirrhotics, were treated either with only tenofovir or with tenofovir and NAPS for these periods. That is a dual combination, as well as a triple combination of the NAPS with the TDF and the PEG interferon for the periods that have been shown here, with the result that in this combination, efficacy in reducing the dual and the triple therapies are very effective in reducing surface antigen, in inducing anti-HBs, and in controlling or clearing HBV DNA. And in fact, in the phase 2 trial, the dual and the triple combinations over 48 weeks showed very impressive results: 60% HBsAg loss, 55% HBsAg seroconversion, and a functional cure in almost 45% that was persisted 48 weeks after the end of treatment in this phase 2 study. And this combinations are now entering a phase 3 trials in humans. A brief word about the CPAMs, the nucleoside capsid inhibitors. Now, basically, the HBV nucleoside capsid consists of about 124 core proteins, homodimers, which are arranged in icosahedral symmetry, as shown here. And these then incorporate within themselves the pre-genomic RNA, the HBV polymerase, and form first the immature nucleocapsid and later through various steps, the mature nucleocapsid. These CP modulators are important for most of the steps of viral life cycle, including capsid assembly, intracellular trafficking, genome packaging, etc. And these are vulnerable parts of the HBV life cycle that are readily targeted by a variety of small molecules. In fact, the CPAM have been divided into two classes, class 1 and class 2. Class 1, the HAPs or the heteroaryl pyrimidine derivatives actually result in the formation of aberrant core protein aggregates that are subsequently degraded and thus prevent the formation of functional nucleocapsids. While the class 2 CPAMs, the phenylpropionamide derivatives, result in the formation of empty capsids, so that overall the functional nucleocapsid production is dramatically reduced. The same thing shown in what happens in normals and with the CPAMs on electron microscopy in pictures. And at least 14 of these agents are in various phase 1 and phase 2 trials. The J&J molecules, particularly in combination with siRNA and nucleotides, have shown a significant reduction in HbA1c levels at 12 weeks, while this Abbott molecule has a more potent effect on the pre-genomic RNA as well as the HBV DNA. Specifically, this study with ABI-H0731, in which an interim analysis has been done in the phase 2 study. It consisted of 2 studies, one in chronic hepatitis B patients who were already DNA suppressed using nucleoside analogs that is standard of care today. And the second included treatment naive patients. And in both studies, the control group was nucleotide analogs alone, vis-a-vis the combination of nucleotide analogs versus the CPAM. And as you can see, there were impressive results in the reduction in HBV DNA as well as HBV RNA, but not so impressive in terms of HbA1c decline. So while the HBV DNA decline by week 24 was by 4 to 6 logs, there was no significant change in the HbA1c. And CPAMs now, as I've been shown earlier, have become part of various combination agents that are being used. Now, moving to the immunomodulator and the components, some of the DNAs that the DAAs that affect viral transcription, the small interfering RNAs like the ARC520 and ARO5 HBV molecules, they block the production of HBV transcripts and they result in their degradation. These have been used and they show some significant reduction in HbA1c at 1 log in the large majority at 24 weeks. While the antisense oligonucleotides that hybridize with target RNA and block viral RNA production and protein formation, the GSK molecule has shown in phase 2 studies almost a 25% HbA1c loss at 48 weeks, all of which are very dramatically superior to the currently available nucleotide analogs. There are some limitations of these siRNA and antisense oligonucleotides, particularly toxicity of the delivery platforms, off-level target toxicity, and because cccDNA is not affected, following withdrawal of treatment, there is the potential for rebound, but they all form an important component of combination therapy approaches. Now, the immune modulation approaches, we all know that there is chronic infection in hepatitis B because of a weak innate immune response, weak HBV-specific adaptive immune response, which eventually results in T-cell exhaustion and sustained expression of inhibitory receptors. How do we overcome this? Well, TLR7, TLR8 antagonists and RIG1, retinoic acid inducible gene 1 agonists, immune checkpoint inhibitors, and therapeutic vaccination has been used to overcome these problems. The toll-like receptor agonists stimulate the innate immune response. They are basically pattern recognition receptors for the pathogen-associated molecular patterns for hepatitis B, both of which are integral to the innate and the adaptive immune responses. And the TLR agonists can suppress HBV replication to a variety of these modes. The initial molecules tried out by the Gilead, the vesatolimod, was not very impressive compared to the TLR7 agonist compared to placebo. But the TLR8 agonist, selgantolimod, showed modest decline in HbS-Ag levels from baseline and a 5% rate of HbS-Ag loss at 24 weeks. The oral RIG1 agonist, while it showed very promising initial results, trial studies were stopped initially because of severe adverse events, including a death. But now gradually these the study design being revised, studies can be expected in this area. Finally, the checkpoint inhibitors help, like nivolumab, which is available, help in correcting the T cell exhaustion, which is a basic reason for chronicity of hepatitis B virus. The CAR cells, which have proceeded dramatic results in various tumors, have now also been adapted to applications, but they are more at a proof of concept study for the hepatitis B virus. Therapeutic vaccines have generated interest for a long time. The prophylactic vaccines that we have really were not very effective at inducing long-lasting effective in chronic hepatitis B patients because of the huge surplus of surface antigen that is present in these individuals, which could not be overcome. The early DNA vaccines that only incorporated HbS-Ag forming sequences also showed poor results. But the more recent DNA vaccines that incorporate multiple genes that produce antigens against the surface, the core, the X genes and their proteins have shown better results. The Gilead molecule and the TG10050 have shown decline in HbS-Ag, which is comparable to tenofovir. And in this, the newer studies that have shown undetectable DNA levels and decline in HbS-Ag levels have also been achieved. But these are still very early data, and human studies with phase 2, larger phase 2 and some phase 3 studies in the pipeline. Results are expected in the next few years. Finally, it does appear that no one single agent, even of the newer molecules, is going to be really effective. And like we have seen for tuberculosis few generations earlier, more recently for Hep C and now for NAFLD, in all of these conditions, the use of combination therapy appears to be the way forward. Combination therapy with the older agents did not really yield very good results. As we know that LAM and PEG were combined, but they did not prove superior to LAM. Studies with entecavir and thymosin alpha-1 agonists were no better than entecavir alone. And nucleoside analog along with GS4774, the DNA vaccine, was not better than nucleosides alone. But subsequent studies, tenofovir with PEG interferon, entecavir with PEG interferon vaccine, were superior in terms of DNA suppression and S antigen clearance than the monotherapy alone. However, combination therapies involving the novel agents have shown definitely superior results compared to monotherapy. And these phase 2 trials are some examples. The CPAM siRNA combination with the nucleoside analog showed a 1.5 decrease in surface antigen levels after 12 weeks, and better improvement is expected with longer durations of therapy. Similarly, nucleoside analogs with the TLR8 agonists showed a 5% antigen loss at 24 weeks. The nucleoside analog with the antisense oligonucleotide showed surface antigen loss in almost 25% at 4 weeks in their early trials, while the phase 2 study that I spoke about earlier using tenofovir with PEG interferon, the HbS-Ag secretion inhibitors at 48 weeks showed a staggering 60% HbS-Ag loss in chronic hepatitis B infected individuals with equally high seroconversion and functional cure rates at the end of treatment. So in conclusion, hepatitis B probably is the most difficult to treat virus that is known to mankind. The multi-pronged attack strategy at different steps in the life cycle of the hepatitis B virus are probably needed for cure. MAPS for acid HbS-Ag secretion inhibition and CPAMs to block nucleoside capsid formation appear the most promising newer agents available for hepatitis B virus therapy. The cccDNA silencing and excision technology of genetic engineering is ready for use in humans, but only phase 1 data are available, and this technique will need a lot of further development, and safety barriers have to be crossed before its use in human beings. And finally, phase 3 trials of various combinations of therapy have already begun. And some of these combinations may see licensing as early as in the next 3 to 5 years. So combination for cure is likely to be a combination of nucleoside analog, TAF, tenofovir, or one of the newer tenofovir molecules with a small inhibitory RNA with a CPAM or a NAP and an immunomodulator in combination. Thank you very much for your attention.
Any questions?
Excellent presentation, sir. So which of the many of the molecules which you mentioned is likely to be the game changer in near future?
Exactly, that's what I tried to point out in my last slides. All of these are relatively early data. Most of the results that we are talking about that make us really work further ahead are from phase 2 studies. Phase 3 studies, only a few molecules are now entering phase 3. And none of these are those mega phase 3 studies that we have seen in NAFLD and HCV, where one large study of a few hundred, several hundred patients results in licensing. So I think these barriers need to be crossed before we can look at therapies that can be introduced in humans. But of the various technologies, at least the NAPs, the nucleoside nucleic acid polymers that inhibit the secretion inhibitors, have shown very promising results. And if they are borne out in larger phase 3 studies, they certainly will be game changers. But then, as I again pointed out, no one single molecule is going to do it. And presently, at least 2 to 3 different techniques and nucleoside analog inhibitors that we are using currently seem to be an integral part of most of these strategies. You add on siRNAs, NAPs, HAPs, and maybe immune modulation with pegylated interferon or other molecules to achieve all the various problems that you have in chronic hepatitis B, from poor innate immune response, poor adaptive immune response, T-cell exhaustion, and of course cccDNA and integrated DNA. So still a long road ahead, but there seems to be some light at the end of the tunnel.
Thank you, sir.
Thank you, Vivek. Masterpiece as always. 2 simple questions. What is the contribution of integrated versus cccDNA in the quantitative HbS-Ag we see in the blood?
Anil, I think there are now good data to show that in the E antigen negative chronic hepatitis B, the reactivation group that we see after with the E antigen seroconversion, most of the HbS-Ag is from integrated HBV DNA. It does not reflect the cccDNA burden. Whereas in the HbAg positive chronic hepatitis B group, most of the circulating HbS-Ag you have is from the cccDNA and its expression.
And
that seems to be the understanding.
I presume that cccDNA is a complete, integrated, robust component of the HBV DNA. Does it depend on the replenishment from the HbS-Ag,
Absolutely,
which is being generated during the replication?
That's, I think, insightful question, and that is very important. To perpetuate chronic hepatitis B, each time the virus replication cycle is completed in the hepatocyte, only a proportion of the virions are excreted into the circulation. A good proportion also go back into the nucleus and replenish the cccDNA pool. And at any given time, you can have as many as 10 to 40 active cccDNA mini chromosomes within each hepatocyte. So you can understand the burden of elimination of chronicity. And that is why actually eliminating cccDNA or preventing this replenishment by capsid inhibitors and by secretion inhibitors will play an important part in depleting the cccDNA pool. Also, the rate at which the hepatocytes are replicating has an effect on the cccDNA. And I think more recent studies have shown that it may be several weeks and months only, in which if you can arrest the cccDNA replenishment, we may be able to eliminate the cccDNA pool compared to previous studies which talked about years or lifelong therapy of inhibition being required before the cccDNA can be eliminated. So I think newer techniques will be promising.
Only if the replenishment is an integral component, will all these downstream pathways will be effective. Because if it keeps on producing its own machinery, and whatever you may do to the exit of the particle or
lack of
Absolutely.
encapsulation will not help.
Yeah. And so, I mean, the population that is going in to reinfect the nucleus, if you can decrease this population by the capsid inhibitors, by the and secretion inhibitors, which also have a role in cccDNA integration, then it looks promising that it can be happening. And eventually, probably the best way forward will be once the cccDNA silencing technologies using CRISPR-Cas9, the zinc finger nucleases, the talents and all, actually sees the light of day in humans. So it's being tried in various models.
And since you were not there, there was a talk by Mamun regarding the
Right.
nasal vaccine, NASVAC. So where does it fit into the algorithm change?
Well, I think the earlier, this is the one of the therapeutic DNA vaccine strategies that has been used. And at least the initial data for the NASVAC did look promising, but larger studies and from other centers have really not shown that NASVAC is living up to its potential. So what they need to do is to re-engineer NASVAC to include pre-S1 and core gene as well as maybe X gene elements. And then the attraction of NASVAC is its non-invasive delivery of vaccine through the nasal route rather than para and parenteral. So while this route does appear promising, probably kind of tweaking the components of the NASVAC may make it even more promising in future.
Thank you, sir. Thank you for such an exhaustive review of the literature as well as the current publications. Thank you very much.
Thank you. Thank you for this session. We're requesting you for a picture in the center of the stage. I would also like to invite Dr. Praveen Sharma, who will be giving the closing remarks for today.
Thank you, Dr. Saraswat sir, for his excellent talk. So as a concluding remark, I would like to thank all our speakers for their excellent talks, all our moderators and chairpersons for their interactive session during the sessions, all our delegates who have taken out their time from their busy schedule and come to us to join this academic feast. I would like to thank M.I.C.E team for their travel support, Pranav, our endoscopy staff, Ms. Prachi for taking out your time, and all the pharma people because without their support, I think any conference is not possible. We tried our level best to make out a program so that it can help all our students, our delegates, our day-to-day practitioners. But still there are certain issues which are beyond our reach, but we all welcome your suggestions so that we can incorporate all these suggestions so that the next time we can improve our academic event. So you can contact our Dr. Anil, Dr. Ashish or me for any particular suggestion in the next year conference. Thank you, everybody.
Thank you.